ಅಂತ ಕುಡಿಯಲ್ಲಿ
ಆಗಿದೆ ಸರ್,
ಇಲ್ಲಿ ಮಾಡಿಲ್ಲ.
ಇಲ್ಲಿಂದ ಆಗಿದೆ ನೋಡಿ. ತಾನೇ ಇಲ್ಲಿದು.
ಓಕೆ
ಮೇಡಮ್ ಫಸ್ಟ್ ಸೆಕ್ಷನ್ ಯಾರು ಮೇಡಮ್? ಶಾಂತರಾಮ್ ಬಲಿಗ.
ಡಾಕ್ಟರ್ ಬಾಲಿಗ.
Morning, sir.
ಏನಿದೆ ಪೆನ್ ಡ್ರೈವ್?
Good morning, Jagdish.
How are you, sir?
Good.
Morning,
ಪ್ರೆಸೆಂಟೇಷನ್
Ruchi, madam.
Yeah, good morning. Good morning.
I can start off. You can load that, please.
ಯಾ ಯಾ
But delete it after you finish.
ಓಕೆ
Please.
How was yesterday?
Mic. So do you in the caller mic or directly the podium or
Follow mic is better. Go walk around.
yes, caller mic or is it?
It ಕೊಡಿ ಇಲ್ಲದ್ರೆ ಪರವಾಗಿಲ್ಲ.
It's there, sir.
It's there.
Yes.
So which one, sir?
So which one?
There's only one. There's only one panel. That's it. Just in folders. Only one is on.
ಶೇರ್ ಅಂತ ಕೊಡ್ಬೇಕಲ್ಲ. ಇಲ್ಲಿ Zoom ಅಲ್ಲಿ ಶೇರ್ ಕೊಡಿ.
Get it. Please give me mic. Another people have it.
ಮೇಡಮ್ ನೋಡಿ ಮೇಡಮ್.
ಸರ್ಚ್ ಪೆನ್ ಡ್ರೈವ್.
Oh, so it's okay. We will start
ಒಂದು
one time.
ಸರ್ಚ್ ಪೆನ್ ಡ್ರೈವ್.
Source pen drive. Copy ಮಾಡಿದ್ರಾ?
ಹಾಗೆ
Listen, ನನ್ನ give it to sir. Jagdish Chinappa. Sir?
ಈಗ ಅವ್ರದ್ದೇನೋ ಮೇಡಮ್ ಅದು?
ಅಯ್ಯ
Yes, Ruchi Nanavati and Shantaram sir. Good morning, everyone. Good morning and welcome to National NeoCon 2021. Today is day one of the conference, and despite the trying times, we are all gathered here for a day full of knowledge by some very experienced neonatologists of our country. But before we go ahead, I would like to remind everyone to follow COVID protocols. Please maintain a safe distance, kindly wear masks at all times, and please use sanitizers. Mutual trust and relationship between doctors and patients is one of the most important factors of a treatment plan. Changing trends in medical fields does affect this relationship. So our very first panel discussion of the day focuses on this very subject, ethics in neonatology. This session is being moderated by Dr. Jagdish Chinappa. And sir is the cluster head pediatrics Manipal group of hospitals in Bangalore. He's a past president, respiratory chapter, Indian Academy of Pediatrics 2019-2021, consultant Child Central Bangalore, CEO. Sir, we welcome you on stage. And with that, we have our panelists.
ಕಲರ್ ಮೇಕೆ
Can I move from here?
Yes, sir, you can try.
Okay, that's good. I'll do the introductions for this one. We start. Good morning, everybody, and I thank the organizers for putting this as one of the first sessions, and I think this is a wonderful session which we're going to have for the next 45 minutes to 50 minutes. We have got 3 panelists who are going to be available physically and 2 who are going to be available virtually. So, Dr. Rekha, can you please come up to the podium? Architect. Dr. Saurav and Dr. Edwin both are there. Welcome, Dr. Swarna. Rekha Bhatt. So today, we're going to talk about ethics in neonatal practice. And what we plan to do in the next 45 minutes to 50 minutes is to brainstorm with our panelists And we have a very distinguished group of panelists. We have Dr. Saurabh Datta from the Postgraduate Institute of Medical Sciences at Chandigarh. We have Dr. Swarnarekha Bhatt, who was the ex-chief of neonatology at St. John's Medical College and is one of the most senior neonatologists in our part of the country. Dr. Ruchi Nanavati, who is the head of department of neonatology at the KEM Hospital, Mumbai. Dr. Edwin Dias at the Srinivas Institute of Medical Sciences, Bangalore. And Dr. Shantaram Baliga, who doesn't need introduction to any of the audience members here, from Bangalore, from the Lady Gershwin Hospital. And also he's been pioneering the community care of newborns in Karnataka. So the outline of this talk is going to be basically a brief introduction by me, and then there'll be 3 cases, 6 key questions which we will try to answer, and finally some take-home messages. So starting off with the domain map, actually what we need to do in neonatal ethics is to look at what is the map, what is the territory, and then what are the guideposts to this territory. So looking at the domain map, what is the territory? The main thing that we are all interested in, at whoever we are, is the best interest of the baby. And if you look at that, there are a number of things that come in. We have the neonate. Morning, sir. Morning, Dr. Edwin. Welcome. So, as I was saying, we are all interested only in the best interest of the child or the baby. And basically, we have the neonate, who is at the centerpiece of this. And we have neonates of different varieties. We have a preterm baby, a baby who is on the verge of viability. We have a baby who has had significant asphyxia, congenital malformations. We have a baby who has been abandoned. So we have a large number of variety in the neonates where ethical issues will come in. We have a care team which is going to vary across different centers. We have babies who are in tertiary care centers with every possible facility, and we also have newborns being taken care of at small places where the facility may not be as good. We have parents of different viewpoints, belief systems, family support systems. At least in India, we have an extended family. We have the legally authorized representative in case of abandoned babies. We have institutional policy which can vary from institution to institution. We have legal frameworks which are not very clear. We have social norms and religious beliefs which are going to influence the ethical practice. And all this is going to come into 3 main groups. How we practice clinically, how we look at the research aspects, and how we get into the public policy. Now, as you all know, the lighthouses are the principles of navigating this entire map are the principles. And the principles, as we all know, the prime principle in pediatrics, neonatology, and any child is basically beneficence. What are we doing to benefit the child? Then we have non-maleficence or do no harm. We have parental autonomy, which is a major issue. We have justice, especially in countries where there are going to be scarce resources. Justice is going to be 2 kinds. You're going to have retributive justice and you're going to have distributive justice. We'll not discuss too much about that. Veracity or truth telling. We need to be very clear that we are only disclosing the entire truth when we are talking to parents and even in our interactions on records, etc. Confidentiality. And in neonatology, this is even more important because this confidentiality breach can take place 18 years down the line when the child is an adult, and you may end up in problems there. Then I'm going to introduce 2 other concepts which are unique to neonatology. One is the concept of what is called as phronesis. What is phronesis? It's basically a Greek word for a type of wisdom or intelligence that is relevant to practical action. So this is a very important part because we are dealing in neonatology with a large number of things which are not clear. And this is one thing which we need to have. The other is episteme, or that is we need to understand the basics of what we are doing and why we are doing. And the reason for that again here is that we are going to be faced with new challenges. This map is not an old map. This map keeps changing. You're going to get suddenly COVID coming in. You have MISN. So therefore, you need to understand the basis. Excuse me, please keep quiet. Another is communication, because communication is a very important part which we're going to touch on. And of course, we also have to look at how the interaction is going to be between the healthcare system and the parent. So I think with this introduction to both the map of what we are going to look at, and two, what are the principles of ethics that we are going to look at, we'll now move on to the next case. And I think Dr. Datta is here. Welcome, Dr. Datta. Please join us. So we will start, since Dr. Datta is here, I'll give him a moment to breathe, because there has been quite a bit of traffic issues here. Dr. Datta, can we start? This is a 25 weeks baby who was antenatally diagnosed with Down syndrome. The parents have indicated that they do not want to raise the baby. The baby has been delivered normally and has a weak cry. Would you resuscitate and continue treatment, Dr. Datta? Yes, please. You can go ahead, sir.
Thank you. As we have heard, it's an antenatally diagnosed Down syndrome. We already knew before birth that this is Down syndrome. 25 weeks gestation, delivered normally as a weak cry. And the parents had indicated, they already indicated they did not want to raise the baby. So can I have the next?
Yes, sir. You can do it like just move that area.
I think it's already been discussed. The 4 key pillars of medical ethics are beneficence, that means the physician is supposed to act in the best interest of the patient. Non-maleficence, that means the physician weighs the benefits and harms of interventions and intervenes only if the benefits outweigh harms. Patient autonomy, in case of neonates, is basically parental autonomy. Given the special relationship of parents with their child, any parent of sound mind has the power to make rational decisions and moral choices for their child. That's an assumption. And justice, the 4th pillar, means to the extent possible, all patients in similar situations must be treated similarly. So let's look at this case. So what does the law or the Indian guidelines say about do not resuscitate at birth? Basically, that's the issue that we are debating over, whether we should resuscitate or not at birth. So the Indian law actually does not give any specific guidelines, but there is an Indian Academy of Pediatrics consensus statement, which was published in the year 2017, and the panel included neonatologists. So there is a neonatal component to it. This consensus statement is worth reading. So they say that do not resuscitate at birth is justifiable under one of the following situations. First, if there is a congenital anomaly incompatible with life, but Down syndrome does not fall in this category, we know that. Secondly, a congenital anomaly likely incompatible with life, expected quality of life, likely compatible with life, but expected quality of life very poor, or is going to be a huge drain on the resources of family and society. And generally speaking, Down syndrome is again not considered to be in this category. Third is the birth weight and gestation is such that intact survival is almost impossible. So the IAP consensus statement interestingly gives broad guidelines for this. They say that for tertiary care centers, 23 6/7 weeks gestation and below need not be resuscitated. So if I'm looking at this personally, in my center, this baby would not fall in this category. So 25 weeks gestation. And non-tertiary care centers, the guidance is that 27 weeks or below, and if in utero transport to a tertiary care center not possible, then it need not be resuscitated. So this is not really personally applicable to me, but it could be applicable in other places. So this is again part of the consensus statement. If there was no opportunity for discussion and decision making with the parents prior to birth, the baby should be fully resuscitated, except in the case of an obvious gross anomaly incompatible with life, example, anencephaly. So that means if there was no opportunity to take a decision before birth, you have to have a pro-life attitude, that means resuscitate and then make decisions later on. So what are the ethical issues in this case? Most commonly, areas of conflict are where beneficence and autonomy collide. That means the parents want, say, not resuscitate, but the physician thinks that from the point of view of beneficence, the baby should be resuscitated. On the face of it, this case appears to be a conflict between beneficence, because the physician, if you go strictly by the guidelines, has no reason not to resuscitate this baby, and parental autonomy, where the parents are saying that they do not want to raise this baby. But is it really so? If you look at it a little more critically, so the crucial element here, sorry, this pointer is it? Crucial element here is parents indicating beforehand
not give any further. Your slides are there.
Yeah, I got the slides.
Can you
But
go ahead?
before, Saurabh, thank you so much for making it very clear as to how we go about taking a decision. Before I start off with this case, with your permission, Dr. Jagdish, I think currently we need to be extremely careful about what kind of decisions we take, particularly in neonates. The first thought that came to my mind when I was told I was in this panel was the paper report of this 20-year-old girl with spina bifida, who I think sued her mother's obstetrician because the mother's obstetrician did not give folic acid to the mother, perinatal folic acid, and therefore she had spina bifida. So the message I'm trying to say is that whatever decision we take not only has an immediate implication, but it has a long-term implication. I would have been happy and I wouldn't have had to answer this question if Saurabh had said, I'm not resuscitating the baby. But since with his beautiful analysis, we have resuscitated this baby, I would look into three aspects taking the decision. One is the prognosis for the baby, immediate and long-term, in the unit and situation is being treated, which was brought out by Saurabh in terms of a tertiary and a non-tertiary center. The parents' understanding of the situation and their wish, which again was beautifully brought out by Dr. Saurabh, not just raising the baby, but quality of life of the baby and things like that. And my duty as a doctor, that is the simplest decision to take. And of course, the principles of beneficence and non-maleficence, which has been brought about. So, next slide. My approach would be, if a simplistic approach, which I think we all hope for, keeping in mind my duty as a doctor, I would continue the treatment and ventilate the baby the way we need to do. But if we need to respect the parental autonomy, and if by now, by 6 hours, we have actually discussed all the issues with the parents, and they still feel considering immediate and long-term outcome, the parents feel, I do not want to continue treatment, I think we need to respect that and give comfort care to this baby. Considering the prognosis, which comes into the theory of consequentialism, I have a choice of treating the baby versus giving comfort care. And here, even though I have put CPAP versus invasive ventilation, when we decide to treat the baby, it should not be half-hearted. If we decide to treat the baby with all the reasons and things like that, it has to be a full treatment. So if this baby requires a CPAP, we need to put the baby on CPAP. If the baby requires a ventilator, we would need to put the baby on ventilator. If the baby has any other major cardiac problems, life-threatening cardiac problems, not a simple VSD or something like that, I would hesitate to be aggressive. So, but the ultimate decision has to be a shared decision. And I think that's exactly what Saurabh also brought about. We need to have a framework that we need to talk to the parents honestly and non-judgmentally as to what is the situation, what is the long-term situation. And we need to take their wish in mind before we put this baby through a long-term, the family, the baby through a long-term problems of quality of life, etc. So what I would do is I would discuss with the parents and explain to them if this baby has got a mild RDS and requires only CPAP, it may come out of it. But if this baby has got severe RDS, requires surfactant, invasive ventilation, obviously the prognosis of this baby is going to worsen. Make them understand and then take a call whether to ventilate this baby or not. And personally, in my heart, I would say, I hope this baby needs only a CPAP. I hope this baby does not have any major cardiac problem. And I would be happy if we can just manage this baby with CPAP.
Thank you, Dr. Rekha. That was a wonderful. Can you just wait, please? Just hold on. So I think that was a very, very excellent analysis of it. And this brings about one very interesting concept in ethics, and that's called the equipoise. If you notice in this child, You could do either way and still be right. You may choose not to do anything, and you may choose to do CPAP as what Dr. Rekha mentioned. Both ways you're right or wrong. There is no clear answer to this. And this highlights one of the issues in ethics, and that is there is no black and white here. Because if you're black and white, then you are on legal terms. If you're doing something in between, in the shade of gray, that means you are on equipoise here. And it will depend on a number of factors. And the factors are in which place you are, what is the societal issues here, how does the family look at it, how does the parents look at it, whether they can continue, whether there is a child welfare committee which can give you a decision in the right time. So there are many things which are not very clear. So I think the important thing here is to realize that there is no wrong thing here. Either way you will be right depending on the family decision. So I think we need to move ahead now. Can we move ahead further? Okay, now 48 hours later, this child improves as far as his respiratory condition is concerned, but lands up with intestinal obstruction, and the surgeons have advised a laparotomy. So, Dr. Ruchi, what would you do here? Will you go ahead with the laparotomy, or will you just continue with comfort care with this child?
Yeah.
Dr. Ruchi,
Yeah, am I audible?
yes, ma'am.
Yeah, at the outset, I would like to say that I missed most of the part which Saurabh has said because there was no audio. So I don't know, there is going to be some repetition, but I think we discussed the issue of beneficence, this thing, but what is more important in this case, the next slide, that we have to discuss about non-maleficence. And that is, as we know, that it is, not harming or inflicting any harm to the baby, or do least possible what is harmful to the child. But as we know that ethics are not easy. As a doctor, when we are treating the baby, we are always thinking, can we do more? But when you think from the ethics point of view, our question is, should we do more? And we require to answer these questions, that should we do more? And this is told to us, in the way back, the cases like baby John Doe, where, whether ethically we should be doing more for the baby. Now, when the harm is more than expected benefit, is it ethically right to go ahead with the treatment only because it is described in the literature? And there are still dilemmas in this, and the answers are not easy. The treatment may be futile, and prolonging treatment would be considered as a violation of this ethical principle of non-maleficence. And sometimes death might be a better option over life, in the life which is full of intense suffering for the neonate and the family. So one requires to look into this also. Now, when we are looking at a peri-viable neonate, which is going to be different for different institutions depending upon the care which is available, every procedure and treatment is associated with pain and discomfort. So do we, not need, that doesn't mean that we should not do them, but you require to take a, sort of an informed decision in consultation with the family. Now, this baby is a 25-weeker. The baby has a Down syndrome, has intestinal obstruction. Would subjecting this baby for a major surgical procedure, which is it ethically acceptable, knowing the risk of complications and which are associated with the surgery and associated with anesthesia? So these answers to these questions are not easy. The next slide. And that's why there are, what we described as a gray zone. So when we are talking about the treatment, there is, below this gray zone, this point, that there is an increasing certainty that the treatment is not going to be in the best interest of the child. So you are certain when we go, look at the below this particular lower line of gray zone, while this above line, that there is increased certainty that treatment is in the best interest of the baby and it has to be provided. So this is an upper threshold, this is a lower threshold, and this is a gray zone. And the different countries have different guidelines, as Saurabh has said and Swarnarekha has said, regarding the resuscitation when you are talking about gray zone, and we yet don't have these guidelines. The next. Now, most of the times, when we are talking about these guidelines, you have the physician's assessment of the treatment, whether parents prefer to accept this treatment and whether parents prefer not to accept the treatment but forego the treatment. And this was described in the President's Commission report way back in 1983. So the basic is, if there are, the physician's assessment is that this is going to be clearly beneficial to the infant, one goes ahead with the treatment. But when it is ambiguous, or the physician feels that the treatment is going to be futile, one has to go as per the parents' thing. If the parents prefer to accept the treatment, you provide the treatment. If the parents don't want to give the treatment, one should withhold and withdraw the treatment. That means you give a comfort care or a palliative care. And then when the physician's assessment that the treatment is going to be futile, depending upon the parent choice, you decide what to do. So provide the treatment unless provider declines to do so. And in this case, you might require a second opinion. And at times you might have to go ahead with the legal opinion also. And the same thing when the parents decide not to go ahead with the treatment. The next line. There is also the guidelines, which is, the prognosis, which is prognosis-based gray zone. So there is a gray zone. So people have also looked at the prognosis. And for prognosis, they have given an estimated chance of poor outcome if the intensive care treatment is provided. And what have they considered as an outcome is that the death or a profound disability, which is taken as a poor outcome. So if the estimated chance of poor outcome is less than 50%, and the prognosis, this is the prognosis for the equivalent gestational age infant, which is more than 25 weeks. If the prognosis is less than, for the poor outcome is less than 50%, one should go ahead. The life-sustaining treatment should usually be provided. That is as far as the treatment category is concerned. If the prognosis is going to be, in the range of poor outcome between 50 to 90%, and you are looking at this gestational age, it is optional whether life-sustaining treatment should be guided by the parents' wishes. And when the prognosis is more than 90%, that it is not going, it's going to be poor, and the gestational age of the baby is also, between 20 to 22 weeks, then it is not reasonable to provide life-sustaining treatment. So there are different views which are available in the literature. One is whether it is a prognosis-based guidelines, whether it is gestational age-based guidelines, and the next, and as all of us have experienced, there are a lot of, the next slide, there are a lot of other factors like IVH, PVL, NEC, which will, drastically change the prognosis. So the most important point is that the risk assessment is an ongoing process. You cannot take the decisions before the birth of the baby entirely. Neither you can take all the decisions in the delivery room. So it goes on over the days, over the weeks, and the things will actually unfold. So this is, whatever as far as this baby is concerned. And again, there are issues that everything is based on gestational age, but is the gestational age assessment is very accurate? And we know that the gestational age assessment is not accurate. I think we will be discussing it afterwards. So depending upon that, this is again an ethical dilemma, whether this baby, whether we should subject this baby to laparotomy or we don't subject this baby to laparotomy. I think this requires to be discussed with all the merits and demerits with the parents. And then one should come to a common shared decision. And if required, one can even take the help of the other person if there is any difference of opinion to go ahead further in this case. Yeah, over. Thank you.
Thank you, Dr. Ruchi. I think she brought about basically three main themes which in her presentation. I think the first theme is that it's a complex decision-making process. It's not easy. It's not one-to-one. The second thing which she mentioned is regarding the moving target. I mean, the child, what you see on day one may have a different ethical issue compared to what you see after another couple of days. And the third thing she brought about very beautifully is that while the first two speakers looked at the predominantly autonomy and beneficence, she looked at non-maleficence, saying that if you continue doing some treatment, you're actually harming the baby. And sometimes it may be very important to distinguish between prolonging life and prolonging dying. So I think that important thing is to see when to move from active treatment to comfort care. I think those are some of the major issues that she brought about. Thank you, ma'am. And can we move to the next slide, please? Okay. Now, during counseling, you realize that the parents are school teachers out of a job and financially distressed. They don't have insurance. This is a second girl. Will that make any difference to your decision making, Dr. Maliga?
Hello?
Yes, sir. We can hear you, sir.
Yeah. Decision making should not be influenced
Go to the
by
next slide.
the economic issues involved. So where the right to live of the neonate should be respected. So there's a role for the doctors to be responsive to guide the parents on how to organize the funds for the treatment of the baby. So there are various options available. Firstly, there is a Supreme Court judgment which says you can take care of the treatment, whatever is required, and then claim it from the government for after the treatment is completed. This is one option. Then the other options are to arrange for a philanthropic support, or there are various government programs available. Ayushman Bharat or the state governments have various programs. If none of these are available, then probably now the facilities in the public health sector for neonatal care has improved. The baby need to be transferred to an appropriate public health facility.
Go to the next slide.
Over to you.
Thank you, sir. Thank you. I think the important thing that Dr. Baliga has brought about is the fourth concept, and that is justice. I think every child has to be given his due, and if the facilities are not available, and you can look at alternatives either in terms of funding or in terms of facility. So those 2 points were brought about beautifully. Can we go to the next slide, please? The key learning points was there's some conflict between beneficence and parental authority or autonomy. We need to look at non-beneficence and justice too. Limits of viability, unfortunately, we don't have too much of data from our country. We know that it's a moving target, and there are no absolutes in ethics. There is some degree of what is called as. Now we come to Dr. Edwin, and so Dr. Edwin, here you have the exact reverse here. You have a 33-year-old priming, conceives after IVF. It's a very precious baby. The baby develops, the mother develops COVID and delivers a severely asphyxiated preterm baby who needs prolonged ventilation. The baby develops asphyxia-related severe brain damage and an intraventricular bleed. The baby is detected with hydrocephalus on follow-up. She also has spasticity, seizures, and blindness and significant hearing loss. Parents want everything done, including shunting. So, how do you determine futility, best interest, parental autonomy here?
Thank you very much for keeping me on this panel. So, exactly, I don't know how you got that first case. It is exactly a case which I treated. And exactly, we had the same, we had to admit this baby several times. So we had, but COVID was not there. But it is well known that now COVID is not a problem with the babies. There have not been shown if there are proper facilities, usually baby does not contract COVID. So I think that is really not an issue at the present level of technological advance. So can I get the slide?
Yeah, please go ahead.
So we saved that baby, and exactly what happened is the child developed hydrocephalus and also developed the spasticity as well as the blindness. The child had developed hydrocephalus, and you can see spasticity. Seizures were also there. And the parent was very aggressive on, they had the only child, and they were very aggressive on getting the child saved at any cost. In fact, those days, that was very long ago, the bill was very, very high at that time of life. But still they continued the situation as after we told them about the prognosis, they said nothing doing, we want the baby. So yeah, what happens is you can see that the child has been definitely saved. The right to life was what was told by Dr. Shantaram. And it, due to the parental autonomy and not in the best interest of the child. if we say the action plan was there by the hospital ethics committee and we have a sort of a plan, then of course we know that as pediatricians and neonatologists, we know it's not in the best interest of the child, and the family will have to go through a lot of pain. So the treatment has been futile in the sense that survival has occurred. So if the parent wanted a baby, a live baby, yes, that has been done. But there are many complications. So the question, the conflict comes, is severe handicap, can it consider be worse than death? This is some of the things which have been discussed by certain ethical authorities. So we want to know whether it can be considered. But at the present time, in the technology which is daily occurring, I think the next few years we may get a lot of things that may help in the technological treatment of these babies. So I, for one, say, okay, we'll take a chance and hope that technology advances tomorrow may help the parent and the child to do well. In fact, one of the things I think during Vajpayee government, one of the cerebral palsy children he got a job and he was given an award. So I think that time with that cerebral palsy, when we were previously last decade said cerebral palsy not worth saving the babies if they have severe. In fact, at the same time we had this child, we had another child very well off, had a preterm baby, same age, but had asphyxia, but the parents were very clear that the baby should not live. So we didn't continue the treatment. The child succumbed because of CLIP. So you can see the two different, as from a resource, in a resource full, wherever the resources are very good, even there are two scenarios. Where one, the parental autonomy says they want the child to live. There's another parental autonomy decision that they do not want. So the present technological treatment of hydrocephalus, of course, is easy now because of all the neurosurgical interventions, and but it will add to the further disabilities of financial pain of this parent. So burdens are many. Only benefit is that they have a child survival, principles of beneficence. And many doctors take the view that if parents wish to intensive care to continue, the appropriate response is to carry on invasive therapy, at least in the short term. And that is parental autonomy versus medical autonomy. So I think in this case, we did that. And also there is no time for decision making. Because the time gap with the child, as you said, the moving target. So what happens next, we do not know. So at this present time, if the parent definitely wants the baby, we carry on.
Thank you, Edwin. I think again, three principles here, which have come out very nicely from your discussion. One is, in the first case, we saw that we were looking at how parental autonomy is secondary to the child's beneficence. And in the second case here, we now see how parental autonomy is actually the most important thing here. Because it's the parents who are going to pay for the child and take care of the child. And their autonomy probably trumps the beneficence that's going to happen from the medical intervention. So that's one point. The second point is the very curious thing that all physicians and neonatologists will have their own ethical beliefs and their own knowledge base and their own experience. And again, advising in this situation is going to be biased on what the physician knows and what he is going to take action on. The third thing is on, again, you brought up very nicely, is it has to be individualized depending on what facility the parents can afford and what facility you can give. Because this child could have been very differently treated in a tertiary care center versus a small place where there is not too many facilities available. So there are a lot of complex issues involved in the decision making. And as again we said, is that ethics is not easy. You will have to take a lot of parameters. So we'll move to the next case. Thank you.
5 more minutes.
5 minutes? No, we have got another 15 minutes. We started 10 minutes. Start. Next. Okay, go to the next slide, please. So we'll go to the next one. We have discussed this. Next slide. Yes, madam. Dr. Rekha, Dr. S, a senior consultant in neonatology, prescribes gentamicin in an inappropriately high dose. which nurse Sara administers. The neonate has a renal failure that increases the duration and hospitalization and distress. Sara realizes her mistake in following the doctor's orders. She is depressed and wants to quit. Should she quit? Who should she alert? Are there mechanisms to handle moral distress in the neonatal? Go to the next slide.
Yeah. No, just leave that slide for a minute, please. Yeah. The first, the answer to the first question is very clear. Should she quit? No. Who should she alert? She has to alert somebody, obviously. And in the current situation, in the current scenario, in most of the places, whom she will be alerting is her chief of nurses in the NICU, who will then tell the nursing superintendent, and then they'll have a discussion about this. So she has to alert somebody. Before going on to the third question, I just want to discuss what do we mean actually by moral distress. Moral distress, initially the terminology came basically pertaining to nurses who need to do things against their ethical principles or who are obliged to do things against their medical principles. But I think in a broader term, it means that any one of us who are compelled to do something against our principles. Like in the previous two cases, if my principle is only to save the baby and I need to not resuscitate the baby, it causes moral distress in me. So that is the initial thing that I needed to mention, because this is something not usually talked about, and therefore I thought it's important for us to discuss what exactly is moral distress. Go ahead. Next slide. Yeah. So currently the mechanism is informal. And I think with the situation getting more and more complex, I'm not saying difficult, but more and more complex, we certainly need to have some kind of a backup formal committee, formal team who will take care of this. I think there should be a team to address such issues and a mechanism to provide psychological support without being victimized. Most often what happens to a nurse, all of us have gone through this, if she breaks a syringe, she has to pay for it. If she does a mistake, whether it is hers or somebody else's, she resigns, etc., etc. And we can't be judgmental about this. So we need to have a team which would include a nursing superintendent, the nurse in charge, the HOD of the specific unit, one or two senior, unbiased senior faculty, both from the nursing side and medical side, psychologist counselor, who is there as a backup when decisions can't be sorted out at the level of the unit. I don't think it is necessary that every moral distress situation should go to this group, but there should be a backup. And just digressing a little bit, even for ethical decisions, I think ethical decisions will be done by the treating team, but sometimes it gets a little more difficult, and there should be a clinical ethical committee. I don't think the research ethical committee is trained to take care of this. So you need to have a clinical ethical committee whom we can approach. This one last thing in this particular case, can you go back to the previous slide, please?
Previous slide, please.
Here, if you look at it, the mistake is the doctor's. But the only way to prevent some problem like this is to give more autonomy to the nurses when they can, or more education, more knowledge, more training to them, so that they can recognize that this is a wrong prescription and correct it. So I think that's something very important. Thank you so much.
Thank you, Dr. Rekha. I think you brought out very important points. I would even go to an extent to call this workplace distress, because it may not be only nurse distress, but anybody else too. And of course, there's also a problem of power relationship, because the doctor is probably on a higher pedestal compared to the nurse, and the nurse doesn't want to complain against the doctor. So those power relationships are again things which we probably need to explore. Okay, now what we're going to do in the next 5 minutes, because I think they are getting a little impatient, the organizers. So what we will do is run through the questions. And I would request the panelists to just briefly answer them so that we don't go too much into detail. So let's go to the next slide, please. So learning points, yeah, okay. Next. Dr. Datta. Can you briefly say what are the steps we need to follow in an ethical dilemma or conflict? Can we have, is there any structure? Let's say there's an ethical conflict of beneficence versus autonomy. Is there any structure by which we can resolve these conflicts?
Yes, I mean, there are certain informal, again, guidelines. So the general dictum is try to minimize the potential for conflict when you have the opportunity, and to resolve issues when the conflict has already become intractable. Next. So these are the steps that have to be taken when you think trouble seems to be brewing, rather than doing firefighting. So one very important thing is ensure that there's only one person in the team counseling the family on issues, and that the team is not talking at cross purposes. This is one of the biggest problems that happens in most community events. Somebody makes a loose comment about prognosis, parents latch onto it, and that creates conflict between the team. Second, ensure parents have fully comprehended the information provided. Sometimes assume that what we have said, they have comprehended, but I mean 90% of the time actually they do not comprehend. And you need to keep repeating the same thing again and again, and not make comments like, oh, I've already told you 3 times before, you should have understood it by now. Parents take time to absorb things. And you can use creative means to promote understanding, such as making diagrams and showing images and so on. Next. If you are at a crossroads, seek time for further clinical observation before you attempt a consensus on critical decisions. I think you're okay. Just seek a little more time. And continue discussions, and you can even defer decisions on conflicts to say the next meeting. Next. Don't gloss over the ethical issues in the conflict. Be transparent and open and tell the families, look, here is where we are having a conflict. This is my view, this is your view. And be open about it. And explore complex cultural and socioeconomic issues underlying the decision. True of all societies, all cultures, but particularly so in India, where mother side family, father side family, in-laws pressure, societal pressures play a huge role in decision. And at the same time, re-emphasize the preferred consensual nature of shared decision-making process and the shared burden of this. Next. Try to remove artificial system-imposed obstacles, which again are a very common practical problem. Frequent changes of physicians because the roster now, a new physician has come in place. And recognize the failure of any particular physician, who's having a particularly difficult relationship with the family. And maybe some other physician can come in place. And recognize whether it's becoming an ego issue between the physician and parents. Next. Explore the degree of disagreement between the parents themselves. Quite often, father and mother have different opinions. Expand the moral community by including additional significant family members, religious or spiritual members who can help the decision-making process. Next. And when parents say do everything possible and you disagree, find out what do everything possible really means and address the issues one by one. And I'm listing them here. I'm not going to read them all out. Sometimes when a parent says do everything possible, you don't just take it at face value, probe a little deeper. And if the differences are intractable, consider transferring to another physician. And if the conflicts are still unresolved, as a very last option, consider institutional or legal advice. Having said that, once you do that, effectively the parent-physician relationship is broken when you start taking things like institutional advice and legal advice. Then it becomes a battle. That should be the absolute last resort for solving that.
Thank you, Dr. Datta. I think very, very important checklist. I think this should be created as a checklist and circulated to everybody, because I think these are very important points, and very, very often we forget many of these and then land up in soup later on. So let's move on quickly. Dr. Rekha, what training should residents and trainees undergo in neonatal ethics?
Yeah, I think the answer to that is very simple and is going to be very quick. Should be incorporated in all courses, MBBS onwards, nursing training, etc., etc. Specifically talking for neonatal trainees should be included in the curriculum with specific time allocation. Could be in the form of lectures, seminars. Modular or online training for longer duration courses, I think, is the way to go. And I believe IAP is coming out with something like that. But more important, that is the formal kind of training, but more important, I think it should be discussed on rounds. And residents should be encouraged to make case presentations to discuss only the ethical issues. And the most important is there should be an assessment. whatever way. We're not going to go into how we're going to do the assessment. But if we can assess our residents and graduates on this, I think everything will be taken seriously. Thank you.
Thank you, Dr. Rekha. I think very nice about that. Quickly, let's go into the, can we have a uniform ethical policy? For example, we have different units with different kind of policies. Is there something that is constant, which is non-negotiable, and something that is negotiable, which you can put into a policy? Dr. Nanavati?
Yeah. May I have the slide? See, as you have said, that there are different types of units across the country. So it may not be possible to have a uniform policy. But I think what is first step and the need of the time is to have an institutional bioethics unit. And that unit should have data at least for your institution. So I should be aware of what is, say, an outcome for a particular condition in pediatric surgery, or when I'm dealing with complex congenital heart disease, I should be aware that what is the outcome of that particular, disease in at least in my unit, and that will help you to take the decision. One has to basically understand the all basic 4 principles and their application in NICU setting. We should survey our own ethical beliefs of our healthcare unit, and you should use this information as a basis for discussion in your ethical decision-making process. Whenever you come across an ethical issue, it is very important that we have debriefing session. We are aware of debriefing session in neonatal resuscitation, but we should consider when you come across an ethical issue, subsequently following that case or whenever feasible, we should have a debriefing session and try to understand more and more about ethical dilemmas and how do we solve them in your given setup. The next slide. It is also, next slide. It is also important to understand and respect the cultural differences in ethical beliefs and values, and one should not be rigid because this is very important and it also has a human right issue. You have to comply with the legal standards for ethical care, which are, we have certain legal standards, but on many of the issues, the legal standards you don't have. You have to adopt a family-centered approach to the ethical decision-making. And another important thing is that you should consider the regular use of ethics committee comprised of all stakeholders, including the family representatives. So, this is what we require currently to go ahead with ethical policy. And the subsequent question was, are there something negotiable and non-negotiable issues? I don't think, there are definitely said which are negotiable issues and non-negotiable issues. It is not there, and it is going to change from case to case basis, and even in a case to case basis from time to time. So I think it's a dynamic process. It's not very rigid that you can take decision at a time, and then it has to evolve as the case evolves. So yeah, that is what I feel as far as this issue is concerned. Over.
I think we can spend an entire session on this, but I think we should move ahead now. Dr. Baliga,
Yep.
we have already addressed this to some extent. So I think, is there a case for an ethical clinical consult or an ethical grand rounds?
Yeah, because coming to ethical conflicts, it's a varied etiology because dependent patient, uncertain outcome, potential trauma, prolonged support, lack of established guidelines, especially in gray areas, increasing costs, and the emotional issues among not only the family, but also the doctors, the neonatologists. Most of us learn by self-realization, and then some institutions would have policies and guidelines, or there would be some external evaluation and inputs. So since it's a complex process, one may not get a clear picture about the conflict. So there is a big role for conflict clinical ethics consultation. So it's an advisory service designated to assist parents, families, and health professionals. And it helps in identifying, analyzing, resolving ethical dilemma and issues. And it's a specialized field, and there is a need for experienced input and also the external audit be impartial. So this is different from the Research Ethics Committee, and it has a good scope for Clinical Ethics Committee, which could be for the institution, for the hospital, and it is different from research bioethics. Now, coming to ethical grand rounds is carried out by these clinical ethics committee or clinical ethics consultants. And there's a need for formal education, and they should carry out or formulate policies for the hospitals and for the institutions. There is a need for case reviews. Ethical grand rounds are monthly programs which are practiced in the West and is conducted by clinical ethics committee to discuss policies and principles of ethical practice. And they give what is called as EGR credit points, ethical grand round credit points. I think that concept needs to be incorporated in our system. Over to you, Jagdish.
Thank you, sir. Thank you so much for being very clear about that. Now let's move to Dr.
Please, we need to wind up.
Yeah, we are finishing now. We have finished just last 2 slides on. So regarding research, quickly, Dr. Edwin, can you just
next slide, just push the slide. Yeah, newborns cannot be given consent informed. So assent is there between 7 to 11 years, and I think the Indian legal says only 13 years. So and full consent can be given only after 18 years. So neonates represent the most vulnerable group. Study protocols must weigh the potential long-term effects of interventions, including development effects, and then research can be conducted. Obtaining parental permission is a complex issue with positive evidence describing the feasibility of informed and voluntary consent and under conditions of duress and a short therapeutic window. As you said, moving target. So validity of informed parental consent and modes of consent process in newborns are very difficult. So that will be an important thing in newborn research. But newborns should not be neglected as because drugs and maybe different effects in newborns. So they should not be research should be conducted. Mother and fetus or neonate are participants, and thus in both fetal and neonatal interest and maternal interest are in question. Perinatal consent may be required. Call for pragmatic randomized clinical trials. That is, where the risk and research risks are very less, may differ from traditional RCTs, and this can be reduced by modification in study design, modification of research design, consent procedure, or regulations for research oversight. Of course, legal framework should be made as the principles of equipoise, which you told, new treatment for critically ill neonates, which may save, and there are a lot of articles on enzyme treatment for the other babies. Presumed consent in emergency neonatal research, current concerns about neonatal research, the lack of adequate licensing of drugs used in neonate, and the need to evaluate emergency treatment such as neuroprotection in asphyxiated neonates is futuristic. And you can see a lot of equipment already shown in our conference. Waived consent has also been used in neonatal trials where the interventions in study are deemed to be minimal risk and obtaining antenatal content prior to the intervention, which is not practical or possible. So in short, this is the, there are futuristic.
Yeah, I think, thank you very much. I think the key thing in neonatal research is to estimate risk. And I think that is the most important part of neonatal research, because the risk could be immediate or it could be long term. So I will just ask Dr. Datta just one sentence only on counseling, because we are running short of time and I think we should close. Yeah, we can skip it after that, because it's a very exhaustive presentation. So we'll move ahead. Go ahead. And I think that should be the last. But I think this is one of the, we just will not go into this now. NNF policy, we'll just go through basically 3 things. We need clinical ethics committees, we need advocacy to enact laws based on policies, and finally, certain gray areas need to be addressed. This is probably the NNF role which they need to take in account. So I think take home messages, we have already gone through all of them. So we will stop here. Thank you very much. Any questions? Maybe 1 or 2 questions. Is there anything? Any on the chat box or anything of the sort? If there is nothing, then we can.
Thank you so much, sir. Thank you everyone for being a part of this panel and clarifying so many ethical dilemmas for us. As we're running tight on schedule, we move on to our next talk. So kindly appreciate Kindly accept a small token of appreciation, sir.
ಇವತ್ತಿನ ಡೇಟ್ ಆಗಿದೆ. ಇದೆಯಲ್ಲ ಮಾತ್ರ ಇದು
Thank you.
All 3 days. Oh. Next ಯಾವ್ದು?
Next.
Clicker. Clicker.
Thank you. Nice reading.
ಯಾವುದು? ಇದು ಓಪನ್ ಮಾಡಿ.
Oh, nice. Yes.
Good morning, one and all. We know India's first and only human milk fortifier, which is made from 100% human milk, is Neolacta. Let's hear more about the spoon for babies from Dr. Vikram Reddy. He's a chief scientific officer with 8 years of experience in medical research and clinical applications, 12 publications, 8 conference presentations, and 5 international multi-center clinical trials. Please welcome him on stage.
ಇದೆ ಮೇಡಮ್, ಇದೆ ಆಗುತ್ತೆ ಮೇಡಮ್. ಅಲ್ಲಿ ನಿಂತ್ಕೊಂಡ್ರೆ ಆಗಲ್ಲ, ಈ ಕಡೆ ಬಂದ್ರು ಆಗುತ್ತೆ.
Sir, would you like a collar mic or do you want to?
ಮುಗಿತಾ ಇದು?
ಮುಗಿತಾ.
ಏನ್ ಮಾಡಿದ್ರಿ ಇಲ್ಲಿ?
ಇದು ನಾನು ಓಪನ್ ಮಾಡಿ ಇಟ್ಟಿದ್ದೀನಿ ನೋಡಮ್ಮ. ಇದ್ರಲ್ಲಿ ಓಪನ್ ಮಾಡಿ
ಶೇರ್ ಮಾಡಿರೋದು ಯಾರದು?
ಶೇರ್ ಇನ್ನೂ ಯಾವ್ದು ಆಗಿಲ್ಲ, ಫ್ರೀಸ್ ಆಗಿದೆ. ಒಂದ್ ಸೆಕೆಂಡ್, ಫ್ರೀಸ್ ಆಗಿದೆ. ಇದು ಓಪನ್ ಮಾಡು ಒಂದ್ ಸೆಕೆಂಡ್. ಹೌದೌದು.
ಯಾವುದು ಸರ್ ಇದು?
ನಾನು ಓಪನ್ ಮಾಡಿದ್ದಲ್ಲ.
ಮಣಿಕಂಠೇನ?
ಇದೆ ಇದೇನೆ
ವಿಕ್ರಮ.
ಅಷ್ಟು ಕ್ಲೋಸ್ ಮಾಡಿ.
ಟ್ಯಾಂಕ್ ಬರ್ತೈತೆ ಇದು. ಇದೆಲ್ಲ
ಇದು ಕ್ಲೋಸ್ ಮಾಡಪ್ಪ. ಇದು
ಕ್ಲೋಸ್ ಆಗಿದೆ.
ಕ್ಲೋಸ್ ಆಗಿದೆ.
ಇದೇನಾ?
ಇದೇನೆ.
ಇಲ್ಲಿ ಶೇರ್ ಮಾಡ್ಬೇಕು.
ಅಲ್ಲಿ ಶೇರ್ ಮಾಡು. ಓಪನ್ ಮಾಡಿಲ್ಲ. ಪಿಪಿಟಿ ಓಪನ್.
ವಿಕ್ರಮ್
ಕೊಟ್ರ ಮೈಕ್ ಕೊಡೋಣ.
ಮೈಕಲ್ಲಿ ಸ್ವಿಚ್ ಆನ್ ಮಾಡಿ.
Good morning, one and all. I'm Dr. Vikram Reddy, Chief Scientific Officer, CSO from Neolacta Life Sciences. I would like to thank NNF and also the Neocon organizers for giving us this opportunity to present about human milk derived fortifier and its benefits. If you would like to look at the current available fortifiers in India, so these are the different options which we have. So there are 2 brands of bovine milk derived fortifiers, and there is one brand of human milk derived fortifier, which is available in India, which is Neolacta MMF Plus. So among the fortifiers, we have 2 categories, that is a bovine derived and also the human milk derived, the only human milk derived fortifier which is available in India. And if we would like to look at the WHO guidance for 2011 for optimal feeding of low birth weight infants. So WHO guidance for 2011 clearly mentions that VLBW infants who fail to gain weight despite adequately breastfeeding. So these are the infants who require human milk fortification. And these human milk fortifiers should be preferably of human milk based or human milk derived. So with this WHO guidelines, I think this also urges us to implement and continue the exclusive human milk diet or EHMD diet in the NICU through human milk derived fortifiers. So if you want to compare the key elements or key differences between these two categories of fortifiers which are available, that is a human milk derived versus human milk derived. So let's look at the macronutrient and micronutrients differences between these fortifiers. So in the first column, we have the bovine milk derived fortifier, that is HNF, and in the second column, we have the Inalactic MF+, which is a human milk derived fortifier. So if we compare the macronutrients, that is proteins, which is 0.27 and 0.27 as well in MF+, the main difference is these proteins which are available in bovine milk derived fortifier is sourced from bovine milk, and from MMF+ it is sourced from human milk explicitly. And if we can look at the fat, which is more in the MMF+, so that is one of the other reasons that MMF+ is having lesser osmolality, because recent scientific studies also say that if a fortifier has more fat and less carbohydrates, so that will reduce the osmolality as together. So that's why the MMF+ also has lesser osmolality, that is less than 400 osmoles per kg. So among the other important elements where there is a clear-cut differentiation, which is unique for human milk-derived fortifiers, which we can see here, there is presence of immunoglobulins or retention of immunoglobulins. First is IgA, and next is secretory IgA, which is more important for preterm infants who are predisposed for many infections, including sepsis and disease. So these stick to the gut lining and definitely help prevent infections in the gut. And we can see that each gram of each fortifier, when it is added to human milk through human milk derived fortifier, we are adding almost 48% extra immunoglobulins into the human milk through these fortifiers. So this will, I think, definitely help to reduce the risk of infections and mainly sepsis and MAC. And then also importantly, that is human milk oligosaccharides, that is HMOs, which is also being retained in the human derived fortifier. Nucleotides, which will help in brain development and neurodevelopment, is also being retained. And also alpha-lactalbumin, which is also one of the key elements and also known as the best protein among the whey proteins, is also retained. And it is 22% in human milk. So this is also useful in many ways, not only as a protein, but also beyond nutrition, it is also used as anti-infective properties. And recently there is a anti-cancer agent which has been formed using alpha-lactalbumin derived from human milk, which is called as Hamlet. So this has already been tried in many of the bladder cancers. It is in phase 3 already. So this also has anti-cancer properties. And GML, which also has anti-infective properties, which is also higher in human milk derived fortifier. So these are the main key differences between a human milk derived fortifier versus a bovine milk derived fortifier. So this clearly like classifies or distinguishes between the human milk derived fortifier and the human milk bovine milk derived fortifier. So let's look at briefly about the evidence which has been generated in India about the human milk derived fortifiers. So there is a study which was done on the EHMD, that is exclusive human milk diet, which was a survey which was conducted in almost 17 hospitals across India and 31 cities. Almost 100 neonatologists and also 150 NICU nurses participated in this survey. And one of the key results, if we have to pick and highlight, is 50% of neonatologists opine that almost 10 to 25% of preterm infants who are on a bovine milk-based fortifier, they also develop feeding issues, almost 10 to 25%. And 80% of the neonatologists also agree that HMDF, that is a human milk-derived fortifier, is having good efficacy and safety in preterm infants. And 85% of the NICU nurses also think that human milk derived fortifier is one of the best options among the other fortifiers for fertilization in preterm infants. So this also highlights like usage across India, and also this also highlights what is the clinical benefits that they've already seen through their in and day out practices. So there are also two studies which are also published recently about the human milk derived fortifiers. The first one is the Pejawar et al. There is a pilot study on human milk derived fortifier, where there were almost 13 babies were put on human milk derived fortifier, and this was started at 100 ml per kg per day. If you would like to look at the results, weight gain per day was almost 25 grams per day. And would like to highlight about the last row here, that is the feeding issues were zero, that is almost nil, which would be definitely be expected from using a human milk derived fortifier, and that was also shown in this study. Moving on to the second study, which was done by Dr. Halkar et al., which was published in Prenatology. So this was done mainly.
Sorry to interrupt, sir. You have 4 more minutes left.
Yeah. Just to highlight that this was a study which was done to see how the human milk derived fortifier can be used as early fortification. So here the human milk derived fortifier was started at 50 ml per kg per day, which is considered as early fortification. And one of the baby also started receiving the fortification as early as almost 37 ml or 36 ml per kg per day. So that was the earliest fortification where human milk derived fortifier, MMF, was used. And none of the babies experienced any type of feed intolerance, and there was, of course, 0 episodes of NEC in this study also. So this also again proves us that human milk derived fortifier is definitely beneficial, and efficacy and safety has also been established through these pilot studies for early fortification as well. Human milk derived fortifiers can be safely started at 50 ml. And there is a recent study which was conducted by Kotha et al., that is Rajesh Kotha et al. In Nilofer Hospital in Hyderabad. So this was published recently in JPNM journal, which is the Italian journal. This is the first study where there is a head-to-head comparison between a human milk derived fortifier versus a bovine milk derived fortifier. So this was a randomized control study where the 50 samples, the sample size was 50. There was 25 preterm babies in each arm, and all the fortifiers were initiated at 100 ml per kg per day. If you would like to look at the results of this study, so there were MMF, that is Neolact MMF, that is the standard version which was used, which was having almost 0.12 grams of protein versus 0.27 gram of protein from milk derived fortifier. So human milk derived fortifier in this version had a lesser protein content. Even though that MMF had lesser protein content, we can see that weight gain per day and growth velocity and head circumference is numerically better when compared to the bovine milk derived fortifier. So this also highlights that the benefits of using a human milk derived protein, even if it is in the lesser concentration, will definitely perform better. So coming to the other parameters, that is the secondary parameters, which is the complications in maturity. So here, when the babies were using HMDF, that is the human milk derived fortifier, Neolact MMF, there were 8% lesser incidence of NEC, is 1 versus 3. And there was also 8% lesser incidence of sepsis, that is 3 versus 5. And feed intolerance was also very much lesser in MMF or human milk derived fortifier now. So this again proves us that human milk derived fortifier will not only help in weight gain, but also will help to reduce the complications of sepsis, NEC, and feed intolerance. And this is mainly happening because of the retention of immunoglobulins, HMOs, and alpha-lactal, which is empowering the fortifiers to also prevent the sepsis and NECs. So all these things also resulted in one final solution, that is length of hospital stay was reduced in MMF group, and which is also statistically significant by 3 days. So 3 days is definitely a bigger thing for premature infants who are admitted in NICU. If they can be discharged 3 days earlier, and if that can be done, it was also beneficially, clinically, and also it is beneficially cost effective wise. So definitely it will help in giving the benefits of reducing the sepsis or complications and NEC in preterm infants, which will also help us in reducing the hospital stay, which also ultimately results in cost effective benefits. There was also one more recently published a unique case report on human milk derived fortifier from Andy Stoy from Canada. So here, a baby, that is a preterm baby of 30 weeks gestational age, was put on a bovine milk based fortifier. And immediately after starting a bovine milk based fortifier at 100 ml, the baby developed severe feed intolerance, and the weight gain was over at almost 5 grams per kg per day, 5 grams per day. So they also changed over to the other brand of bovine milk-based fortifier. So even after changing to another brand of fortifier, that is another brand of bovine milk-based fortifier, the same thing repeated again, that is severe feed intolerance, and the weight gain remained less at even 5 grams per day. So with the usage of 2 bovine milk-based fortifiers, the weight gain was very, very less, and also there was severe feed intolerance issues.
So time is up actually.
Yeah, just 1 second.
Sure, sir.
So when the baby was changed over to MMF, that is a human milk derived fortifier, the actual difference was noticed. That is, there was 0 episodes of feeding intolerance, and the weight gain was almost 30 grams per day. So this shows the effectiveness of using a human milk derived fortifier in the same baby where the baby was not tolerating the bovine milk based fortifiers. So concluding the talk and also concluding the results which we have from the preliminary evidences which has been published in, which is also available in the public domain, is that there will be, by using human milk derived fortifiers, there will be 8% reduction in the risk of sepsis, 8% reduction in the risk of NEC, which is a very dreadful complication for a preterm infant. And human milk derived fortifier, because it is available in both 1 gram and also 0.5 gram sachet, that will allow us to start the fortification early, that is almost as at 50 ml per kg per day. And there will be 12% reduction in risk of feeding intolerance, which I think many of the preterm infants experiences this day in and out in NICUs. And of course, all these things will also lead to reduction in the NICU stay by almost 3 days. So this is what we have seen in the study. I think clinically, if we would like to ask the doctors about their clinical experience, it would be more than 3 days, like 4 days or 5 days in their respective units. So this is the main highlights of or benefits of using a human milk derived fortifier. And of course, there are many studies which are also undertaken by many of the neonatologists themselves as the investigator-initiated trials. So we would definitely come back with more evidence, and this is the initial evidence which shows some positive benefits for using a human milk derived fortifier for all the preterm infants in AIDS. Again, thank you very much for giving us this opportunity, and we welcome that any questions are there from the audience. Definitely try to answer them.
Thank you so much, sir. So moving on to our next session, the introduction of endoscopy into surgical practice was one of the largest success stories in the history of medicine. Endoscopy has its roots back in 19th century, and today it's evolved tremendously. So diving into our next talk is endoscopic neonatal surgery by Dr. Ramesh. Sir, are you there?
Yes, please. Am I audible?
Yes, sir, you're audible.
Okay, if this is fine, I'll go. No issues.
Yes,
I'm ready.
Sir. And we chairing this session is Dr. Najagal Mat. We welcome you, sir. Yes, sir. And Dr. Mukund, is Dr. Mukund here with us online?
Yes, I'm online.
Yes, we welcome you, sir.
Yeah, thank you.
Yes, so we can start.
Yep. Good morning, ladies and gentlemen. It is indeed a matter of privilege and a pleasure to be amongst good friends. NNF has been a very, very good group of people with whom I have got a long association. I'm very happy to be sharing with you my ideas and my concepts of this minimally invasive surgery. In fact, more than endoscopic surgery, which is a rather misleading term, I prefer to call it as a minimal access surgery. People used to also call us minimal invasive surgery, which may again not be the right thing, because it's not the invasion which varies, but the access. The organizers, can you please mute the other microphones, please? I'm getting too much of noise from others. Distracting, please. Hello? I think some organizer's microphone is on. Okay, thanks. I think it's taken care of. Now again it is gone. Hello. Okay. So coming to minimal access surgery in children, it has been a revolutionary advance. So whatever initially came to general surgery and say gynecology was gradually adapted to pediatric practice, and we've been practicing minimal invasive surgery in children for the last 20 years or so. And with every passing year, we find that there is increasing applications. And every year somebody comes up with something really new and very interesting. The feasibility and safety concerns, which are major issues earlier, have all been adequately addressed. To that extent, yes, we know it is feasible, and yes, we know it is safe to do procedures even in newborn children. The technology and equipment, which used to be the major hindering factor as far as performing procedures in small babies, particularly newborns, have been adequately addressed to a major extent. To that extent, we are getting a lot of this miniature equipments, small equipments, and small little hand instruments with which we are able to do justice even to the smallest of newborns, including preterm children. And with increasing number of cases being done across the world, the evidence also is increasing about its utility, about its safety, about the newer technologies by which we can. To that extent, I can even comfortably say that what can be done by open surgery will ultimately be done by minimal invasive surgery. Even though it is right now looks very far off, that day is actually not very far off. When it comes to minimal access surgery in a newborn child, the challenges are plenty. The first challenge is about a space constraint. In fact, if you can see my hand, it is just this much of space. Most of the times it's available, whether it's the chest cavity or the abdominal cavity. All that you get is about a fist space within which we need to adapt, because we don't have much place to move our fingers and hand and instruments, and space is the biggest constraint. We need to adapt because we can't do anything more, and we need to choose the right size instruments, right quality instruments to have. There are a lot of other safety concerns as far as baby is concerned, a newborn is concerned, because there's a very unique physiology, because the newborn is in the adaptation process from in utero life to an ex utero life, and lots of changes are happening, not just in the organ systems, but also in the immune function. This apart, for creating a space, we always use carbon dioxide. And when we use carbon dioxide to inflate, there may be problems of adaptation by the newborn baby. Not just that, the pressure inside the abdomen or chest may impair renal perfusion and even circulation. For example, if you can keep abdominal pressure of more than 10 in the beginning, or the chest about more than 5, the venous return gets hampered, by which the cardiac output gets hampered, and definitely it doesn't bode well to the baby. So obviously we need to adapt. We need to wait for things to work out well and go further. Current status. Okay, where are we? Where are we? Even though I extolled about its virtue and say that it has got plenty of advantages, it is still considered as a highly specialized procedure requiring a lot of expertise and experience. It requires a very strong setup, not just about the theater setup, but also the backup team. Most important, I personally feel the reason why it has not taken its due place and it's still not widely done in all the centers is reflected by the risk appetite of the time. That is, if the team is willing to try something new, willing to put that extra bit of effort to learn and adapt to newer technologies which come, definitely that is a center where you can expect these neonatal MIs to pick up. In other places which may not be that easy to adapt, may be lagging behind. However, the specialized centers where this sort of MIS procedures are being done are definitely increasing. The indications are increasing and newer technologies are coming. For example, the robotic surgery, which used to be very big behemoths and very difficult to handle, now are coming up with smaller and smaller instruments. It's time before we get miniature robotic instruments to go further. I'm just going to share with you some of the videos by which we can show about the procedures which we have done. It's not somewhere else. Okay. So for example, this is a child with an esophageal atresia and a tracheoesophageal fistula. You can imagine even within a small chest space, we have managed to put our instruments. This is the azygos waist, which is being sort of cauterized and is being divided. And in fact, now people are saying that you don't really need to do ligation of the azygos vein. You can see the chest, and this is a fistula which is being sort of dissected. You can make out that the visibility is better and the fistula is being clipped. Nowadays, we don't clip, we would rather transfix it and ligate it in suture. But again, if you look at it, anything inside the chest, it is worth attempting thoracoscopy, because what happens in a chest is that Even for approaching a small little lesion, you need to make a very big incision, a chest rib spreading thoracotomy to go ahead. After the fistula is ligated or clipped in this case, we're trying to divide it. Once the lower porch of the fistula is divided, and you can see the lumen which is coming up, this is the upper porch which is being dissected, and a feeding tube is being passed from the proximal pouch, and this will be put into the distal pouch, and then we will be doing the anastomosis. So what we are trying to tell is the child which requires a long incision in the chest, this is anastomosis in progress. You can make out that it's not an easy thing. It's not a child's play. It requires a lot of expertise and adaptation, but still we feel it is worth it when compared to giving a long scar and a rib cutting thoracotomy for a small baby. This is a child with a diaphragmatic hernia. Newborns, we tend to see them quite a bit. And again, previously laparotomy was used with a choice because we used to say we need to correct malnutrition. Now we understand that it is not needed. There are two types of diaphragmatic hernia, with and without a sac. With sac is a little easy. This is a child where there is no sac, and hence we have to reduce the contents which are herniated into the chest back to the abdomen. And it may be quite a daunting task because we cannot afford to injure. This child, if you can make out, the stomach has been reduced, the intestines have been reduced, and the spleen is going to be reduced. Any small injury to the spleen will likely to bleed a lot. And if you realize after reducing the whole thing, this is in a newborn child, you can realize that the defect is not too huge, and we may have to suture them. And there are other various methods to suture. One, we can do it intracorporeally, one we can do extracorporeally. You can already see one stitch being put, and we need to take a series of stitches with the non-absorbable suture material, either by means of a what we call as a proline, nylon, or silk. Anything can be used, and we have seen that again, just with a small 3 little ports, we are able to handle it, and abdomen is left free. Diaphragmatic hernias, only those with a very large defect may require a patch, and those patches may be a problem. This is a child with a duodenal atresia, in which the proximal duodenum is dilated, distal duodenum is small, may or may not be associated with an annular pancreas. Unfortunately, this video is not playing, so I'm not able to play. But of course, it's very easy to put as anchoring stitch in the proximal end, lake it up, and do a diamond shape anastomosis called a duodeno-duodenostomy. This is generally the standard treatment of choice, whether we do open or laparoscopy. Advantage of laparoscopy is again very minimal access. The disadvantages, we require immense amount of suturing skills to do that. This is a child where there's a malrotation, fundoplication being done in a small baby with operated for G reflex, severe G reflex following TEF. If we can make out such a small child, even for getting into the hiatus area, it requires a lot of dissection. Here is the place where we are opening the hiatus. We're just cutting the peritoneal attachments. You can see the lower end of the esophagus is being released. We're going to the opposite side. We're creating some space. We are creating some space, and then we'll be getting the fundus across and suture it. If you look at it, it is fairly a daunting task, but it can be done provided you have the expertise and the experience to do it. So it is not difficult, but it is definitely, if you can make out, this is how the hiatus is being sutured to make sure that the fundal wrap doesn't go up. And once that is done, we're going to, this is the fundus being brought along around the lower part of the esophagus. This is Hussein maneuver to make sure that there is adequate mobilization. And we put a series of preferably about 3 stitches, and including anchoring on the esophagus to make sure that the fundus is hitching around to prevent reflux happening. This is a child who had a CCAM, underwent a lobectomy, again in a newborn child. This is a video I've taken from my good friend, Dr. Chandrasekharam, because I couldn't locate my this thing. This is just about the pleural cavity being opened up, and then we are going to gradually see there is the fissure being separated, and gradually we will be exposing the vessels which are basically supplying the lobe which is affected, in this case the lower lobe. And then we have devices like LigaSure, which will help us to identify and seal the vessels as well as to cut. So it's a very patient procedure, because we don't have much space, we don't have adequate assistance from others. If you can make out the pulmonary vessels are ligated or dilated, so it's a question of patient dissection that we will be able to get. A point to be kept in mind is all these pulmonary vessels are directly draining into the vena cava, superior or inferior vena cava. So this may bleed a lot if you don't have adequate control. Okay, you can see that the vessels are being isolated, and then we ligate it, or we basically use a ligature device to seal them and cut them. And again, there are the other vessels, the pulmonary vessels, the pulmonary artery, the pulmonary vein, the bronchial vessels, and finally it's a bronchus which comes, which in a small child we just use a ligature or we just ligate it, whereas in an older child we can use a clip application. I mean, we can use a stapler. This is a child with a fundoplication, not necessarily seen in newborns very many times, but it is a paraneonate. It's about 1.5 month old children is commonly seen. Whereas we have also seen at least about 5% of children who actually undergo pyloromyotomy are quite small. We're just making a small incision to get a starter hole. And this is a pyloromyotomy knife with which the pylorus is being cut to get a starter hole. And you can see the elegance with which we will be able to do the pyloromyotomy. That is, we're just going to put a pyloric spreader and we're going to open this. Many people used to argue that the incision otherwise is small, but please understand, in a small child, whatever incision, especially in newborn child that you give, will definitely grow as the child grows. We're just putting a pyloric spreader, stabilizing, and you can see the effectiveness of this pyloric spreader with which we will be able to get it. Okay, all it requires is a splitting of the pyloric muscle thickened. You can see the intact mucosa inside, with which we are sure that we have not caused any damage. This procedure actually takes not more than 10 to 15 minutes, and it is as much as the open surgery and comes out well. This is a big, normally pyeloplasties are done a little later, but this child had a very large pelvis with a documented obstruction with reduced function. This is a robotic pyeloplasty being done just to tell you about the utility of the robot. Can you make out the precision with which we are able to take it? Of course, this video is not mine because I'm not really into robotics because I don't have access. This is a case of pyeloplasty being done by Dr. Gurusev Sandlas in Mumbai. But I just want to say that all these videos what I'm showing are all done basically within our own country. You can make out the spatulation goes, and this is the suturing goes. Even in a small 3 kg child, we are able to do robotic and we are able to do the pyeloplasty. This is a complicated reconstruction and requires very fine sutures between a very narrow ureter and a very thin pelvis, but still we are able to manage and we should be able to do it. And this is the pyeloplasty where you can see that the ureter is sutured, and what we're now seeing is a suturing of the pelvis. Most of the children have got very good results. Again, this is a video clip from Dr. Chandrasekharam about a pancreatectomy being done for nesidioblastosis. This is a child. You can see that the stomach has been taken up and the lesser sac is open to expose the pancreas. And then once the pancreas is exposed, we dissect most of them. In a case of nesidioblastosis, we may have to do about 90 to 95% pancreatectomy so that the functioning pancreatic tissue can be taken out and the episodes of hypoglycemia can be reduced so that these children can do well. This is again fixing the stomach to the abdominal wall. These are the jugaads that we have to do because we don't have too much of space and we don't have too many assistants who can help. This is the pancreas which is being taken out, and if you can see what is being seen here behind is the splenic vessels, splenic artery and vein. We have to be extremely careful because taking out a spleen in such a small child is going to be difficult. You can make out that the pancreas is being slowly dissected off from the tail and the body. Only the head of the pancreas may have to be kept, mainly because it is covering the duodenum and we can't afford to take that out. If you can make out, most of the pancreas are already being dissected. We go up to the superior mesenteric vessels to make sure that the most of the pancreas actually is dissected. If you can make out, now most of the pancreas already is being dissected and we can be able to take it out. Okay, this is a sealing device. This is an end-seal device by which we are taken out, and you can clearly see that the superior mesenteric vessels are there, the splenic vessels are there, and we are making sure that there's going to be no other damage to the essential structures to come back. This is a child with a malrotation. Unfortunately, video is not playing. Again, for malrotation, all we need to do is to release the bands, to release the duodenum from the colon, widen the mesenteric base, do an appendicectomy. All of them can be easily accomplished just by laparoscopy. In conclusion, I would like to say that minimal access surgery in children, especially in newborns, minimal access surgery in neonates is there to stay. It can't be wished away. It is safe, it is feasible, and there are increasing applications. Every year, there are new indications being added, and what used to be considered not possible, the list is slowly coming onto the puzzle. It is possible. And what was possible in being done in specialized centers are being done in other centers. So it's a question of time before this goes much more wider for much more wider application. Of course, it requires a lot of expertise and experience, and it's still not routinely done in most of the centers. But with the high volumes that the country of India has, it's a question of time before this spreads more. Footbridge is enlarging. Definitely, future is extremely bright. I would like to acknowledge these people for the videos because I was not able to get my own personal videos. I've done all these things, but I couldn't get my videos because of some technical issues. Dr. Asik Shah, Dr. BBS Chandrasekharam, Dr. Gurusev Sandlas, all of them in Bombay. I'm in Bombay and Hyderabad. All of them very good friends of mine helped me to give the videos. I would like to sincerely thank them for this. Thank you very much for a very patient listening. I'll be very, very glad to take any questions from anybody.
Sir, thank you. Do we have any questions?
Yes, Dr. Ramesh, Dr. Mukund.
Yes, Mukunda.
So sir, because you started laparoscopy in 2006, because I was one of the trainee under your laparoscopy.
Yes, Mukunda, I remember.
Yeah. Correct. So now 15 to 18 years of your laparoscopy.
Yes, sir.
What skills you have? Because you have seen residents going through your training program.
Yes,
how many residents can do a tracheostomal fistula repair or a duodenostomy kind of a thing?
Yes,
as
sir.
we discussed, it is quite demanding.
Yes, sir.
And when you go into private practice and all, the outcome of the surgery is the most factor.
Agreed.
Because we need 100%. There is no 99.9% for
agreed.
How do you see the suturing skills talked about? How do you train your residents for the high-end kind of a stuff?
Yes.
And your take on the instruments, because we have a Grasper, Maryland. Some of the basic things come from what we have. And especially I was in US, now you got angled scopes, dedicated instruments, research programs going on for the technicality, what the surgeons gone through during the operation. So you are taking this forward in your institute because Indira Gandhi is a very, very high volume center.
Yes, sir. Thanks for asking this, Mukunda. Because as I have seen, in fact, small correction, we started laparoscopy in 2001. We had the first major international workshop in 2001. And then onwards we've been doing. But steadily, three things have seen. Because initially the people did not, even the residents did not have much interest, and they never used to come, and you would have thought as an experimental thing where me and Dr. Srimurthy used to sit and log in on. But gradually when they start going out and started practice, they realized that it is inevitable they have to learn. So the pressure came on them. So gradually our own people came down, started approaching it more. Number two, the instrumentation and the visibility. For example, previously used to work with single chip camera, then we turned to 3-chip camera. Now we got HD camera. The visibility is much better. So the safety factor also is better. The instrument availability has also become better, and the application and the interest of the residents are increasing to that extent. Our institute, laparoscopic pyloromyotomy is done by the first and second year PGs, and for first year PGs with assistant, second year PG without assistants. And this means that we have come a long way. So I encourage them to do diaphragmatic hernias. I encourage them to do pyloromyotomy. Yes, and excisional surgeries. Yes. When it comes to esophageal atresia, when it comes to duodenal atresia, when it comes to a lobectomy, yes, it is going to be technically demanding. It is still the staff being done. But the way they're assisting us is a question of time before we get. Having said that, Mukunda, the biggest drawback that we have in institute, which is a very large volume center, is that we don't get time. Okay, because there are so many emergencies waiting. Anesthetist simply said, do you want to do this for a longer time? Because initial learning curve is more, especially if it is done by youngsters. And that is a major drawback we are finding. For example, despite all my assertions, the number of TOFs that we are doing thoracoscopically is less than 5 to 10%, maybe about 10% or much less than that. The reason is because they come late or there's not much time, we have to finish up. But what I would say definitely, Mukunda, to answer is that the learning curve is coming down, the incidence is coming down of what do you call, the reluctance is coming down, and definitely it's a question of time before it goes. I hope I've addressed your question.
Yes, Doctor. I mean, what happens in the backup? If you see, if around me, I can do a diaphragmatic hernia or a pyeloplasty. It's a backup plan for any surgeon, because in senior guiding us, the outcome for the baby and the stress to the surgeon becomes very minimum.
Yes, sir.
That's what you should. I think in that way.
Yes,
and the suturing skills. I mean, you see, when I do a TOF, I use 60 or 70 PDS, but maybe a thoracotomy.
Yes,
for
sir.
dural atresia, again I use 6070. Pyeloplasty 70. The
Yes,
same thing. I mean, my personal say, unless, like as you said, VBS is one of an expert suturing techniques you have to
Yes,
replicate those stuff in a common group of pediatric surgeons, or the learning curve is tremendous. I mean, in that way, my opinion slightly differs, especially for whenever you do reconstructive surgery, because the outcome is for 70 years. The stricture rates, the anastomotic clicks, the dissection. It's a very skilled special thing.
Yeah, just to address Mukunda, just to address that issue, I agree with you that it is technically demanding, but unless you try, you're not going to improve. And the best way to improve is not on the baby, but on endotrainers. In fact, I conduct laparoscopy training courses. I set up endotrainers. I think all you need to do is to get an endotrainer, put a small box of 5 centimeters each, put some 2 gloves inside, and practice a suturing skill every day for at least 20 to 30 minutes every day. So what happens is some question of months before you will be comfortably doing it. So I sincerely suggest that you start practicing on endotrainers or maybe animal tissues, and you should be able to do this better, sir.
Yes, sir. Yes, sir. Point taken.
Nijigal, any other questions? Or I think time is up.
Thanks for a nice talk and for introducing minimal assist surgery to all the neonates. Thank you, sir.
Thank you very much.
Thank you, sir. Thank you so much. You're always inspiring me. Thank you.
Thank you, sir.
Thank you.
So moving on to our next talk, because we're running tight on schedule, is a very interesting one. That is on anticoagulation in neonates by Dr. Vandana Bharadwaj and chaired by Dr. Amit Dahar. Sir is MBBS, MD, Fellowship in Neonatal Medicine, Fellowship in ECHO, and MBA in Healthcare Management. He's a Director and Head of Mother and Child Unit at Vidarbha Institute of Medical Sciences, Maharashtra, and Director of Geeta MediSquare Private Limited. We welcome you, sir. And ma'am, are you online?
So good morning, everyone. So nice to see you on this early morning. And we are having a very interesting topics. It's a mixed bag. And about the next topic, we have anticoagulation units. Dr. Vandana Bharadwaj, she is a prolific speaker. She is Associate Professor in Pediatric Hematology Oncology at St. John's Medical College, Bangalore. And as we are having scarcity of time, I will request ma'am to start the session.
Thank you, sir, and thank you to the organizers. This is my first time at NNF, and I'm really grateful for the opportunity to come and speak here with so many eminent speakers and experts in the field. So I'll move on. My slides don't seem to be moving. Just a moment. Yeah, sorry. I had just the context of what is anticoagulation in neonates. Why should we know about anticoagulation in neonates? I had some quiz and trivia for a face-to-face presentation, but perhaps I'll go over that quickly. A couple of case studies and some data from our own center. As you all know, we have a big tertiary neonatal center. One of my special interests is neonatal hematology, and we have a thrombosis registry for the past 3 years, and I'd like to present some data on that. And finally, some take-home messages. So the incidence of venous thromboembolism in children is between 0.7 and 1.9 per 100,000 children. And we know that more than 90% are secondary. But newborns are a separate group, and we consider them separately because they are at particularly high risk of thromboembolism. And the estimated annual incidence is about 0.5 per 10,000 newborns. But it is increasingly diagnosed because of increased awareness and early recognition. And the mortality is anywhere between 5 and 20%. RVT is renal vein thrombosis and 18% for other venous thrombosis. But this is a fairly about a 10, 15-year-old registry. And as we learn to recognize these illnesses earlier, our mortality and morbidity becomes much lesser. The other important thing in neonates, of course, is venous access and sampling. And as you know, the coagulation parameters are the hardest to sample because of the exact volume of blood required. So why are neonates at increased risk of thrombosis? They have an immature coagulation system, the concept of developmental hemostasis. They have decreased activity of anticoagulant factors like antithrombin 3, protein C, protein S. They have decreased fibrinolytic activity because of lower plasminogen levels. And neonates, particularly the preterm neonates, have an increased risk of having central lines, getting sepsis, having liver dysfunction. So we classify the risk factors into what happens in the mummy, what happens to the neonate, and risk factors due to central venous catheter and mechanical ventilation, placing of a umbilical venous catheter, etc. Won't go into too much detail on that. So I'll skip over these and go to the case history. So we have a 17-day-old baby girl, primary gravida mummy, who gave birth to this 2.7 kg girl at term by cesarean section. Incessant crying and abnormal movements for 1 day, exclusively breastfed with some feeding difficulties, 30% weight loss and irritable with a sunken fontanelle. The investigations at admissions show a hemoglobin of 11, normal white cell count, slightly low platelet count, obviously hypernatremic, and a high urea. So this is the neuroimaging, acute intracranial hemorrhage in the bifrontal region, and no flow signals in the superior sagittal sinus and the left transverse sinus and left sigmoid sinus as well. So this is suggestive of CSVT, cerebral sinus venous thrombosis. So hypernatremic dehydration, which I'm sure you all see fairly frequently, with cortical sinus venous thrombosis with intracranial hemorrhage. Now, the question here is, should we anticoagulate this baby? This is always a question in the presence of intracranial hemorrhage. Should we anticoagulate such a baby who clearly has a thrombosis because of a presence of a risk factor? So the recommendation here is, this is from the American College of Chest Physicians and other international guidelines, ASH guidelines, American Society of Hematology guidelines. So any cerebral sinus venous thrombosis without significant intracranial hemorrhage, the anticoagulation should be continued for a minimum of 3 months, probably 6 months, and we'll come to that in a minute. With significant hemorrhage, again, it's a gray area. So what we follow in our unit is to actually, there's a school of thought that says you should anticoagulate anyway, because the harm from the progression of the thrombosis is probably going to be more than the intracranial hemorrhage you have. Or reassess the risk factors and see if you have very high risk factors, like for example, a significant thrombocytopenia or extreme prematurity that increase your risk for intracranial hemorrhage, then you reassess at about 5 to 7 days. Sometimes we do it a little earlier if the baby is more symptomatic, to see whether there is progression of the thrombosis. And if there is progression of thrombosis, then there is no doubt that anticoagulation should be instituted. And who should get, why we should get antithrombotic treatment. So reducing the risk of embolization, reducing the risk of recurrence and the risk of post-thrombotic syndrome, which is not such a big problem in children as it is in adults, but is there nevertheless. So when should we not treat? Like we just discussed, exceptionally high risk of hemorrhage, and a relative contraindication is a thrombocytopenia. So a severe, very severe thrombocytopenia, like for example, less than 20,000, may be an indication to withhold anticoagulation temporarily, knowing that one must assess the risk of not anticoagulating on a daily basis. How to start antithrombotic therapy? So we all know starting either unfractionated heparin or low molecular weight heparin, and then transition to a vitamin K antagonist if feasible. Although I have to say these are the recommendations. Personally, my experience is that it is actually quite difficult to give vitamin K antagonists in little babies, in neonates, particularly the preterm ones, because of the developmental hemostasis problem, because of the relative vitamin K deficiency and liver immaturity. So our preference overall is to keep these children on low molecular weight heparin for the entire duration of anticoagulation. How do we monitor therapy? So an APTT or an anti-factor 10A. So we all know about this. Luckily for us now, the anti-factor 10 APTT is available, of course, in all centers, in all laboratories. All small laboratories will also have an APTT available. So that should not be a problem for the unfractionated heparin. For the anti-factor 10A, we have several laboratories in the city and all over the country available to do an anti-factor 10A. If it is not possible to do an anti-factor 10A, and you have normal renal function and a normal platelet count, it is reasonable to still go ahead and give the low molecular weight heparin, because giving unfractionated heparin actually is much harder. You have to monitor the APTT quite frequently, and doing it once the baby is discharged, giving unfractionated heparin once the baby is discharged is actually quite troublesome. So a little more about low molecular weight heparin therapy. The only thing I want to say here is targeting a level of 0.5 to 1. Of course, this varies slightly between 0.5 to 1 and 0.3 to 0.8, depending upon which low molecular weight heparin you're using, dalteparin, tenzaparin, etc. But in general, the range is 0.5 to 1. Okay, so this is about doses in neonates, and we know that if the more premature the neonate, or the younger the neonate, the higher the dose that we need to give, for all the reasons mentioned at the beginning. So anybody less than 3 months, 1.5 milligram per kilogram subcutaneous every 12 hours. More than 3 months, we generally give 1 milligram per kilogram twice daily, subcutaneous. So oral vitamin K anticoagulants, like I said, this is not that much of an issue in neonates, because giving warfarin or acetrom to neonates is actually quite difficult. So I will go over all of these. So now, how long do we give anticoagulation? So transient risk factors. So for example, our case of hypernatremic dehydration, 3 months of therapy is definitely indicated. Whether or not we should continue beyond 3 months, again, is a matter of debate. But in general, the recommendation from several groups seems to be that if there is an unresolved risk factor, for example, if this is an antithrombin deficiency, for example, or there are continued risk factors or multiple risk factors persist, then we should continue 6 months of therapy. And this was recommended in the KIDS-DOT trial. Now, in neonatal thrombosis that is secondary to hypernatremic dehydration or sepsis, for example, in our center, we do an MRI at about 12 weeks and see whether there is complete recanalization. If there is complete recanalization, often we stop, and we really have not seen any recurrence or progression of thrombosis when we stop anticoagulation at that point. So just a couple of slides about our thrombosis registry. So we know that the disease burden is small, but however, in our center, we had about 24 cases in 3 years. So 7 per every 1,000 neonatal admissions, and the incidence calculated according to this is about 128 per 100,000 live births. This is a bit more, of course, than what incidence I described at the beginning, but that is probably because we have a referral bias as a tertiary center. So the gestational age, obviously we take children up to between 24 and 40 weeks. Most of them were term infants, actually. The preterms had less thrombosis. All birth weights there. And as you will see here, most of them, so 15 out of the 15 had a provoked, so a secondary thrombosis, like we alluded to before. And only actually 1 child was born out of a consanguineous marriage. The rest were non-consanguineous. So the majority of these thrombosis were actually the venous CSVT, cerebral sinus venous thrombosis. We had a couple of strokes, of course. Then we had 1 hemorrhagic stroke. We had some purpurofulminans. We had a couple of peripheral venous thrombosis, as well as a couple of arterial thrombosis, including aorta thrombosis. So in terms of etiology, sepsis, dengue, hypernatremic dehydration, birth asphyxia, all of these causes made up for more than 90% of the causes. Thrombophilia was only 2 out of the total, 26, and polycythemia was only 1. I'll go over this. So this is case study 2. I'm sure many of you in the audience or certainly the listeners have seen a child like this. This is an 8-day-old term neonate which showed a Doppler of the bilateral and presented with this to a peripheral hospital and then referred to our hospital. As you can see, there's purplish discoloration of the hands and the feet, and then necrotic area on the scalp as well as on the right leg. So the Doppler of the bilateral upper and lower limbs showed normal uptake in all vessels, and the platelet count was low, whereas the hemoglobin and total count were reasonably normal. There was no evidence of sepsis. This was a neonate with purpura fulminans. And I just wanted to talk a little bit about this because this is a life-threatening emergency and we need to manage it optimally. Otherwise, the situation gets out of hand fairly quickly. So it's a cutaneous hemorrhage with necrosis resulting from microvascular thrombosis, most commonly due to homozygous protein C deficiency, and it is treated by FFP infusion. So the other question that often is asked in the neonatal period is how is a central venous line related, whether it's a UVC or a long line related thrombosis in neonates managed. So the general recommendation is that one should start therapeutic anticoagulation and then remove the umbilical catheter. Duration, again, between 6 weeks and 3 months, but I think most experts around the world would probably give about 6 weeks of therapy. If the central venous line cannot be removed, obviously because it is vital for the care of the baby, then prophylactic anticoagulation can be continued until the time it can be removed. So just a few other indications in neonates about renal vein thrombosis. So bilateral venal vein thrombosis obviously has to be treated by anticoagulation. If there is impending renal failure, oliguria requiring dialysis, thrombolysis is indicated, and I'll talk about that in a minute. Unilateral renal vein thrombosis obviously is not as serious because the other kidney is there to compensate. So treatment with low molecular weight heparin between 6 weeks and 3 months is the recommendation.
Sorry for the interruption, ma'am. You have 5 more minutes left.
Yes, sure. I'll finish quickly. So thrombolysis in neonates can be systemic or catheter guided. Very happy to say that we have successfully done this in at least 5 neonates at our center for arterial thrombosis as well as venous thrombosis, mostly arterial thrombosis, life-threatening, limb-threatening venous thrombosis. So the child with the aortic thrombosis as well as one brachial artery thrombosis and one with the other arm thrombosis and an iliac vein thrombosis. So we have successfully given thrombolysis in neonates as well as, of course, in older children for other indications with no major increase in bleeding, no catastrophic bleeding reported. The recommendation is that it should only be used for life and limb-threatening thrombosis with giving prior FFP. This is to replace the enough plasminogen so that the thrombolysis can actually be effective because neonates, as we know, are low in plasminogen. Move over. So peripheral artery thrombosis, removal of the central venous line. Surgical thrombectomy can also be considered. So arterial ischemic stroke, final thing here. So if there is no cardiac source, so the echocardiogram shows no evidence of a source of an embolism, then there is only supportive care. If there is an ongoing cardioembolic source, then we would suggest unfractionated heparin or low molecular weight heparin. Neonates with recurrent acute ischemic stroke, arterial ischemic stroke, can be given aspirin or anticoagulation. In our unit, we generally give aspirin. Okay, so last slide, I think. So this was just a quiz on most neonatal venous thrombosis are secondary events. Yes, that is true. CT is the choice of CNS imaging. No, MRI or MRV is the choice of CNS imaging. Anticoagulation by low molecular weight heparin is preferred in the newborn. That is correct. Purpura fulminans is obviously not a self-limiting condition. And thrombophilia testing should be selective and interpreted appropriately. Haven't had time really in this lecture to go into thrombophilia testing, but happy to take any questions on that. But that is really the take-home message. It should be selective and interpreted appropriately.
Thank you so much, Dr. Vandana, for such an excellent presentation. As we are running short of time, we won't be able to take any questions. If you would have been here physically, we would have felicitated you, but I am sure, like, you know, your friends from Bangalore can courier you the certificate and the memento. So with that, I'll ask the organizers to shift to the next topic. Thank you so much.
Thank you, sir. Thank you. My pleasure.
As we are running tight on our schedule, moving on to our next talk, which is on setting up a neonatal database network in India by Dr. Deepak Chawla. Deepak Chawla is a professor in the Department of Neonatology in the Government Medical College, Chandigarh. His areas of interest being the research methods, systematic reviews and guidelines, and quality improvement. So can you hear me?
Good morning.
Yes, sir. We can hear you.
Okay, can you see the slide? First slide.
Yes, sir.
Thank you. Good morning, everyone, and thanks to for giving me this opportunity to address you on this morning of first day of the NeoCon. So over next 20 minutes or so, we will try to look at what are utilities and challenges in setting up a neonatal database network in India. Now, before we go on to look at different options and benefits of having a database and purpose of having a database, let's look at definitions. So what is a database? Database can be defined, Oracle defines it as an organized collection of structured information, usually collected in an electronic format. Although it may not be in electronic format, it may be even in a non-electronic or analog format. What is a network? A network we can define in two ways. Network is a noun, in which then it will say network is a collection of computers connected to allow data sharing. But more appropriate definition of for us when we think of a neonatal database network is network as a verb, making a network which allows interaction with each other to exchange information and develop, although the definition says professional or social contacts, but here the idea of exchanging information is to develop action points. Now, if you are practicing neonatology in a unit which is providing level 2 or level 3 care, you may have some questions like, what changes have my unit seen in the incidence of late onset sepsis over last 5 years? How does it compare to other similar units? Or how can I improve the proportion of very low birth weight babies who are on exclusive breastfeeding throughout admission? Or is use of postnatal steroids high in my unit? And if so, why? And if high, what practices can bring the use of steroids down? So these are 3 examples of different questions which may come to your mind if you are reflecting on your practices, your processes, and your outcomes. But most of us are not able to answer these questions. And the reasons are that we work in our silos, we work in our units. The data collection in most of the units is paper-based. Many units, when they are discharging, they are just typing the discharges on a Microsoft Word and then taking printout. Some units may be entering data on a spreadsheet to collect data. But when you are collecting, we are afraid of sharing the data that the data may show us in bad light. And when we are able to analyze data individually, we do not have analysis skills to bring out information which can compare performance in our unit with other units. So if we look at an individual unit has a input in the form of admission, and then various inputs in the form of human resources, doctor, nurses, various equipment, consumables, which are used to conduct various healthcare processes and which then result in discharge or death. So all of these things, admission, baseline characteristics of a baby, type of healthcare processes done, timing of healthcare processes done, resulting in various morbidities, discharges, deaths, all of this constitutes the data which is collected in a database. And every unit has its individual variations in type of admissions, types of healthcare resources in the form of human resources or supplies and equipment, the way they conduct their processes, and hence the variability in discharges or deaths. So if you look at setting up a database, you can think of every unit having this sort of process of input, procedures and outputs going on in their units. And we know that while this is going on in different units, there is a lot of variability. This variability was evident 20 years back. For example, this graph shows data of the NNPD network, which was collected last in 2002 and 3. And these two graphs 20 years back are showing adverse outcome rate per 1,000 live births. And you can see that although the most of the units are around 38 or 40%, but there's a variability with a unit showing as low as around 17% and another unit showing as high as 97%. Similarly, percent of very low birth weight babies who develop late onset sepsis, although the common denominator you can say or mean is around 10%, but the variation you can see as low as around 3% to as high as 18 or 19%. So this variability, which was seen across 16 centers in 2002, is still there. It has not been addressed. For example, if we look at the Delhi study, the Delhi sepsis study, which had 3 centers, and if I look at case fatality rate among all sepsis cases, one center has around 20%, another center has around 43%, another third center has around 10%. And if you look at case fatality in culture positive sepsis, again, so much variation, and even their confidence interval do not match. Then if you look at another trial which has been conducted in India, the goat lung surfactant extract trial, and we look at deaths in the control group, not in the goat surfactant group, but in the control group in which baby got Surventa, and you look at deaths variability, 0%, 22%, 37%, 50%, 67%. And lastly, if you look at the Helix trial published recently and raised a lot of controversy, again, if you see the incidence of death before discharge is varying from as low as 40% to as 14% to as high as 40%. And I'm showing these 3 studies or trials because they have defined eligibility criteria in which you have certain subset of babies which meet this criteria, and therefore the population is likely to be uniform. So even when the population is uniform, we see a lot of variability. And what are reasons of this variability? One reason can be, of course, as I said, different. But this data is from trials which are more likely to have similar sort of patients. And second can be just random variation that if you keep on collecting data, even from similar patients, even from within a unit, there will be month to month or quarter to quarter or year to year variability. And if you're collecting from different centers, there is variability, which is just random variation. But if you take out these 2 things, different patients or random variation by looking at, by uniforming, standardizing the patients, like we saw in the trials, and by taking into account random variability, by taking their confidence interval, and if there is still variability unexplained, then most likely it is because of different care practices, different resources, different care practices. And this variability cannot be addressed till we understand the reasons of variation and then take steps to standardize the care. Now, what are the drawbacks of currently deployed paper-based system data recording or semi-electronic, you can say Word or that kind of database collection? First of all, it facilitates data entry, not retrieval. If you are collecting data in registers or Microsoft Word, you can enter, but you cannot retrieve the data from it. And data is not indexed, so it takes long time to find what you seek. There is no implicit criteria by which you can say that my data is now completed if you're collecting on registers or papers or Word. And data collected at different places is not interlinked. And of course, the perennial problem of poor handwriting and trying to find out what actually is meant when someone has written some words on a case file. So most units who deploy this kind of paper system or word typing system have these kind of problems to convert data into information. Now, once we collect data has to be translated into information. Unless it is translated into information, it is useless. And it has certain steps, which can be divided into two parts: data production and then use of that information. Data production has three components: a systematic, harmonized, standard data collection, quality check of the data, and then analyzing the data or compiling the data to convert into information. Once information is there, then it should be disseminated to people, which can then use skilled decision making based on this information. And based on that skilled decision making, they can take evidence-based action. And again, the data collection, data use cycle resumes to find out that once you have taken evidence-based action, what is the result, whether your variability is improving, whether the outcomes are improving or not. Now, once we understand the reasons of data collection and specifications of data collection and use, there are two interlinked set of questions. First is, what kind of database a modern neonatal unit needs, and how can one implement such a database? And second is, what kind of questions we should ask from the database and how to use the information we get from this database. Now, what kind of database a modern unit needs? There are two specifications which we can think of from database perspective. That first of all, it has to be a web-based system or similar system, which can be accessed from different sites and which have a hierarchical access so that different people can access from different ways. And if you think from neonatal units perspective, or from a user perspective, I want that such a database should be integrated with processes of the unit. What are processes of the unit? Admitting a patient, assessing a patient first time, discharging a patient, or recording different events in between. And second, most of the units have to generate different reports, perinatal reports, birth defect reports, reports to give to NHM. So if as a user of the data, if the database can satisfy these demand-driven reporting, that will facilitate the use of the database. So these are the four things we need from a modern database. And there are few examples. For example, the Indian Neonatal Collaborative, which has been functioning from around 5 years, many of the listeners will be participating in this, has been able to collect data of around, till now, around 25,000 babies. And we have different set of babies in which data has been collected and reporting is done. Similarly, there are other platforms like Redcape platform, which can be used, and there are different platforms which can be used to constitute this kind of database. Now, once it is available, how to implement in a particular unit? So there are obviously questions: who enters data? Once we have availability of such a database, it is important that it becomes part of the processes of the unit, so that it is part of the work culture, so that residents, consultants, everyone is entering data. When you are interacting with data, you are checking data, you are entering the data. Of course, having a data entry operator helps because he or she can at least enter the baseline things. When to enter data? At admission, then periodically updating it, and finally at exit. And it helps if the use of database is integrated with discharge, because this is the endpoint by which the data should be completed. And some units have also experimented it with using the database in everyday round, so that you can keep on updating every day, so that at the end you do not have to spend much time to generate the discharge and data is complete. And it also facilitates checking the quality if you are interacting with data on daily basis. And finally, if you have a database, use it to generate information. Use it to generate monthly perinatal reports, or the report which has to be sent to National Health Mission or to Government of India for birth defect reporting. So once database is there and you're using it only when you are deploying it to generate information to reports, then you know that what are the shortcomings, and then you know that what data has been missed, what data is incomplete. So these are the various things but one can use to implement a database. Now, what is information to action? So once you have database, then the next step will be to detect and understand unwarranted variability. By unwarranted, I mean, which is not because of random variation, not because of patients, different kind of patient mix. And then once you understand that variability, then you can do benchmarking. Benchmarking means that you look at the graph and see that which center is performing best, and then go to that center, interact with that center to find out what kind of processes they do. Do they have different practices? And then try to deploy those practices in your unit. And this kind of QA collaboratives have been helpful. And there are many reports, first from Western countries, now also emerging from India, which have shown that this kind of information to action process helps to improve quality.
Sorry
and
for
of
the
course,
your time is up.
yeah, last 2 minutes. So this kind of information to action also helps to conduct clinical trials. So this kind of information has been used to look at variability in early enteral feeding, to decrease antibiotic use. So this is an example of quality collaborative in Madhya Pradesh, in which 3 centers which participated in antibiotic use were able to reduce antibiotic by 1/3 to half. And this also helps in conducting multicentric trials. To summarize, collaborative neonatal database is the natural next step in the evolution of neonatal care in India. Web-based interface, integration with process of care, and including discharges and quality checks, it helps to deploy such kind of database, and analysis of information, benchmarking, improvement collaboratives, and clinical trials are the logical next steps. Thank you.
Thank you, Deepak sir. Next over there, close medics.
ಯಾರು ಬಂದಿಲ್ಲ ಅದು
ಇಷ್ಟದಾಗ ಮಾಡಿದಾಗ ನನಗೆ ಗೊತ್ತು ವೆಂಕಟ್ ಜೊತೆ ಇದ್ದ ವೆಂಕಟ್ ಸ್ವಲ್ಪ ಮೈಕ್ ಅಷ್ಟೊಂದು ತಿನ್ನಕ್ಕಾಗುತ್ತೆ ಮೇಡಮ್ ಚೆನ್ನಾಗಿ ಪ್ರೆಸೆಂಟೇಷನ್ ಯಾವುದು ಮೇಡಮ್
ಪ್ರೆಸೆಂಟೇಷನ್ 11:30
ಎಲ್ಲ ಆಯ್ತು ಅವತ್ತಿಂದ ಎಲ್ಲೇ ಇದ್ರು ನನ್ನ ಫೇವರ್ಟ್ ಇಕ್ಕಿದ್ರು ಕಳ್ಳ ಪೊಂಗಲ್ ನನ್ನ ಫೇವರ್ಟ್ ಪೊಂಗಲ್ ಮಸಾಲ ಸೂಪರ್ ಇವತ್ತೇ ಅಣ್ಣ ಇಷ್ಟು ದಿವಸಕ್ಕೆ ಮುಕ್ತೇನ ಅಂತ ಮಾಡಿದ್ರು ಇವತ್ತೇ ಮಿಲೇನಿಯಂ ಯಾರ್ದು ಯಾವ್ದು ಅಣ್ಣ ಎಂಡ್ ಮೈಕ್ ಕೊಡೋಣ ಎಲ್ಲಿ ಕೊಟ್ಟಿದ್ದೀರಾ? ಯಾರ್ದದು? LED ವಲ್ಲ ಎಲ್ಲಿ ಬೆಂಗಳೂರಾ? ನಾವು ಪರ್ಚೇಸ್ ಮಾಡಕ್ಕ ಅಥವಾ ನೀನ್ ಪರ್ಚೇಸ್ ಮಾಡಕ್ಕ? ಹೇಳಕ್ಕಾಗಲ್ಲ ಯಾವ ಇರುತ್ತ. ನೀನು ಮನು ಪಾರ್ಟ್ನರ್ಶಿಪ್ ಅಲ್ಲಿ ಏನೇನು ಮಾಡ್ಬೇಕು. ಮನು ಹೇಳ್ತಾ ಇದ್ದ ಮೊನ್ನೆ ಕೆಂಪನ್ ಸಕ್ಕತ್ತಾಗೈತಣ, ಹಾಕೊಂಡ್ರೆ ಬೇಜಾನ್ ವರ್ಕೌಟ್ ಆಗುತ್ತೆ ಅಂತಿದ್ದ. ನಿನಗೆ ನೆಟ್ವರ್ಕ್ ಹಂಗೆ ಅವನು ನೀನು ಮೋಸ್ಟ್ಲಿ ಮನೋರಿಗೆ ಏನಾರ ಚಮ್ಗಿಮ್ ಕೊಟ್ಟು ಏನಾರ ಮಾಡ್ತೀಯನ ಯಾರಿಗ ಗೊತ್ತು. ಇಲ್ಲ ಬೇಕಾದ್ರೆ ಅವನೇ ಕೊಡಿಸಿ ಬೇಕಾದ್ರೆ ಏನಂತ ಅವನು ಮಾತ್ರ ಮಾತಿಗೆ ಮರಳಾಕ್ ಹೋಗ್ಬೇಡ ಅಷ್ಟೇ ನಾನು ಹೇಳೋದು. ಏನ ನಮ್ಮ ಬುದ್ಧಿ ನಮ್ಮ ಅಷ್ಟೇ, ಬೇರೆ ಇನ್ನೇನು ಹೇಳಲ್ಲ. ನೀರಿಸ್ಕೊಂಬರ್ನ ಬೈಕ್ ಇದೆ ಮ್ಯಾಮ್. ಇಲ್ಲ ಅಣ್ಣ ಕೊಡೋಣ ಬೈಕು ಅನ್ನಿಸ್ಬಿಟ್ಟು ಟೈಮ್ ಮುಂದೆ ಹೋಗ್ತಾ ಇರೋ ಟೈಮು. ಮ್ಯಾಮ್ ಅಣ್ಣ ಬ್ಯಾಟ್ರಿ ಬೇರೆ ಮೈಕ್ ಕೊಡೋಣ. ಅಲ್ಲೇ ಕೊಡೋಣ, ಅವೇ ವರ್ಕ್ ಆಗ್ತವೆ. ಅದು ಒರಿಜಿನಲ್ ಮೈಕ್ ಅಣ್ಣ.
Any students here for free paper presentation, kindly proceed to Ebony Hall. Thank you.
ಅಣ್ಣ ಪೋಡಿಯಂ ಕೊಡು, ಪೋಡಿಯಂ.
During the oration, there won't be anything there.
PPT ಏನಿಲ್ವಾ?
Nothing. Everyone should be here. That's the importance of playing.
ಕಾಪಿ ಮಾಡ್ಕೊಡಕ್ ಕೊಟ್ಟಿದ್ದಲ್ಲ ನಿನ್ಗೆ ಡಾಕ್ಟರ್ ವಿಷ್ಣು. ನೀನ್ ಬೇರೆ ಸ್ಟಾರ್ಟ್ ಆಗುತ್ತಲ್ಲ ಇದು ಹೆಸರು ಹೇಳಿದ್ರೆ ಇರು ನೋಡ್ತೀನಿ. ನಿನ್ ನೇಮ್ ಕೇಳ್ತೀನಿ. ನಾನು ಕೊಡೋಣ ಯಾಕೆ?
So good morning, dear friends and dignitaries. Now we are starting some of the very important NNF sessions. The first session that we'll be starting is NNF oration. Tell you more about this prestigious NNF oration, may I invite our President Dr. Ranjan Kumar Bajawar to please be on the stage.
ಶೇರ್ ಮಾಡ್ಬಿಡು.
Good morning, colleagues, ladies and gentlemen. Good morning, members of the EB NNF. President 2022, Professor Siddharth Ramji. Senior members of the neonatology fraternity, Dr. Shashivani, Dr. MKC Nair, and all the guests. We come to an important session of the National Neocon, and that is the NNF oration. NNF oration, we have only one throughout the Neocon. So it is unique, and it is a custom to give it to a person who has dedicated his life, all his services to the uplift of the newborn, to the teaching, academics, research, and community neonatology service, all put together. As you know, we have very few people who have all these boxes ticked. And today we have an orator, I can say very confidently, whose CV, whose biodata, whose services over the last 4 to 5 decades fulfill all the requirements or achievements that are needed the NNF orator should have. And that is none other than Professor Vishnu Bhatt. We all know him. I will leave the official introduction of Vishnu Bhatt to our secretary, Dr. Dinesh Tomar. But we all know him. We all know the gentleman, Dr. Vishnu Bhatt. To be honest, I have never seen him angry. I have known him for about 30 years now. I have never seen him angry. I have never seen him raising his voice. He has taught so many of the undergraduate, postgraduate, and many fellows during his stint in JIPMER. He has been the dean. He has been the research section head. He has been, of course, the head of the Department of Neonatology Pediatrics. You will hear about it from Dr. Dinesh Tomar, but I feel that we are lucky to have him here, and we are grateful to him for agreeing to deliver the oration. His topic will revolve around avoiding perinatal asphyxia. Every newborn counts. Sir, we are very eager to listen to you. Please come and deliver your oration. Yeah, please.
As Dr. Ranjan has elaborated the academic brilliance of Dr. Vishnu Bhatt, I'll just tell his journey in this. It started from, this journey, academic journey started when he got the best outstanding student of his school and the best intern award. Then he has been appointed as senior resident, senior research officer, lecturer, assistant professor, associate professor, then professor and head department of pediatrics. And this journey started in 1979 and he was head till November 2014. He had been the professor and head of neonatology from November 14 to June 2018, and then he had been dean from Feb 2016 to June 2018. And he has been director from March to June 2018 and professor of pediatrics, PIM Pondicherry from January to December 2019. And from January 2020 onwards, he has been director medical research at AVMC Pondicherry. He has been training undergraduate, postgraduate, postdoctoral, PhD and DM students for last many years. He has 364 scientific papers and 62 chapters in books. He has edited a book on protein energy malnutrition and edited a book on NICU protocols with JIPMER, which was released yesterday only. He has been section editor of Indian Journal of Pediatrics and has been reviewing articles for various medical journals. His academic interest is pediatrics and neonatology and medical education. And research interest areas are perinatal asphyxia, neonatal sepsis, preterm and low birth weight, and neonatal nutrition, perinatal and neonatal mortality. He has thrice received the Best Scientific Paper Award by JIPMER Scientific Society. He has given various orations in various forums and was awarded Fellowship of NNF in 2014. And he has WHO Fellowship in Basic MCH Care from Nepal and Thailand, and WHO Fellowship in Neonatology at University of Illinois, Chicago, USA. So this was his CV, and I now request Dr. Vishnu Bhatt to please deliver his oration.
Respected present, past, and the future, the NNF office bearers, my dear colleagues and friends, seniors, and this is a great occasion in my life, not because of racial, but I could talk in front of you for some 2 minutes. So when I was contacted to give the oration, I was looking at what I should So some areas where we did extensive research, one in neonatal sepsis, another in intrauterine growth restriction and follow-up of low birth weight and preterm disease, and others is perinatal asphyxia. But as I was thinking, lot of calls were coming, sir, can I hold? Can I not hold? So I thought this is be the topic on which I should speak. So next few minutes, I will spend time on this. It is not so, as you know, HI accounts for about 30% of neonatal deaths in India and 30% of the babies with significant hypoxia will develop disability. And among severe asphyxia cases, 60% will become handicapped. I was putting the wrong direction. So these two examples of cases which you must know, because if first a baby of a 23-year-old primary gravida mother, hooked and immunized, delivered a term baby with perinatal asphyxia, no expected asphyxia in the baby. It was a male baby, 3 kilos. Apgar was 2/10, 6/10. Severe metabolic acidosis was there. He was resuscitated, he was ventilated, and he required inotropes and anticonvulsant. Discharged after 10 days, after 6 months, microcephaly and development delay. Many of you would have experienced similar situation where the baby has asphyxia. Parents will give sweet to you when they go home, but they will come back with the baby with the developmental delay. Second case, 25-year-old mother, almost similar, 3.2 kilos, no antenatal risk factor, delivered a baby, 3/10, 6/10 Apgar, metabolic acidosis, resuscitated, ventilated, again required inotropes, anticonvulsant. Discharged after 10 days, I was happy to see that the baby is completely normal without any neurological disease. So I was always wondering why this is happening, that some babies are doing very badly, some babies are doing very well. So although they had similar problems, but the outcome differed. So it was causing a lot of problems in seeing these babies days after days. And Jipmar, as you know, is a referral hospital. A lot of cases are coming in the last minute. And on an average, 1 or 2 babies will be requiring active resuscitation. Some of them will go to HAE. And as you know, most of these babies, they will have severe metabolic acidosis, low Apgar score, neurological abnormality, multi-organ dysfunction, to say they are HAE. Not all babies with asphyxia develop HAE. And if you take the incidence of HAE in India, it is about 0.5, in all over it's 0.5 to 2%, but in India very high, almost 14 per thousand lives. But in India, although it's one country, but the care is different in different places. So 90% of these asphyxias are antenatal or intranatal. So one should understand why these cases have different outcome, because if you look at the asphyxia event, initially there is something called primary energy failure, there is a latent phase, then there is a secondary energy failure. So in a primary energy failure, if you make some intervention, it is likely to help the baby. But once he reaches the secondary energy failure, whether you do cooling, don't do cooling, whether you give whatever you give, it is not going to work. So it all depends upon when you start treating the baby. So if you look at the hypoxic ischemia, you see that it's a significant anaerobic glycolysis, and it acts in different pathways like the adenosine pathway, that there is a decrease in ATP, the receptors, and also in nitric oxide pathway. But whatever mechanism it acts, finally there is a release of free radicals, and these free radicals are the one which causes damage to the brain and the multi-organ failure. And if you look at the organs, kidney is the most important organ which affects, with hypoxia affects. Almost 50% of the babies with moderate severe asphyxia will have some kidney damage from varying degree. Brain, cardiovascular, pulmonary, other systems, which is almost about 1/4 of them. Almost all organs in the body gets affected, but except for the brain, most of them do recover unless they have gone to severe organ damage. We do basic investigations like glucose, calcium, electrolyte, blood glucose, and glucose. These are usually done. Some you will do EEG, renal ultrasonography to see whether there is any abnormality, CT scan, MRI, and other investigation as needed. But they will and give supportive care to the baby. So some of them will recover, some of them will not recover, some of them will recover with the neurological deficit. So we were wondering what to do. So I was getting MD students, DM students, PhD students. So one after another, I was looking at the hypoxia in the various levels. So initially looked at the myocardial function, nucleated red blood cells, renal parameter, oxidative stress, renal excretion of protein and uric acid biomarkers, DNA damage, all these things we have studied. If you look at them in ECG and echocardic changes in the normal babies and hypoxia babies, many of them do have cardiac changes, and almost 40% of them will have over grade 1 ECG changes, and grade 3 will be less, but many of them do have myocardial damage. And other things, when you do echo, you will find tricuspid regurgitation, right ventricular hypokinesia, left ventricular hypokinesia, and almost 70% or 2/3 of the infant with moderate severe asphyxia will have some myocardial damage, but most of them do recover. We looked at the myocardial damage, and 30% of them babies had myocardial damage among them, and many of them who have died, the 30% deaths did have, almost all of them had myocardial damage. We also looked at myocardial enzymes like troponin and CMP level, the myocardial fraction of the creatine kinase, and all of them are increased in hypoxia, and cardiac troponin has got much more sensitivity and specificity to detect myocardial damage, and ECG and echo changes together, as I said, they were come to normal once the infant recovers, and cardiac troponin has got a better predictor of the outcome. We also looked at nucleated red blood cells. In the peripheral sphere, if you look at the nucleated red blood cells, it indicates less and more RBCs. And if you look at the nucleated red blood cells from mild to severe asphyxia, if you take from controls will have 3 to 4 nucleated red blood cells per 100 WBCs. And if you go to the severe asphyxia, it will be more than 10 RBCs. And stage 1, 2, 3, you see as the stage hypoxia increases, HA increases, the nucleated red blood cells increase. And if you look at only the expired cases, it is very high. So if you look at the nucleated red blood cells, that also will tell you whether the baby will have good outcome or bad outcome. You look at the urine MDA, the malondialdehyde in the urine, creatinine, uric acid, and protein. If you look at this oxidative stress, you will find it is markedly increased in those babies with hypoxia, and we can predict mortality based on these various levels. So if you look at the urinary protein, uric acid, and MDA level, they controls and cases, the cases it is markedly increased. And we also looked at other things like in the babies, the oxidative stress, the MDA level and protein carbonyl in the blood also, not only in the urine, but all these are done in cord blood without actually removing blood from the baby. In the asphyxiated babies, along with other investigation, we took blood at 48 hours also. If you look at the melandialdehyde level and carbonyl level, protein carbonyl level, they are markedly increased in cases when compared to controls, and the expired cases will have very high values. Based on these levels, we could predict outcome. So predicting the outcome is something you are only telling the end point. We are not doing anything to the baby. It does not help really improving the condition of the baby. We also later looked at other things like the renal functions. If you look at the renal function, urea, creatinine, electrolyte, and also beta-2 microglobulin. We did both in the urine as well as in the blood. The beta-2 microglobulin was estimated in the urine. If you estimate the beta-2 microglobulin, it shows markedly increase in hypoxia, and it also correlates with the outcome. All 9 babies in that small series who expired had renal damage. So using these various parameters, since the president told me I have to cut short my oration, so I'm going a little faster, but since these are very basic. So urea, creatinine, uric acid also you estimated, and they are significantly different when compared to the controls and hypoxia. The controls are the normal babies, cases are the hypoxiated babies. So the beta-2 microglobulin has got much more sensitivity and specificity to predict the outcome when compared to the other parameters like urea, creatinine, uric acid. So these hypoxiated babies have myocardial damage, they have renal damage. Of course, the one thing which persists with them for a long time is the neurological damage. Then I got a PhD student, so I told him, why don't you look at the chromosomal damage and the DNA damage in hypoxia and see whether it is affected, so that why these babies are not recovering from the hypoxic stress we wanted to see. So we did what is called as comatase. Comatase is nothing but it does not require cell culture. You have to separate the leukocytes, you have to lysate, electrophores you apply, then counterstain and see how much DNA damage is there. What happens is in a normal cell, the DNA will be within the cell. Even if you put electrophores, the DNA will not move. But in a hypoxiated baby, when the damaged DNA will move away from the cell, so you will find something like a tail. So that's called comatase. It looks like a comet. So the damaged DNA was the anode it moves, and also the longer the tail of a cell, or the bigger the comet, more DNA damage. So we calculate by the microscope, the computerized microscope, you calculate, it will give the reading like the head size as well as percentage DNA in the tail. So if you look at the first one, the control case, which is a round cell, it's a normal cell. In a mild asphyxia, moderate asphyxia, severe asphyxia, if you see, the tail becomes longer and it looks like a bigger comet. So the bigger the comet, the more severe is the damage to the baby. So we did the comet tail length is a micrometer, that's a percentage DNA in the comet tail. The controls and cases, if you see, there is a smaller head, longer tail, and more DNA will be in the tail. And if you see the HA1 and HA3, there will be significant difference. So there is a significant chromosomal damage in cases of hypoxia. And this is called micronucleus. So in a biload nucleus, there is a one small nucleus. You see below in the center one, you see the third one, that's called micronucleus. Micronucleus indicates cell death. So the more number of cells have micronucleus, that means the cell has already died. Yes, you know, the brain cell, neurological cell, neural cell or brain cells, they do not recover on their own. See, once it's damaged, it is damaged permanently. That is the basic problem. So this micronucleus core, what we found is more when there is more convulsions, more severe degree of hypoxia. We also looked at the karyotyping and chromosomal damage, whether this also another finding which you are looking at. And if you look at interchromatin damage will be there, interchromatin will be there, ring chromosome, dicentric chromosome, all abnormal types of abnormality you will see. And these are seen in severe asphyxia cases. If you take their blood and look at this, you will find this damage. That is why hypoxia babies which are affected severely do not recover after they go to the irreversible level. Now, I was not getting sleep because all these babies are coming. The parents will come, they will stand in front of your room, they will start crying. Then you also feel like crying. We don't know what to do. So by the time this therapeutic hypothermia attracted our attention, then we started looking at therapeutic hernia. So all my DM, MD and PhD students work on therapeutic hypothermia one after another. So why I got interested in this? Because if you look at the therapeutic hypothermia, unlike other modes of therapy, it acts at multiple levels. It acts on anaerobic glycolysis, it acts on the glutamate level, NMDA receptors, it acts on the reduce the oxidative stress and nitric oxide mechanism. So it acts at multiple levels. It is not at single level, it acts unlike other modes of therapy. So as you know, it is very important in the therapeutic hypothermia, you induce hypothermia in a very rapid way within half an hour to 45 minutes, 1 hour, maintain the same temperature, 33 to 34 degrees for 72 hours, then gradually rewarm almost about 8 to 12 hours, or you should, the longer you take for rewarming, the better it is. Many times what happens, the people will cool, they will say 72 hours over, they will switch on the warmer, the baby gets heated up. Whatever effect you have got of cooling will disappear if you do not rewarm them very, very gradually, because it causes severe oxidative stress, vasodilatation, and creates more problem. So rapid cooling, maintenance, gradual rewarm. This you must understand when you do cooling in the baby. So initially we did not have any cooling devices. So I sent one of my students to CMC Vellore. By the time they started cooling, she stayed for 1 week there, and I also went with her, and we looked at what they are doing, and we were using the gel packs which we use in the vaccine carrier. These gel packs should not come in the direct contact with the baby's skin, otherwise it will cause skin damage. You have to cover with cloths, and that should be kept by the side of the baby. If you have about 3 or sometimes 4 gel packs, you can cool the baby within about 45 minutes, 1 hour. This should have a rectal probe, this should have a skin probe, so the temperature is continuously monitored. In addition to the multi-parameter monitor will monitor the heart rate, respiratory rate, and oxygen saturation. So whenever you set this thing, as you know, in the multi-parameter, it will give alarm. So it will tell the people, yes, yes, I am going wrong. So you have to see what is happening. So initially we randomized this hypoxia baby, moderate severe asphyxia, and then we started cooling, and then we started looking at it. The first study, we found almost 21% better outcome at 6 months of age, which is death as well as neurodevelopmental outcome, which we did at 6 months using the DASI score. And in the asphyxiated non-controlled babies and hypothermia babies, we found difference of almost 21%. Everybody was puzzled. I was getting calls from UK, USA. How you are getting such good results? The reason is that we did not have very, very severe asphyxia babies in this this thing, because we did not have enough ventilators that time. We could not ventilate them. So those were very fixed. We could not randomize them. So it will be moderate and severe asphyxia who are not very, very sick. So the outcome was very good. We followed them up for 6 months and looked at the outcome. You look at the developmental score, developmentally pass level at 97% pass level. All are better in hypothermia group compared to non-hypothermic group. Even impaired hearing, impaired vision were less, but they did not reach statistical significant level. So when you look at the combined outcome, it was markedly different in the cooled babies when compared to uncooled babies. Even the number of convulsions, anti-convulsant also were less. So next student, I asked him to look at the oxidative stress, because we found that oxidative stress markedly increased in hypoxia, whether it comes down with cooling or not. So he again did a randomized study to look at the MDA level and antioxidant status. What happens that as the oxidant stress increases, the antioxidant status level comes down and MDA level, which is the oxidative stress, goes up. So this side you have hypothermia, that side you have normothermia or controlled babies. And at the beginning, if you see, they are almost similar in both oxidative stress level as well as antioxidant status. As the time passes, they have significant difference. The oxidative stress increases in the babies with control, and in the hypothermia baby group, it comes down. So it is not that hypothermia just acts at that. It prevents further damage. Whatever damage has occurred to the brain, it cannot reverse as such, but it can prevent further damage. This we should understand, that hypoxia is not that thing 1:1. It is little different, which we should understand. And oxidative stress as well as oxidative stress are markedly comes down in the hypothermic group, and that is one of the mechanisms by which the better outcome is there. So next, the PhD student came. So I told you, follow them up for 24 months, because everybody says you are followed up for 1 year discharge, you are followed up at 6 months. So we want to follow up for 2 years and see. So he looked at the DNA damage, he looked at the oxidative stress, and then he followed them up for almost 2 years. So if you look at the tail length of the comet, it is markedly increased as the time passes. You see that the base level that is about 38.11 and 38 is the control. And as the time passes, hypothermia babies do not have increase. They are almost same, whereas in the control group, it keeps on increasing. That's what I'm trying to say. If you do not cool the baby, you allow them to go further damage, continued damage, and then you will see the end result. And if you look at the DNA in the tail also, it keeps on increasing in uncooled babies. With cooled baby, it remains stationary. So therapeutic hypothermia definitely prevents further damage to the baby, but it may not reverse what has been done. So if you already cooled the baby in an advanced case or a sick condition, it is not going to improve. This is a bar diagram showing the DNA damage in the cooled and uncooled baby. The red one is the uncooled one, here blue one is the cooled one at 36 hours and 72 hours. You see, it's almost 1.5 to double the time of DNA damage at 72 hours. We correlated at 18-24 months the tail length along with the mean developmental score and also mental as well as motor development score. And if you see, as the tail length increases, the developmental age comes down. Similarly, the mental development, motor development, if you look, similar changes takes place. So therapeutic hypothermia reduces oxidative stress and DNA damage. Therapeutic hypothermia improves the neurological outcome at 18 months among the survivors, and DNA damage, the oxidative stress, had a significant negative correlation with the developmental age and development course. So we also looked at renal function because many people were telling you reduce the dosage of drugs when you cool. It is not for cooling you are reducing, it is because of hypoxia, because in hypoxia there is renal damage. So if you look at the babies with cooling and non-cooling, the renal damage is almost double in the uncooled babies when compared to the cool babies. We also looked at the myocardial function in the cooling and non-cooling, and if you see the ECG changes, echo changes, enzyme levels are significantly different between the cooled and uncooled babies. So it will keep improving the condition of the baby because it prevents further damage. We also looked at the fluid management in perinatal asphyxia. Many people say that you reduce the fluid in your treating perinatal asphyxia. But what happens is that if you reduce the fluid, many of them have mild increased serum sodium level, and also the renal function is slightly altered. So what we thought suggested is that you treat all hypoxia babies like a normal baby, normal maintenance, but keep monitoring their electrolyte and fluid load. And if there is any problem, then you should test. There are many things which people are trying, which are tried, but what I'm trying to say is that these may work as an addition to therapeutic hypothermia. They can never substitute to therapeutic hypothermia, which we know at present. We may find a better alternative for the therapeutic hypothermia days to come. I'm just quoting two systematic reviews. One by this is with magnesium sulfate. We try to look at addition of magnesium sulfate to therapeutic hypothermia and see whether it improves the outcome. So if you look at with the magnesium sulfate, without magnesium sulfate therapeutic hypothermia, because by this time when the HELIX trial started, we stopped randomizing to non-cooling arm because I was feeling guilty of continuing studies because it was found definitely it's beneficial, and if you're doing more harm to the baby by not cooling, I don't think ethically we are justified. This I told Sudhin also, don't do this study because already it is proved and it is unethical to not cool the baby, but people do not listen when you talk. So if you look at the magnesium sulfate and without magnesium sulfate, slightly they are better. But what happens is that when you give magnesium sulfate, there is severe respiratory depression, sometimes sedation. So the benefit which you get, you have to work very hard to get little benefit. So that is one of the problems. Now you may ask me, therapeutic hypothermia is safe, so can I cool everywhere? Can I cool every bed? No, they have complications, but most of these complications are common to hypoxia, whether you cool or you do not cool, except sinus bradycardia and the skin changes. Skin changes mostly we were finding when we were cooling with the gel pack. After we started the cooling with the biracradle phase changing material and servo-control cooling, this problem was not there. If a baby does not have bradycardia during cooling, that means you are not cooling properly. Or if he has got tachycardia, most often the baby will be either having infection or he will have shock. So you cannot have a cooling baby with a tachycardia. Tachycardia means there is some problem with the baby for which you should look. So we looked at the cooling arm and uncooling arm, except sinus bradycardia. None of the changes are significantly different between the groups. This is published by Dr. Sita Sankaran. So they say that if you have to have a normal outcome, 6 babies have to kill 1 normal outcome. Yeah, it is true because not all babies will improve completely in schooling. Jacob et al. And the systematic analysis was published in 2013 Cochrane review, which says that cooling should be done in hypoxic wake because the short-term damages or problems will outweigh the long-term development outcome. Beth et al. He has published in 2021 the therapeutic hypothermia for low middle income countries, and it is definitely beneficial. That was the conclusion drawn from the study. Then we compared this HELIX trial and Sudhin Sadhu's trial from Calicut with other studies available. This first but is not me, it is another bird from Kashmir. So in all the studies except the Sudhin studies, the mortality is less in cool babies. So I told him, say, only in your study, the mortality is high. You should explain why your mortality is high. And if you look at the neurodevelopment outcome, even the helix trial has a better neurodevelopment outcome among the cool babies compared to uncooled babies. I'm not criticizing anybody, but whenever you talk, we should have the patience in our mind. And if we do anything damage, what we have developed over 10 to 15 years in India, and all one stroke of pen, if you can undo that, is a more very dangerous thing. And I am sure that in this hall, there are several people who have cooled and they have their own experience. They may not have done randomized control trial, but they have their own feel. So some of the problems which I noted with the helix trial is that 70% of the babies were 70% of the babies were outborn. What happens in outborn babies? None of our JIPMA studies, babies were outborn because we never used to get the babies within 6 hours. Even if you get, they do not have any details of what they have done during delivery. See, sometimes you say oxygen. Now Ramji is there. So you say oxygen. Keep on giving oxygen. The more oxygen you give, it causes a reverse problem. So controlled oxygen should be given. So whatever you do, it should be controlled. See, even Amrutam will become poison if you take it in large amounts. So you should be very, very careful. Many of these babies in the helix trial, only 10% you see had quadruple pH, and high proportion of the baby having convulsions and 80% of them having white matter damage. This indicates that these babies did not have proper care at birth. They were not looked after properly. They came and you put them for randomization without seeing the condition. I think that is a major problem in this study. There is no mention about intrapartum fetal monitoring or transport or monitoring during transport. See, the moment care at birth, resuscitation, proper care, proper maintenance of temperature, proper transport if you don't do, you do cooling, this is what is going to happen. You will have more deaths, more problems. Yeah. Now, should we offer therapeutic hypothermia to our babies or not is the question. So it should be offered according to me, whether you want to believe or not, it is your destiny. So within 6 hours, if they come, you can cool them, provided they have metabolic acidosis, they have significant encephalopathy, moderate, severe encephalopathy. Do not wait for convulsions. Some people wait. Okay, it is not yet moderate, it is mild, it will recover. Then suddenly you will throw convulsion, you will become very sick. Then you say, okay, now I will cool, the outcome is bad. So you should try to pick up these babies. These babies should be carefully monitored. The moment they have moderate hypoxia, HAE, they should be cooled. But it should be done only in centers where they have facilities. Now, NNF guidelines also says 1:1 nurse. I think in 100 years, you will not get 1:1 nurses. So you also should be realistic to the situation. It cannot be, the rules cannot be made out of context. You should have good neonatologists, you should have nursing staff, you should have cooling device. If the cooling becomes lower, you should be able to bring up the temperature by warming, and you should have mechanical ventilator, APG machines. All these things should be available. In addition to that, you should have a protocol to whom to cool, whom not to cool, and you should follow them up. And I suggest that we record all cooled babies, see what happens to them after 2-3 years, and then show the results, compare with what has been seen. So to conclude this oration, the take-home message will be that perinatal anesthesia is an important problem. Those who are doing in the private hospital, probably you may not face that much problem because good antenatal care, good delivery care is there. But it is a very, very sad thing to happen in many other centers. Oxidative stress and DNA damage is a very, very important mechanism by which causes damage. But our aim should be to have good antenatal care, you have adequate monitoring facilities, proper delivery care, and if any untoward incident occurs, appropriate transfer facility should be available. So aim should be to prevent hypoxia, not prevent hypoxia, because we have not understood fully how hypoxia occurs. What happens, as the cases I have told in the beginning, they were almost normal baby. Nobody has expected any problem, but problem occurred, and one baby became normal, another became abnormal or neurodevelopment
Any further changes?
delay. So definitely therapeutic hypothermia reduces both mortality and morbidity and better outcome. So be assured that it will happen. If anybody has got doubt, anybody is not convinced,
Just check in that.
I am not in JIPMER now, but I can arrange for a training in JIPMER or any other center where they are doing regular cooling and get a train and do well. And my best wishes to you all and also the future babies of India. Thank you very much.
Thank you, sir. Thank you for your brilliant oration. You have taken us to the journey of perinatal asphyxia, the understanding of it, the research, and one of the important modalities, therapeutic hypothermia. You have said that research can be double-edged sword if the methodology is improper. And one of the best messages you have given is when elders and experienced people speak, listen, not just hear. Thank you very much, sir. Of the outstanding services rendered for the cause of the newborn care, Dr. Vishnu Bhatt is being honored with NNF Oration 2021 at the 40th Annual Convention of the National Neonatology Forum held at Bangalore, 16th to 19th December 2021.
This is a citation that NNF is giving to sir. It says that the president, secretary, members of the executive board, and all the members of NNF of India have the great pleasure and feel honored in awarding this citation to Dr. B. Vishnu Bhatt, Director Medical Research, Professor of Pediatric and Neonatology, AVMC Pondicherry, on this day, 18th December 2021 at Bangalore, Karnataka, India. This citation is awarded for his dedicated services in the field of newborn medicine and his achievements in the field of medical education, research, and scientific publication. He has kindly delivered the NNF oration.
I am greatly honored. I thank you all for your love and affection. And nothing, no credit goes to me because these were work done by my students, both MD, DM, PhD students. I was only guiding them and helping them to learn. So I am not, I should not take credit on my own because everything is not done by me itself. Thank you very much. Thank you.
The second important event of this morning and of this NeoCon will be the awarding of the Lifetime Achievement Award for 2021. And that will be awarded to Dr. M.K.C. Nair. As he is popularly known, MKC. Dr. MKC Nair is an evergreen person. He is an evergreen person, humble, sitting in the last but one row. You can notice, and he has done so much work in the field of pediatrics and adolescent health. Dr. MKC's achievements, his work, his research goes across the age groups, from newborns, children, adolescents, and his capacity to interact with the adolescent children, which is a very difficult age group, and the rapport he develops with the parents, the paramedical workers and nurses is unmatchable. He's a friend to every patient he treats. And why I said evergreen is, beginning of the year, I called him and said, sir, we want to do a module on DETECT, that is early detection of developmental delay in newborns and infants. We want your guidance. He was so happy, he immediately accepted it, called Naveen Jain, his disciple, and arranged for the module, and all the 20 programs. He was there promptly at the beginning of the program to share his views and say a few words. Dr. Dinesh Tomar will go through his work in detail. As you know, Child Development Center, everything will come in that. What I can say is, he has probably done work of 2 to 3 lifetimes of pediatrician. He is the only one of the very few people who have become the president of IAP, president of NNF, and vice chancellor of a health university. Over to you, Dinesh.
It's my privilege to read the CV of Professor Nair, but I've cut it down to 10%. Because it runs in many pages and we will take a lot of time. Professor Nair is a true leader in both his vision and actions. Very early in his career, Professor Nair had recognized the social, economic, and cultural value of child development in nation's life. He relentlessly worked toward developing new scientific tools and innovative training methods for over 2 decades, and is now globally acknowledged as a pioneer in the field. Trivandrum Developmental Screening Chart, TDSC, is one of such examples, which has been the backbone of Child Health Program, Rashtriya Bal Swasthya Karyakram, RBSK. Professor Nair, who has a long research career with 173 national and international journal publications and 22 books as author editor, took several decisions in his professional career where outcome was uncertain. CDC, or the Child Development Center, was his dream, which is now considered a national asset for research, training, and teaching in child and adolescent development. With 25-year follow-up of low birth weight babies, leading to award of the first Doctor of Science DSc degree awarded to any medical person in 80 years history of University of Kerala. His 41 years of counseling experience helped him immensely in establishing student guidance and support program in all colleges during his latest stint as Vice Chancellor of Kerala University of Health Sciences. Professor Nair has established national benchmarks in the process. Professor Nair has been elected Fellow of National Academy of Medical Sciences, Fellow of National Academy of Medical Sciences, FAMS, in the year 2020. Currently is working as a Director, NIMS Spectrum Child Development Research Center, NIMS, Trivandrum. He has been nominated as a member of Board of Management at Nurul Islam Center of Higher Education. Professor Nair is a National Authority in Developmental Pediatrics and Developmental Adolescent Pediatrics, and annual conference of both academic bodies have oration in his name. His CV is large, but one interesting thing I found is he's a man with 1 undergraduation and 10 PG degrees. He's a PhD, he's an MD, he has MSc, he has MBA, he has MA Philosophy, MA from FNNM, FIAP, FICM, FAF, and a lot of other degrees he's having.
Sequence run by me.
He has developed and validated published 11 screening tools, provide research based to 2 Government of India national program RPSK and RKSK, developed 2 specialties, developmental pediatrics and adolescent pediatrics. New courses initiated at CDC were 8, and when he was the Vice Chancellor, 12 new courses. He has 12 national awards and 13 orations. Community activities include Lifetime Achievement Awards of both IAP and IMN. Today is the 3rd one from NNF. He is Editor-in-Chief of National IAP Textbook of Pediatrics. So there's a brief CV of Professor MKC Nair. And we'll allow felicitate him, then I will request him to say a few words.
Okay. He will run his own slides, but we can run if we need to. Dr. Chilani, we have to do everything. We have to run his PowerPoint. Suman and mine, we will do it from here. We can do from there, no? Suman and mine.
This is main laptop. This is backup.
Don't copy, because this Suman Rao, you copy from there. Then we will do it, because Suman Rao is doing the presentation. Copy.
Main operating laptop is there.
This award reads NNF, the President, Secretary, Member of Executive Board, and all the members of NNF India have great pleasure and feel honored in awarding this Lifetime Achievement Award to Dr. MKC Nair on this day, 18 December 2021 at Bangalore, Karnataka, India, for dedicated service in the field of newborn health, developmental and adolescent health, medical education, administration, research, and scientific publications. His contribution to healthcare and humanity in general has been immense.
No, put it in this one. No?
Any postgraduate, please come over. One postgraduate, please come over.
From here,
Anybody,
to this tenant.
quickly. Don't waste time. Any postgraduate. I'm running.
No, just wait.
Wait.
You go and put it there.
No question, no nothing. Come. Better come.
No, go back. You sit down.
Running.
Put the mic on. You can put the screen back.
Okay, this bouquet is the Gayatri, the future of NNF.
Good morning to all. Must thank the whole NNF for bestowing this honor on me. I was not traveling because of some post-COVID problems. But this is the first time in the last 2.5 years that I have come out of my hometown, because Ranjan is so precious to me and our relation is so precious. So dear Dr. Ranjan, Dr. Ramji, and the most energetic Thoma, okay? I must thank 3-4 group of people in my journey over the last 40 years. My students who always give you energy to learn new things. My nurses who always be part of you. My teachers or gurus who have given me the guidance. And most important, my patients, and my patients are too small. So they are mothers who actually are the knowledgeable person. They may not be able to say 95% confidence interval. They may not be able to say p-value, but they give you a lot of information. If you are willing to listen to the mother, they teach you a lot, just like this. If I run through my journey, this is only to remember some of the teachers who made me what I am. 1975 at CMC, my first teacher in neonatology was none other than Dr. S.K. Mittal. He was there for 1 year, civil service in Delhi. And then that was in CMC Ludhiana. And 76 to 79 again in CMC, Dr. Rajarani Pava, who was trained in England, and she was well trained in neonatology. She taught me 80 to 82 at SAT Hospital, Trivandrum, by Professor Sabrinath, who probably is the first board. He could not get certification because that came later, but board-trained neonatologists in India. Then, of course, community neonatology and simple techniques was taught by Dr. Padma, and later I became in charge, and we could reduce the neonatal mortality by 50%. 87 August 1st, I started the CDC project, and the first thing I did was 2 trials proving that N-cephabal is not good for my M.Ed science in research methodology, and proving beyond doubt by an RCT that early intervention is effective. 91, I had the good fortune of organizing the National Neonatology Forum, apart from 83 National Perinatology Forum. This one, why I'm saying this is now perinatology is coming back again. I'm so glad obstetricians and pediatricians coming together. 95, we had the first batch of clinical child development. So far, we have trained 120 girls with 2-year diploma, PG diploma in clinical child development. They are the person who helping us. Now, because it is an all India program, I have developed a program called Developmental Nurse Counselor for Neurodevelopment Chapter. First batch has just passed out. Next year, 15 centers will be given this, even more centers willing to train, because nurses have all the basic knowledge. You just teach them, because none of us can do the neurodevelopment follow-up without the help of somebody. And then, of course, I was the founder, secretary, and president of NNF Kerala. And Dr. Guha, I must remember, he nominated me to the governing council. In the community program, every Saturday, Sunday was for either NANS, breastfeeding, immunization, ORS. And that's why after retiring from the Vice Chancellorship, I said, I'm not going anywhere. I'm going to be with my family because I have my grandchild who will miss me. But now recently he told me you should have been Trichy. I said, what happened? Every week when you come, you bring me toys. Now you don't give me anything. So that's also important. She preferred that going to Trichy. 2010, we published a high-risk newborn book with Dr. Naveen. And I think that is going to be updated, because that tells you where exactly what Sir was giving the oration. Same thing. Where exactly is the neurological damage? 11-12, I became the NNF national president. NNF has already honored me with oration as well as fellow NNF. I must remember all the people who have helped me to achieve that one, and particularly Dr. Gambhir, my secretary, who actually revamped the NNF into a different mode, little more professional, brought in UNICEF in a big way. We use our office for the first time. Otherwise, it was in some college. So that whole lot of change Dr. Gambhir has brought in. 87 to 2019, 25-year follow-up of the low birth weight babies. That has led to the Doctor of Science. Probably 2 or 3 persons in India have got it. Proving the Barker hypothesis. In one way, I'll tell you what we have proved. If you know the birth, it is only for the SGA babies who have, not all low birth weight. SGA babies who have rapid weight gain in the first year, who has, and if you have, so that means you have birth weight, 1 year weight, and 15-year or 16-year height, weight, BMI. You can predict. If you add cholesterol, low density cholesterol, it doesn't have any advantage. So it has a lot of community importance. This is also the time to remember my gurus. I can't remember everybody, name everybody, but at least a few of them who are not so active now. Dr. Ayan Baku, epitome of simplicity. You know, I never seen a teacher more simpler than that. Dr. Mehban Singh, for his clarity of thought in writing. Dr. Santosh Bhargava, the most flamboyant man on earth I have seen. Okay, and then you have our own Dr. Sachivani, who taught me the community. Dr. JM, who actually did the Kanchipuram project, you know, which showed for the first time that without high tech, you can save a lot of babies. You have Dr. Amida Fernandez, you have Simin Rani and all who have really done so much of community. And my guru, Dr. Anand Pandit, who actually taught me Bailey scales and Dasi and all in 1982. Okay, so that's the first time I spent a month there, and the examining, all of us are using Dasi, but I think we need to remember who made it. That's more important, you know. And Madam was literally, my examination for Dasi was more difficult than MD exam. That's what I remember. Finally, of course, I must remember Dr. Ranjan Pejawar, not because he gave me the award, but because of his, my association with him for last so many years, doing many books together and in the Perinatology Journal, a fantastic editor. And I will say who is my waris. In Hindi you call waris, Pingami in Malayalam we say. It will be Naveen Jain, because whatever philosophy I have taught, whatever I said, he will, like a litmus paper, he will take it. And he is taking it to great heights, particularly among hardcore neonatologists, because I cannot penetrate so much as he can penetrate, because all are DM colleagues, and he has taken early detection to height. And the last word I want to say is, for 30 years I have been talking. In fact, I was feeling ashamed to say again and again, 2 months, visual, or 2 months, that early, 4 months head holding, 8 months sitting, and 1 year standing. Okay, but it is he and Dr. Ranjan who made it into a detect program and made it available to the whole country. So, and Naveen has also helped me with the Illingworth's developmental book. Of course, he has done other books also. So, to the end, I will say it has been a long journey, all not so happy, but forget about the unhappy events. Only remember the happy events. Forget about those who have come in your way. Remember only those who have been with you, your partner. Thank you. Thank you so much.
I think sir needs a standing ovation.
So you agree with me? This is a fantastic morning. We have had two very important events, the oration and the Lifetime Achievement Award. We have the third one, which is equally important. That is the WHO UNICEF plenary. For the first time, WHO has actively been involved with the NNF. UNICEF has been more visible. UNICEF has been our support, our backbone for all our activities. So this is a joint plenary session of UNICEF and WHO. It will be moderated by none other than Professor Siddharth Ramji, who has taken over as the president and who will start functioning from 1st of January. He needs no introduction. He's an astute clinician, brilliant academician, keen researcher, and an able administrator. That shows that he's a great all-rounder. And we NNF, we are fortunate for him to be the president. So may I request Dr. Siddharth Ramji to take over. He will introduce the moderators, panelists or the speakers and conduct the session. Thank you.
Thank you, Dr. Ranjan. I think we all realize that what you've heard this morning from two eminent persona, Professor Vishnu Bhatt and Professor N.K. Nair. While a great deal has been done to save newborns, what is very important is to have intact survival, which boils down to say that we do many things, but unless there is a quality part of it, it's not going to help you survive nor thrive. India has done, if you look at statistics, should say we have done remarkably or reasonably well. We look at mortality figures coming down. We also know that there will be many states and districts in this country which will not meet the INAP goals for mortality by 2030. But even where figures are close to or below the target values, when you go and visit, it pains us sometimes when you see quality issues being obviously, blatantly visible, and it causes concern that what will happen to this child in the future. So like most developed countries, India too is in that crossroad. A mortality comes down, but you have to work to improve the quality of life thereafter. This session, which is jointly supported by UNICEF, WHO, to assist all of us, the Government of India, to move in the direction. We have put together a panel of experts who have been good in their own field to share with us what they have done and what needs to be done for all of us to move to the next stage. We have 4 panelists who are online, 4 panelists here. Some of you may have seen the brochure order. I'm going to make a departure because 2 of our panelists would have to leave. So let me begin. The most important thing for survival is to ensure the baby is fed early and gets human milk. We have heard this so many times. We also know that our breastfeeding rates are what they are, and how do we make it better? And how do you achieve ensuring that babies get breastfeeding within the first 30 minutes or 1 hour? I have the pleasure of inviting Professor Vani. I'm sure Dr. Vani needs no introduction to this audience. She has spent all her lifetime telling us that these are the simple things that need to do if you have to move forward. So, Professor Vani, to share with us about the promotion of mother's own milk and early initiation of feeding. Professor Vani.
Thank you very much. The subject is very important, but time given is very short, so I'll just quickly highlight some of the messages. Okay, now breastfeeding importance, I don't have to say in this august audience. All of us we know, but we find that we know a lot, but when it comes to immediate application, it has been very poorly done. I'm not satisfied with what we've done. So promoting mother's own milk, that is, everybody is now talking about it. Next one, please. Next one. And we have been working with this mission statement that mother's chest is the best place for the newborn care, mother's milk is the best nutrition for the baby, and zero separation of mother and her baby as much as possible. At least if these three principles we keep in mind, we will be able to save a lot of babies in our country. That is for sure. Next. And we know breast milk is good for the babies, but it is much more important for the preterm and fragile babies. That is the one message we want to give. So mother's own milk is good for even preterm babies, where a lot of formula are being prescribed and a lot of top feeding is being given, and that myth we want to demystify here. And second, why it should be early and how it should be done. These are the few messages we will give here. Next, please. All of us, we know why it is important, that there are so many important biological factors in mother's milk which cannot be reproduced in the artificial milk, and that is the importance. I won't go in for that. And you know, by giving that, we are able to reduce several infections and several complications in preterm babies, including ROP, necrotizing enterocolitis, and many other complications. Next, and it has got so many evidence-based suggestions now that it is babies experience less stress with mother's milk, less episodes of oxygen saturation, less temperature instability, and so on. There are so many attributes we have to realize, and we have to make it as a mission statement that we will promote as much as possible mother's own milk. Now, direct breast milk may be possible in few babies, but at least express breast milk, and then it could be donor's milk and several other things I won't go into. Next. And why it has to be given early. So we know first few hours, the baby is very alert. So naturally the suckling can start immediately, whether the mother is getting milk or not, but the suckling itself will stimulate milk production, and that will start the story of successful breastfeeding rate later on also. Colostrum feeding is very important. All of us, we know colostrum is the best first nutrition and first vaccine. And now even in extremely preterm babies also, they are introducing the technique of colostrum swabbing. Just a few drops of colostrum in baby's milk, mouth, even that will stimulate various production of immunological factors. So all these techniques also we have to learn, and less chance, and early feeding, naturally less chances of hypoglycemia and its further complications. These are the few highlights. Next. And as early as possible, it should be started in all the hemodynamically stable babies with normal gut. And of course, there are few situations where it may have to be delayed. But sometimes we exaggerate these situations without thinking the moment it is low birth weight baby, immediately the prescription comes. So that story should end. Next. And naturally it depends on the suck, swallow and breathing coordination. All that I want to say here is generally we go by the gestational age or the weight criteria. But in our country, we have to remember we face a lot of small for day babies, IUGR babies. So we will have to individualize the approach. Some of the babies may be able to have this coordination much earlier, and we should be able to promote direct breastfeeding also, or even oral breastfeeding by express breast milk also much earlier. So we have to individualize the criteria. These are just the guidelines. And there is no place for bottle feeding in our setup. That is for sure. It has got so many adverse events. Next. Next. Yeah. So some of the modalities all of us know. These help us in promoting early breastfeeding. So non-nutritive sucking for the very preterm babies who may not be ready for direct breastfeeding. Next, and similarly, minimal enteral nutrition in babies who are already on gavage feeding, that also helps in successful breastfeeding later on. Next, so these are all certain theoretical, because of the time constraint, I'm going fast. Next, please. So we know some of these theoretical things, but when we translate into action, some of the simple interventions we forget. That is the point I'm making here. Next one. So counseling, which is a very, very important thing for successful breastfeeding, that is not being done. Many times in the large unit, they say we have lactation counselors. But just as you give importance to your ventilation baby, I think you need to give that much importance for promotion of breastfeeding also. You cannot just say, because we do not have lactation consultants, we are not able to do that. At least you have to, if you want to do it, you will find out a way. So counseling has a very important thing. Somehow you have to make sure that every mother gets the counseling right from the antenatal period and at multiple stages. Next. This is one simple intervention, easily doable, but still not being done universally. So early skin-to-skin contact of all the babies, including preterm and low birth weight babies. Even before cutting the cord, you can put the baby immediately on mother's abdomen. Delayed cutting cord in most of the cases, only those babies who require immediate urgent resuscitation or any other immediate life-saving intervention, they are the exceptions. Otherwise, all of them, including term, preterm, small for dead babies, all should have immediate skin-to-skin contact. And this is a very simple, doable thing, evidence-based one. Next one. And it is being recommended by, strongly recommended by WHO, American Academy of Pediatrics, and so many agencies. But when we say, people know about it, but they say they are not able to do it. And then they sometimes say, our obstetricians don't permit, there is a hurry, there is a crowding in the labor room and so on. I think we have to find out a way to promote this, and it has got several dividends. And early intervention, of course, it promotes breastfeeding in so many ways. I have listed here that early initiation also starts because of the close contact of the baby, and that promotes the breast crawl also, and so many other benefits. And naturally, it lays a strong foundation for the early child development when it is combined with skin-to-skin contact or kangaroo mother care. It has got multiple dividends. So that part also we have to remember, and better neurological development also. Next. And along with the promotion of breastfeeding, there are so many other advantages in this early skin-to-skin contact. First of all, there is early development of bonding. Then mother and baby are calm and relaxed, and that itself promotes breastfeeding. Then there is less cry. Baby gets a deep, calm sleep. That also promotes neurodevelopment as well as promotion of breastfeeding. And then it reduces hypoglycemia and so on. And then early stabilization of all the physiological parameters like heart rate, respirations, and then less release of stress hormones. So that also gives multiple benefits in the babies. And all these help for the promotion of breast milk feeding also. I am using the term breast milk feeding because preterm and low birth weight babies, many of them cannot take direct breastfeeding. We will have to promote express breast milk in these babies. And sometimes because we are not able to promote or we give just cursory attention, that itself becomes an indication for the top feeding. So that element we have to stress. And there are many benefits to mother also by promoting breastfeeding and this early skin to skin contact. And particularly emphasizing on this, it is an easily doable intervention with multiple benefits and everybody must give a serious thought to it. Next. And then, of course, when after the early skin to skin contact, it should not be restricted only for a few minutes. It should be continued wherever possible. In fact, most of the cases it will be possible. It should be kept for 1 hour and recent recommendations are continued for 2 hours so that many benefits can achieve by giving 2 hours. So that, and you know, by keeping the baby, continue to keep the baby on mother's chest. The baby is also calm, mother is also calm. There are so many neuroendocrine facilities are there and so many benefits are there. Next. And naturally the breast milk and the skin to skin contact, it helps in stimulating multiple sensations and it helps in simultaneous synaptogenesis strengthening, and that helps in neurodevelopment also, nutrition also, and so many benefits. Next. And then when you, instead of having the skin to skin contact, if you separate the baby just for observation or just because mother has got a cesarean or because it is a multiple birth or baby had high risk situation, just for this situation, if you separate the baby, keep the baby under incubator, naturally the baby undergoes in the stress mode and baby has to spend its energy in maintaining its own metabolic strength also, and that itself can precipitate hypoglycemia in low birth weight babies and several other complications. So this separation of mother and baby, as far as possible, we have to avoid. In fact, I would feel all the tertiary care units should have an audit round. Why this baby required to be put under warmer or incubator and not on mother's chest. Earlier, we used to say kangaroo care was introduced because there was no enough space in the incubators. But now there is a paradigm shift. It is to become, we have to make an audit why we are not able to give kangaroo care in this baby, and that becomes the indication for that. So all that we have to take in consideration. Next. And quality and duration of kangaroo mother care is also important. And longer the duration, the mother is able to hold the baby for 1 hour, 2 hours continuously, it gives effect. And multiple such situations, in fact, almost 22 to 24 hours now they are claiming, but at least more than 12 hours cumulatively per day we should be able to have. And baby can feed, continue to feed in kangaroo position also. That also we should be able to encourage. And this also encourages family participatory care also. Mother is also involved. So naturally now we are going in for introducing mother in the newborn care units, and not only in the stabilized babies, even in the intensive care units that you will hear later on. Next. So with that, and so again to make the message, take an audit in your situation, how much we can keep the mother and baby together and avoid all the complications. So mother's body is the biologically normal place for the care of the newborn. And we have to consider that as much as possible. Yes, there may be certain situations where it may not be possible, but that doesn't mean we just generalize and separate all the babies together. Next. And of course, same thing we are saying, zero separation. There are so many evidences now, so many studies who are justifying this. Next. And it has got so many advantages. And it is not only for the developing countries like ours. Even the most developed countries in Sweden, Norway, all of them have now accepted the statement that the new place for care of the premature infant is the chest of his or her parents. So this is one statement I want to bring, and they are now creating facilities for the parents to stay in the units so that baby can get almost 24 hours kangar care. Next. So this is another point I just wanted to express, manual expression of new breast milk. Nothing new I'm talking, but this is not given the due attention it requires. Nobody teaches the mother, just leave it to them, or at the most in some of the units, some nurses are there, might give initial information, but nobody monitors, nobody guides the mothers properly. So for a successful, next one, for a successful breastfeeding, naturally the right technique has to be taught, and not only that, it has to be started even when the baby is not ready for the breastfeeding. Express breast milk should have been started much earlier. They are saying within 6 hours. Sometimes we wait for the baby to be ready for the feeding and then we start with the express breast milk, and by the time it is too late. So it should be started as early as possible, even when the baby is not ready for oral. That milk can be utilized for breast milk banking or giving to other baby, or even it can be thrown away. But for continued breast milk secretion, early secretion should start, and it should continue as many times as the baby would have fed. Even the night expression should have continued. So all these points we have to take into consideration. Otherwise, without taking it, we just say that express breast milk, mother is not getting milk, and that is another reason we want to give formula feed. Next. Next, please. So manual expression, that is the one which we want to encourage, but in the hospital situation, many times we will go for the use of pumps. They can be manual pumps or electric pumps, but at least before we discharge, looking at the situation of the mother, manual expression must have been taught to the mother. There are so many advantages. And another recent observation has been, wherever pumps have been used, and the moment they stop using them in the hospital, the mothers suddenly have less milk. So even to have continued milk supply and have successful breastfeeding up to 6 months, manual expression must be taught to mother. Next. Next, please. Yeah, these are the techniques. I am not going in detail. Next one. So all that I am saying is the correct technique should be taught to mother. Next, so breast pumps, all of you know. I am not going in details. Next, they have their own limited role, but at least before the mother goes home, she must have learned the technique of manual expression. Next one, please. Now quickly pass through this slide. And this is another thing. When the express breast milk is there, if the baby is also with that, mother gets more milk. So this is another simple technique people are using for getting more milk during expression of breast milk. Next one. Cesarean. Now many units abroad, not many, but those who are following that, they strictly follow this. Even before the operation is completed, the baby is put to mother's chest and the breastfeeding is started. So this is another common situation. Now the indications of cesarean are day by day diluting. More and more mothers are getting it. They are stable and many of them undergo spinal. So they are fit enough to accept the baby, or there might be some other family member who can help, or birth companions can help, or some dedicated nurse can help, and this can be promoted, that early skin to skin contact and breastfeeding soon after birth. Next. And mothers must be given all the facilities to have satisfactory breast milk thing. And these details we can go in later. And hunger cues, that is also is there. Nowadays we go by the demand feeding depending on the hunger cues of the babies rather than just volume driven feeding. And hunger cues, we know about the mature babies. Now there are certain studies showing hunger cues in the preterm babies also. We have to learn that art also more. Next. And now in the COVID era also, we should promote breastfeeding with all the precautions. And initially we were hesitant. We used a disclaimer also that as on today with our knowledge, we do not know what complications occur, but considering the benefits and risks, we want to promote kangaroo care, breastfeeding, and mother-baby together. But today, confidently, after at least 1.5 to 2 years of experience, we can now say that it appears to be a very good suggestion, and everybody, even those who are reluctant to follow, they should also be advocated to follow. So these are all the few things I wanted to say, that for promoting breast milk feeding, if we have this idea, first of all, we should strongly believe in it. We should be convinced in it. If we are convinced, we will find out all possible ways by which we can promote mother's own milk for her. Thank you very much.
Thank you, Professor Vani. You know, what looks very simple doesn't happen. We know that in spite of all the simplicity with which she demonstrated what happens. There are two things, two messages. These changes can happen only when we, as role models, go right in the thick of the delivery room, demonstrate to our colleagues, the nurses, obstetricians, that it can happen. And I can tell you, my early years of experience with Professor Vani, Professor Jayam, Dr. Siman, and Armida, who actually stood in the labor wards, district hospitals, sub-district hospitals, PHCs, to demonstrate to people that this can happen. So please remember, and if we want these practices, much more so when it's a preterm baby, there's a great deal of diffidence. It's important that we as leaders should be there to show it can happen, and also tell people that we are behind you to support you if you need help. But more important, I think a message that Dr. Vani says, the mother, communicating with the mother. I can't remember another person other than Professor Sudarshan Kumari, whom we unfortunately lost during the COVID. She began her day in the antenatal and postnatal wards. She said, I have less work to do in the NICU. If I can make sure that my mothers know what they're doing, if I can make sure that my antenatal staff know what they're doing. In fact, she knew much more about the mother and her problems than the obstetrician or the pediatrician did. So I think the second message to all of us is we have to, if we want newborns to thrive and survive, we have to walk in to the obstetric unit and stop talking to mothers and the families. Thank you, madam, for this very important, what looks simple, but I think we need to change the tack, our approach. We have to be the thick of midst of things if we want things to happen. But of course, while many good things happen at birth, but a lot of good things can happen if we do interventions before birth for the preterm. One of them is antenatal corticosteroids. We know that antenatal corticosteroids came up with great zeal. Then came that paper which talked about saying that if you give it beyond 34 weeks, mortality goes up. It put everybody in a spin. WHO then initiated two trials, the Action 1 and the Action 2. The Action 1 was completed successfully, and as you all know, is published to document that what happens in high-income countries has similar benefits even in low and middle-income countries. The Action 2, which was there to answer the question of beyond 34 weeks, of course, was put to a stop, and it's now coming back in a new avatar, which you'll hear about. So an obstetrician is therefore a very key player, linking from what Dr. Vani said, to make sure practices which they do are correct to help newborns in the long run. I have the pleasure of inviting Louis, who's the Vice President of FOXI. Fessy Louis, as you know, has talked to us earlier yesterday. So Fessy, may I ask you to come and share your thoughts on antenatal corticosteroids and how we can move this forward for the newborn.
Good morning to all of you. First of all, let me thank NNF for inviting me, especially Ranjan sir, Secretary Dinesh, and Ramji sir, and for the nice word of introduction. It is nice, as MKC sir told, our more and more impetus is coming back into the perinatology care in our practice, in our CMEs. So the importance, as Manu Madam also told, we have to be more into the perinatology care. So as a part of that, I'm allotted to talk about antenatal corticosteroids. And as you all know, it is recommended for women the threatened preterm after 24 weeks and up to 34 weeks. I'm going to the minute details. And it accelerates fetal line maturation, prevent neonatal mortality, respiratory distress syndrome, and brain injury, has been told as one of the most important advances in the perinatal care. So betamethasone and dexamethasone administration during the pregnancy which readily crosses the placenta and that not degraded by the placental enzymes. And this increases the surfactant production, increases the complaints and maximal lung volume, and decrease the vascular permeability, mature lung pairing human tissue, and increase the clearance of lung water to improve the respiratory function, therefore the survival. So the extrapulmonary effect also has been told that reduces the intraventricular hemorrhage, and also as the respiratory morbidity is less, not only the direct maturation of various tissue, but it will help the fetal well-being. And this is one of the earlier studies, you know, which by the Liggins and House in 1972, which told about the advantage of antenatal corticosteroids to the latest Cochrane review. And the latest Cochrane review, as it tells in 2017, reduction in the adverse outcome related to the perinatal death, neonatal death, RDS, moderate and severe RDS, IVH, necrotizing enterocolitis, need for mechanical ventilation, and systemic infection the first 48 hours of life. So, what is the long-term influence also? There is no significant association of one course of corticosteroid with the childhood development delay or this cerebral palsy. And this is another study of 30-year neurodevelopment follow-up. They were telling no difference between the exposure groups of whether there was any neurodevelopment delay. So what does the government of India tell? They tell we have to give dexamethasone between 24 to 34 weeks of gestation at all levels of health facilities, including private sector and public sector as far as possible. And the different associations tell, this is the NICE and WHO tell, it advocates between 24 to 34 weeks, American College from 24 to 37 weeks, Canadian Society from 24 to 35 weeks. In all cases, we must assess the gestational age properly, and it has to be administered to a woman who is in spontaneous labor, which is characterized by the uterine contractions, which is increasing, and patient can go for a preterm delivery. And administration of corticosteroids, fetal maturation cases, when we are anticipate delivery within the next 7 days. So, what are the expanded indications? One is the late, preterm delivery. That is antenatal late preterm steroids. The American ACS has been advocated from 34 weeks to 37 weeks, but it is controversial because how far it is really useful to that. And the recent indications tell that in these settings of expanded indication, it is imperative to go beyond the evaluation of the short-term benefits, determine the long-term safety effect also, whether there is any long-term adverse effect of when we give empirically in the late preterm pregnancies also. So preterm exposure to exogenous corticosteroids, as you all know, is associated with alterations developed in the programs of the fetus, affects the neurological outcomes. So there is a 5-year follow-up of which came recently in 2018. There is neurosensory disability can be occur that is needed to a larger study has to be done. And also another thing is that neonatal hypoglycemia occurred more frequently after antenatal corticosteroids. Slight increases. These are the things which you have to see when we are giving prophylactically for extended indications. And what NICE tells from 34 to 36 weeks we can give. ACOG tells we can give up to 37 weeks. The Canadian Society tells we can give up to 37 weeks. And regarding the peri-viable fetus, that is before 26 weeks, definitely most of the societies advocates it can be given. And also NICE from 23 to 24 weeks, Canadian societies from 22 to 24 weeks we can give. And WHO, American College and Canadian Society recommends when the preterm delivery is anticipated, and dexamethasone or betamethasone can be given at 25 milligram in divided doses, either 12 milligrams in 24 hours apart, or even 6 milligrams in 4 divided doses can be given. There are different regimes which has been told. So is there any difference between dexamethasone and betamethasone? Most of the studies tell not much difference, but one study tells that betamethasone is reduced rates of chorioamnionitis and RDS. And another studies tell that dexamethasone has got a slight advantage of lower intraventricular hemorrhage. So there is not much difference in most of the studies. So this is the how we have to see that whether there is long-term outcomes of there is. I just put a few things so that it has to be in future. We have to see when we analyze whether there will be any long-term. The concerns is that another concern is attention deficiency and the behavior dysfunction observed in multiple courses when we are giving the multiple courses. This is another study of 5-year-old children when they are exposed to multiple steroids. There is slight increase of neurosensory disability in them. And repeated courses, whether it is advocated or NICE tells that it is not advocated. WHO tells single repeated course. If you are not anticipating delivery after the first delivery. And American College tells that you can give a rescue course if you are anticipating delivery afterwards. After the first dose, there is no role for a repeated dose. And Canadian Society also tells a repeated course of corticosteroid is not recommended, but they recommend rescue course of steroid is advocated. So next expanded indications when we give routinely for cesarean delivery. There are initial studies telling that it reduces the RDS, transient tachypnea, admission to NICU. But we have, when we see the WHO, it is not recommended in women undergoing planned cesarean delivery. ACOG, we can give before 37 weeks, after 24 weeks. NICE, no specific recommendation they are telling. Canadian Society tells should not be administered to women undergoing pre-labor cesarean section routinely. In cases of preterm premature rupture of membrane, definitely it is found to be reduce the neonatal morbidity, RDS, intraventricular hemorrhage, and necrotis and encephalitis incidence. So it is definitely advised to give for in cases of PPR. So the challenges is that despite of this 50 years of coming of corticosteroids, there is not much difference into the dosage of how you give. It is not been done recently. It is almost following the similar dosage has been followed over these years. And whether the increased neonatal morbidity when antenatal corticosteroids are given to the woman, the preterm labor and the middle income countries also has to be seen. That is what the previously Sir was telling. And next thing is this is one study which I could get from when they analyzed in the African population, but they could not continue the study because there were a lot of bottlenecks of absence of coverage data, poor gestation age was not properly documented, lack of neonatal essential medicines, this thing. Lot of problems were there. So a lot of things has to be studied in the long income nations and settings has to be seen. What are the ways forward before concluding? Do not assume that antenatal corticosteroids will have no programming effects on the human fetus. and record the antenatal corticosteroid exposure and consider the antenatal corticosteroids as a variable in epidemiologic studies outcome, even for heart attacks and neurogenic degenerative diseases. That is, as a pediatricians, you can contribute to that and develop better predictors for time to preterm delivery. If you can predict it, it will be better, useful, and develop new biomarkers for fetus that may benefit from the antenatal corticosteroids and minimize the dose and exposure by restricting to one dosage, and if needed, the repeated dose after some time when we are anticipating preterm delivery only. And to summarize, when administered to the right woman at the right time, antenatal corticosteroids are the effective therapy to the mature lung function and circulatory stability in preterm infants. Their judicious uses reduces, no doubt, the neonatal mortality and morbidity. However, the long-term effects has to be studied in a larger scale, and significant knowledge and gaps continue to exist if we are giving to prior to 28 weeks, and whether we can give in the late preterm babies routinely or elective cesarean delivery, and in the low resource set environments, how we can. Thank you for patient hearing.
Thank you, Dr. Fessy. You know, I think the issue of antenatal corticosteroid, while there's a controversy, I think the message is clear that we must do all that we can to ensure that in the majority of instances where we know what the gestation is, even if the bottom line don't think it makes too much of a difference, we should ensure that steroids are given. We also need to remember that there's an incremental effect of those, even one dose, second, third has some incremental effects. So, especially for people who are referring mothers from peripheral hospitals to tertiary hospitals, I think we must encourage that the first dose be given. We have moved to dexamethasone, as you know, because the betamethasone salt is not available in the country. That's the reason we made the change. And you will hear more about whether this dose that Dr. Fessy actually shared on DEXA can be even lowered further, so that the risks he talked about the hypoglycemia and others will get mitigated, which is going, as I said, in the new format of Action 2 trial that is being proposed as an element of that. So thank you so much, Dr. Fessy. So a large proportion of our small babies, preterms, in this country are still, as Dr. Vani had alluded to, are growth retarded. We are still able to manage them roomed in with mothers. They don't necessarily come into NICUs and ICUs. And there is this whole issue about the quality of care we provide them. Should we make a distinction as whether they are in a NICU or not, or by virtue of the fact that you just simply are small and preterm, you need certain quality. To talk about this, I have none other than Rajesh Mehta. Rajesh, are you there?
Yeah.
Oh, yeah, go ahead. Rajesh Mehta is advisor to the WHO CRO region, and he has done a great deal of work in promoting this whole issue, and he's going to talk to us about how standards of quality of care need to be looked at when you look at small and sick newborns. Over to you, Rajesh.
Yeah, thank you, Sid. And thanks to the organizers for setting up this session. This one is about the standards and the quality of care as of our presence and our daily work. So I would draw your attention to this fact, which was analyzed in 2018.
Rajesh, we can't hear you.
Okay. Speaking, is it?
So you have to unmute yourself.
I have unmuted myself.
Unmuted, but we can't hear.
Now?
There is sound.
Now can you hear? Hello?
Yeah, correct. Go ahead.
Okay.
Right. Thank you.
Yeah, sure. So my The point is that we realized in 2018, this big publication happened, that more deaths are happening because of poor quality of care compared to poor access or poor use of the services. So in MDGs, we remember we used to talk about coverage, and coverage has increased. India has achieved the institutional delivery rate of 85% now, and 50% happening in private sector and 50% happening in, for example, the.
Rajesh, we can't see your slides.
Yeah, so I was putting them back for the slides, but the message is that more deaths are happening because of poor quality of care. Yeah, so what is happening is that in most healthcare areas, maternal death 50% coming from poor quality, neonatal death even more than 50%, about 55% deaths coming from. And much of these deaths are happening in poor countries, as in this blue shaded map. So Dr. Professor Vani was saying that the best place for care is the mother's chest, and zero separation should be the policy. But when we analyze the situation, I encourage you to look at your own labor rooms and delivery wards. The global data is that more than 50% cases actually do not receive evidence-based care. So we know what is required, but we are not able to practice it. It is not just about mortality. The poor quality of care is also leading to too many adverse events, healthcare associated infections, medication errors, combining into a lot of dollar loss, and irrational use of antibiotics. Antimicrobial resistance is becoming a huge epidemic. And overall estimation was that cost of lost productivity due to poor health care could be 1.4 to 1.6 trillion in a year. Not just, the quality of care is important for making them survive, but the quality is also impacting the trust in services. This is an analysis in several states in India where they found that people are bypassing the nearby facilities because their perception of quality is not good in these facilities. At least one of these quality related issues was quoted as why the patients are not seeking services from the nearby facilities, and they may be mostly government funded facilities, but this could also apply to smaller private facilities. So quality of care, actually the WHO vision is very clear that all level of care, we should be able to provide good quality of care. This is based on standards, and universal health coverage being the pivot of SDG 3, which includes the coverage, the quality and financial protection. All of these are important. And NNF being the custodian of newborn care in this country and having contributed so much, I think we should invest in all these three areas to ensure universal health coverage, the availability of services, the quality of care, and also looking at the minimizing out-of-pocket expenses. So the simplest definition is that the healthcare which ensures desired health outcomes in terms of survival, decreasing morbidity, reducing the cost of services, and based on best evidence available so far, only then we can say it is quality of care. And we know these typical descriptors of quality of care. Safety is an inherent part of quality of care in healthcare delivery services. So all of these are important. People-centered care is a little bit later concept, and we must excel in this more and more. NNF can be again a lead agency to support this by advocacy and role modeling. So how is quality of care delivered? We know that the whole health system is required, all 6 health system blocks, and it's a complex system. It's not a small, daily process. It's a complex system. Even in a small nursing home, in a standalone solo practice of a pediatrician or a neonatologist. We need to cover all health system blocks in terms of the infrastructure, the essential medications, the training which we have received, whether we are collecting data or not, whether we are able to provide enough financial protection or not. So the standards actually now are well defined to provide this healthcare services. So standards actually cover both the structure or the inputs of the infrastructure and the process of care. Largely, the standard format now in WHO publications is that there are 3 standards of provision of care related to evidence-based practices, which is standard treatment protocols, and data systems and referral systems. On the other side, experience of care is given equal importance. 3 standards are largely related to effective communication with families. And Siddharth Ramji was just mentioning that one of the professors used to visit postnatal ward and antenatal care clinics to talk with mothers. So same thing is happening, should be happening in neonatal units and in labor wards. So how do you respect and provide dignified care and emotional support to the whole family, not just the mother and through her the newborn? The 2 cross-cutting standards are related to the trained and competent, skilled, motivated human resource. This is you and me, and essential physical resources or the room, the available equipment, the disposables, so all of this actually is related to process and structure. Now to convert that into outcomes, quality improvement remains an important element, which is less practiced, but catching up. So in 2016, we had at birth care focused standards, which have been released by WHO and partners. So again, reminding us 3 standards of vision of care and 3 standards of experience of care, and 2 related to the cross-cutting staff and the environment. So these standards were not found enough for small and sick newborn babies who have complications and who are required to be treated in facilities, health facilities, SNCUs, NICUs, but also in home-based situations as a follow-up or for early care. So based on that, the standards 2020 have again been released, which again have these components of provision and experience of care. So how do these standards help? So we all know the role of standards. We practice some of them. We are aware of some of them. So constantly the standards are required to guide the resources, the inputs, the policies, the finances, the rooms, the equipment, all that is described in standards of care. And they also help us decide the evidence-based standard treatment protocols. They provide a benchmark for measurement, monitoring performance. So NNF has a lot of standards-based applications as they visit the neonatal units, the SNCUs for accreditation purpose. So that is what is the use of standards we know. The missing piece has been the how do we use this benchmarking for continuous quality improvement that we constantly measure and improve. That is also catching up. And then there should be a reward system. So standards actually, if followed, could be rewarded by some processes. So achieving desired results is entirely based on standards. So whether optimal healthcare is leading to the desired outcomes or not, whether we are able to eliminate wastage. We will hear some experiences from Praveen Kumar today in this session. So we want to improve the cost efficiency, minimize the cost, and eliminate the wastage. So improving satisfaction of users, and that leads to improving the utilization of services. So most countries have these standards. They may not be available as a booklet, as WHO publishes booklets on standards, but they are certainly available in terms of, in India, for example, you have India Public Health standards, which decide the infrastructure requirements for government-funded facilities. So NNF also has similar standards for the newborn units. So policy strategies and plans are there, which have training packages, which describe the clinical guidelines, So unless we actually comply to these clinical guidelines, we are providing poor service. Then clinical audits are there. Professor Vani was saying, why can't we take rounds in the ward and see labor room deliveries and see whether the baby is being delivered on the mother's chest or not, and whether mother's milk is being practiced in neonatal units or not. So clinical audits. Then there is death review system. We have MPDSR lined up by Government of India, maternal perinatal death system review and response system. Then we have family participatory care. We have policy and guidelines available for that. So all of that actually can be measured through checklists, and therefore standards, guidelines, and protocols, which are included in pre-service education. All of us are professors, many of us are professors. We must teach and do role modeling for young students. MKC Nair invited a postgraduate student, but all of us have to be good role models to them. Therefore training after service, in service, and pre-service training is important. Now compliance to these guidelines and measuring it constantly, we have a tool now which neonatologists in India practiced, adopted this in their practice, called point of care quality improvement. It has 4-step simplified process and rapid learning cycles. So there is a training available. We published a document which actually enlists a lot of hospitals which have completed QI projects. About 1,000 QI projects are mentioned in this document. You can download and study how quality improvement can be done in our day-to-day work. There are learning platforms, 2 of them. One is managed by the Nationwide Quality of Care Network. Vikram would be busy in quality of care session in NNF conference. In another session. Then there is one maintained by All India Institute of Medical Sciences. So the message is that national standards must be applicable everywhere. So whether you are running a private clinic or a small hospital or a nursing home, or you are working in a corporate hospital, and all of us who are working in government sector, everywhere the national standards must be applied. They are minimalistic, I understand. But the corporate hospital, the big private sector can actually set their higher level of standards. Nobody prevents them, but they must comply to the minimum government standards, national standards, which have been published through various documents. So quality of care is a responsibility of each one of us. We must assess our own infrastructure periodically to ensure that all essential items are available. So before stock out happens, we should be able to ensure that enough supplies are available in our daily workplace. We should keep an eye on compliance to evidence-based protocols. If we are not complying to them, there is always a tool available like POCI and other quality improvement processes, which will help you to use the local data to improve the quality on a continuous basis. So teamwork for improving quality of care has to set up and move our daily work so that it becomes a part of our work culture. We allow the students to see that so that the students can go out and practice or practice for continuous quality of care, applying the national standards of neonatal care. So thank you so much for paying attention. We will have some examples during this session itself. And there are separate sessions also on quality of care, which NNF has acknowledged as an important part of the business in present situation. So thank you. Over to you, the chair, Dr. Siddharth.
Thank you, Rajesh, for that very lucid presentation. You reminded us of all the simple things we seem to forget, which over the years still seem to exist. You also clearly indicated a way forward, and just to reassure you and all of you here, you heard Dr. Ranjan Pejawar say in the inaugural that NNF is committed to quality improvement, and you already have a champion amongst us, Vikram Datta, who is the Vice President, is actively involved. So be rest assured, we have been partnering with colleagues and the government, and it will be our endeavor to move forward. So I hope that each one of you will take little lessons from what you heard, from what Dr. Rajesh said, as we move forward. As we move on, I know we are cutting short, very short on time. We heard about KMC and Dr. Vani talked about how to prolong it. And we have experience of how this can happen and also a novel way of how mother and newborn can be brought into an ICU. To talk on this, I have Dr. Harish Chelani, whom I can see. Thank you, Harish, for being here. He's the professor of pediatrics at Safdarjung Hospital. But Harish, I'm going to use the advantage of using a pre-recorded presentation which you sent to us. So
thanks for the opportunity to present.
Yeah. So you just be there and we are going to run your pre-record presentation we sent to us, right?
Thanks, Doctor. As we all know, kangaroo mother care is effective intervention for care of low birth weight babies, and Cochrane meta-analysis 2016 showed 40% reduction in mortality. WHO currently recommends KMC to be started once the baby becomes stable, which may take few hours to days, and most of the neonatal death, however, occur in first 3 to 4 days of life. It is also true 70 to 80% of the babies admitted to SNCU require either minimum oxygen support or require assisted feeding. At present, KMC coverage in SNCU is just 15 to 20%, and average duration mother visit nursery is 3.7 hours and provide KMC for 1.8 hours. Recently, we have got strong evidence regarding KMC for unstable babies and community-initiated KMC outcome. To fill the gap in the existing knowledge regarding efficacy and safety of starting KMC soon after birth for unstable babies, a multi-country randomized controlled trial was done among babies 1 to 1.8 kilogram. Intervention group received early and prolonged KMC, whereas control group received KMC once the baby became stable. To provide this intervention, Mother Newborn Care Unit was built, where small and sick newborns are cared with their mothers or surrogates 24/7 with all facilities of level 2 newborn care and provision for postnatal care to mothers. The mean gestation and birth weight was 32 weeks and 1500 grams respectively. Mother Newborn Care Unit improved the opportunity for prolonged KMC and early breast milk or breastfeeding. We can appreciate that intervention group received KMC of 17 hours per day, while NICU babies received just 1.5 hours per day. Similarly, breastfeeding rates at 7th postnatal age and at discharge were higher for Mother Newborn Care Unit. However, a major concern was to convince the healthcare providers, both doctors and nurses, to have mother's bed next to the baby, which is against the current norms world over. Another concern was to bring obstetrician inside the NICU to provide postnatal care to mothers. This concept has been described as mother newborn couplet care. The training of neonatal nurses was done to provide the postnatal care to mothers. Immediate and prolonged KMC showed 25% reduction in the mortality, which translates into saving 150,000 babies globally every year. This intervention is safe as there was no increase in risk of infection with the presence of mother or surrogate. In fact, infection rates were less in Mother Newborn Care Unit as compared to NICU. Also, there was positive feedback from parents and health personnel in the intervention group. To study the feasibility and effectiveness of community-initiated KMC, randomized controlled trial was done for stable babies between 1500 to 2200 gram. Age at initiation of KMC was 30 hours postnatal and 10 to 11 hours of KMC was provided daily. This resulted in 30% reduction in the neonatal mortality. Community initiated KMC thus would be useful for low birth weight babies who are born at home and are stable, and those low birth weight babies who are discharged from the facility early. So to conclude, immediate and prolonged continuous KMC intervention can save as many as 25% low birth weight neonates. However, prolonged effective KMC is possible if mother and baby are cared together 24/7 in mother newborn care units. Mother newborn care unit implementation would need infrastructure and policy change. Policy to allow mother or surrogate in SNCU 24/7. Also to provide linkage to continue KMC from facility to community and to have support to mothers through ANM and ASHA worker. Mother newborn care unit is therefore the way to prolonged effective KMC to save low birth weight neonates. Thank you.
Thank you, Harish. I can tell you that I've had the opportunity to work closely with Dr. Lani when this project was running, and I had to see it. I know how much effort he put in, but I think this is the best synergy we can provide, because this was always the gap where we have a sick baby and we couldn't get mothers together. We could never achieve zero separation unless you do that. And this has been a great learning experience. Our obstetricians and pediatrician neonatologists came together. Mothers have been extraordinarily happy over here. And in fact, as part of the national program, we have now been trying to promote how to get MNCUs in. So my message to all my colleagues here are that I think you should think about this as the next level of ICU care for newborns, where mothers and babies are together. It will address so many of our problems, which we have been trying to find out. We'll get longer KMC, feeding, family participatory care, whatever you're talking about will simply happen over there. So thank you, Harish, so much for all that you have said. We move on, and one of the big challenges we have are two interventions that we keep doing in our sick kids: oxygen, antibiotics, most misused if you ask me. And to talk about that, I have Dr. Praveen Kumar, who's Chief of Neonatology at PGIM Chandigarh, who's also the President-elect for 23. So Praveen, is he there?
Yes, sir.
Yeah, please go ahead. It's all yours. Praveen, we are running short on time, so I request you to kindly ensure that you complete within 6 minutes. Thank you.
All right. So thank you very much to the organizers and Professor Ramji. So I would just give you a glimpse of the work done in Madhya Pradesh related to safely using oxygen and antibiotics. And I don't need to emphasize, everybody is aware that these two drugs are life-saving, but at the same time can kill. And unfortunately, the poor clinician in the NICU or SNCU is in a very delicate situation. So if you don't give, baby dies, and if you give, then also there can be a problem. So all of us have observed, and we go to the SNCUs, all the prescriptions of all the sick babies carry these three items: oxygen, antibiotics, IV fluids, and nilparol. And this is the standard prescription which every baby keeps getting. So we approached this problem by visiting the field, actual SNCUs in Madhya Pradesh, conducting some direct observations, focus group discussions, in-depth interviews with everybody. And then we presented these findings to the real stakeholders, which means the frontline nurses, the doctors, and the NHM team. and discussed with them that what can be the way out. And based on their inputs, we then organized content design workshops where the goal was, okay, there needs to be a package, but what kind of package, what kind of format, what language, what duration. So all this was decided by the nurses and doctors who actually work in the SNCUs. This is just an example of like how we approach the problem. So for each domain, we identified the local strengths, the local weaknesses, the opportunities, and the threats, so that we could build upon these only, and rather than changing the system totally. And by now, I think everybody is aware of these two packages. Dr. Rajesh Mehta already mentioned about the POCI. So this POCI was extensively field tested during this Madhya Pradesh project in the initial years. And simultaneously, the content package, that is the preterm sick baby care package, which everyone is now using extensively, was made because it was also found that apart from lacking in QI skills, there is a need for evidence-based, simple messages which people are able to use at the front end. And the way we administered these was in the format of the IHI Breakthrough Series model, which means every 3 to 4 months, we would have a learning session spread over 1.5 days, followed by a skill practice. And in each session, basically, we would start with the QI work done by some people already, which we're doing, then introducing QI skills to the new team members, followed by covering one of the subject domains through this preterm package. And then finally, at the last session, developing the next projects which people would work on for the next 3 to 4 months. So this went on for nearly 18 to 24 months, and we had several successes in that. Now, coming to the two examples of oxygen and antibiotics. So related to oxygen, I'm sure everybody is aware of the real context, that you go to a busy government SNCU or NICU, there are several babies sharing cots on oxygen by oxygen hood, difficult to even handle the baby, identify the baby. And we have hardly maybe 4 or 6 functional pulse oximeters to take care of maybe 12, 20 or 24 babies. So there's a gross shortage. So the change ideas, some of them I've listed here, I think they were nothing new, but they were all given by these people only, the nurses and doctors who work there. So for example, the usual practice was a baby arrives in triage, the first thing the nurse does is put on oxygen, like any other emergency. So they decided, okay, why don't we put on the pulse oximeter first before putting on oxygen, so that if there is really hypoxia, then we give the oxygen. And of course, to make them comfortable and to make it safe, certain group of babies, like those who came gasping or in shock, were excluded from this. So this kind of pink slip was introduced to ensure that this was actually happening. And another practice which was based on the WHO guideline was, whether we can change the hoods to nasal prongs for most of the babies. And as you can see, this is data from 3 SNCUs. The oxygen usage, which initially was around 34% of babies used to get oxygen, came down to around 21% after the intervention, and this was sustained. We also looked at certain other parameters related to oxygen. So like proportion of neonates who received oxygen for more than 24 hours. So this nearly halved after the intervention. In one particular unit, while discussing informally, we understood that nearly 50 to 60% of the annual maintenance budget was being consumed by oxygen. So a thought came, well, can we try to decrease the consumption of oxygen by introducing these things? So in this particular unit, because of a very active local leadership, a decision was made to switch hoods to the nasal prong oxygen. And as you can see, the average consumption, which used to be around 8 jumbo cylinders per day, dropped down to around 3 jumbo cylinders per day and was sustained over next virtually more than a year or so without doing anything further. So this led to a reduction in the budget and saving of money of nearly 7 lakhs per year, which would be enough to buy at least 10 to 12 pulse oximeters very easily. And this is one of the papers published recently in case people are interested to look at the details of this experiment, and this is available in this publication. Antibiotic usage was targeted in several SNCUs, but this is again data from the 4 SNCUs. Again, the context to be remembered is most of the SNCUs do not have blood culture facility. Some of them have tie-ups in the PPP mode with some private centers, but this is available only in very limited hours, and hence cultures are usually not done. There is often a side lab with qualitative CRP being done only in the limited working hours. So as per the people working there themselves, they came out with the idea that can we simply decrease the variation in practice? Can we simply bring up some, updated process flow charts which can be followed by everyone? And can we have a written consensus policy between the 4 doctors and the 8 nurses who work there? So this is an example of one of the, process flow charts related to use of antibiotics, which evolved over several PDSA cycles in different units. And the result of this is evident in this table from the SNCU database, that if you see over a period of 6 months, in the green bars are the units which were practicing these QI projects, and the other ones are the units which did not take part in the QI cycles at this time. And as you can see, the use of antibiotics dropped from nearly 50% to maybe 15% or 27% in most of the units, whereas those units which were not part of this continued to use same kind of antibiotics. And all this happened without any change in mortality, because one of the worries when you try to do this is whether it could lead to missing sepsis and babies could die. But the mortality did not increase yet. And I must acknowledge that all this work was possible because the foundations were laid much earlier. We actually ran a collaborative of 6 hospitals, government and private, with the help of Access Health. And I wish to thank Dr. Abha Vendiratta, who was instrumental in bringing some funding and also the IHI expertise to us, where we were working on reducing the healthcare-associated infections so that we gained first-hand experience before going into the SNCUs. So I think antibiotic stewardship is rightly deserving and getting a lot of focus, but oxygen stewardship is still something which is not getting too much attention, except during COVID when there was oxygen shortage, people thought of, okay, how we can regulate that. So I think we are seeking right now support and funding for something which will standardize and maybe rationalize the use of oxygen and maybe bring in some kind of certification that units are actually using oxygen rationally and safely. So what are the lessons we learned? I think nothing new, well known, but still, first most important is we must practice whatever we are preaching. Otherwise, we sound unconvincing to the team. And as you saw, the nurses and doctors were involved right from the beginning. So we need to, co-design so that people, whether it is the frontline teams or it is the state NHM, they, co-own the process and the interventions, and then it is sustained. We all talk and we know that yes, nurses can do a lot of it and they are, most important, but it's really, very inspiring to know that these nurses in the state SNCU who couldn't speak English, couldn't speak Hindi well, they could transform themselves and take lead in the, running these projects. So I think they are the pillars because they are on the bedside 24/7, unlike doctors who are simply visiting for a few hours. Collaborative learning and improvement, I think well known, but clearly amply shown in this project that yes, this is very critical and leads to a spillover of the benefits to several other SNCUs who were not really part of the project. And in our scenario where, the knowledge or the skills of people also are not up to the mark, so training in the QI skills has to be supplemented with small doses of the subject training, content training. And that can be done online and as well as on site with some skill training. So it has to be mixed, both of them, QI as well as the subject training. And we have to have a system where long-term hand-holding and support can be provided to these people, because it's easy to say, okay, we do a 1-year project, 3-year project, and then we leave them. But I think everybody needs somebody more experienced, senior, for hand-holding, for confidence building. And so that system has to be there where they can connect with somebody and try to solve their own problems. So thank you very much. Thank you.
Thank you, Praveen. Thank you so much. What you've reminded us is, these are problems not only seen in district hospitals, I think we see them even in our own hospitals. You reminded us again that we have to set ourselves a role models, do internal audits, ask these questions as to what we need to do. Oxygen stewardship is not a problem only for newborns, it's a national problem we experienced during COVID. And I'm happy to let you know that on the 22nd of December, that is on Monday, the union government will be launching the National Oxygen Stewardship Program, which will be online on YouTube, which will be launched by the Government of India, headed by none other than Professor Ashok Diarari, who is a member of the Empowered Group 2 actually initiated much of this action. We have done great deal to salvage them, but what happens thereafter? Can we help them thrive? We did a large study under the NIT banner of the DBT in Himachal of babies who graduated from SNCUs and found that up to 6 months, a very large proportion of babies, including babies who were term or near term, actually had failure to thrive. And so I think there are big issues related to what we do with them when they get discharged. And to talk more about it, I'm going to invite none other than Suman. You all know Suman here. So Suman Rao from St. John's, please.
Thank you, sir. And it's indeed a privilege to be here on this panel discussion. And my talk is, how do we make these babies thrive? May I request for my slide deck, please? Okay. So we all do so much for these babies in the NICU. And the day they get discharged is definitely a cause for celebration. But our job is only half done. And we need to move forward. And it's important to ensure that they thrive well, and we ensure that we transform the care that we are giving them. So survive, thrive, and transform. That is the complete mantra of WHO for our preterm babies. And why is follow-up important? I think we as neonatologists know this. Like Sir said, these babies, the preterms, though they constitute only 15% of all babies, their contribution to MAM, SAM, and post-neonatal mortality is huge. So we still need to look after them. They have continuing morbidities even after discharge. We need to identify and treat them. And most importantly, the question they ask us, is my baby going to be normal? And we have a big role in making them normal. This just one picture is enough to tell us that it's not only the small babies, but even the babies probably require long-term follow-up. And the lower the gestational age, greater is the handicap that we have. So today my talk is all going to be by the 5 wise men. The why, what, where, those are the questions we're going to ask. The first question was why. The second one we have is who will follow up? And that, it's not you, me, it is us. It is a multidisciplinary follow-up. And this busy slide shows you that we as neonatologists can't do it alone. In fact, with the developmental pediatric specialty now growing, we need to be partners together to ensure that we provide the good quality follow-up care. But even though that is going to be a new subspecialty, our role doesn't end at the doors of the NICU, because we need to sort of continue to handle them. For example, in Johns, we have an excellent follow-up unit. We have an excellent unit of hope, but we still take care of our newborns till the age of 3 years and then only hand over them to the developmental specialist. And what you see here is, it is a team effort. We need neonatologists, we need nurses, we need psychologists, occupational therapists. We need people from ophthalmology and ENT, and very, very important, we need someone to coordinate all this care. So the social worker becomes very important. Where do we follow up? In St. John's, we follow up in the unit of hope, that is our center for special babies or babies with special needs. Every NICU should have a follow-up care center, not an OPD. It should be a multidisciplinary follow-up where under one roof, the baby can get all the care. And that is where I think private is looking at even government, and government is doing so much. And this is the District Early Intervention Center, which is coming up in a big way in all districts. And it's important that when these are being set up, the quality of care is also provided, which can really transform. Not only that, we realized even in our own unit, when we look at a follow-up data, first of all, we were just following up babies who are coming. Only for the past 3 years, we're actually looking at what is our denominator, that how many babies should have come, how many are coming. They are lost to follow-up at each step. Less than 50% come back for their first visit. because we are catering to them from large areas. By the time they're 18 months, it's less than 10%. And that is in what we think is a very good unit. So there is no other choice but to go to their homes and do the follow-up. And maybe the ASHAs have such a big role in identifying and bringing them to the district, the mobile health team, and to the district early intervention center. And this is again what we sort of realized from our large scale district kangaroo mother care WHO study. We are now following up all these low birth weight babies in the Koppal district of Karnataka who are part of the study. And this was a district level study. And now we are going to their houses and doing it even during this COVID pandemic. And we know that this burden is huge. We are using the WHO recommended tool, that is the GMCD, and we are seeing that only around a third have no delay. Yes, the severe delay is less than 10%, but a lot of them have a mild neurodevelopmental delay. So we need to probably give these services right at the doorstep of the babies, because once they are gone home, they don't realize that these babies require a lot of interventions. So when to follow up? This is our criteria in St. John's, but it is good to sort of link it along with immunization. But the point we're trying to make here is the follow-up is not just due for immunization and others. The follow-up goes on. I have put here 3 to 5 years, but it's even maybe better till 8 years. And probably, like we know from the Pune cohort, it doesn't end. You need to follow up them into adulthood. But please mind you that at every follow-up visit, what you need to do is different. And that's what we have here. What are the things that we need to do at every follow-up visit? And the other thing we need to remind ourselves is that when we talk about preemies, we are talking about corrected age. And that's a message that we need to give our mothers right in the NICU. Don't compare your babies with, your 3-month-old who was 28-weeker with another 3-month-old. So we need to look at the concept of corrected age. Now we come to the question of what should be done. It's monitoring, it is screening with standard tools, and doing diagnostic confirmation and assessment. And all these pictures I have taken from the District Early Intervention Center booklet, excellent one for all of us to know what all should be done. This is what, as neonatologists, we are comfortable with. We have to focus at each visit, like Vani Madam said, feeding and KMC. These two things can together add definitely somewhere around 5 to 8 IQ points straight away if you do it well. So focus on that, continue that, but also look at other morbidities, look at growth. We need to look at the eyes because retinopathy of prematurity is a big issue. The hearing is important. We need to do ABR test for all these babies. We need to do neurodevelopmental screening, and we use tools like Hammersmith and then subsequently Amintison. You need to do formal developmental assessments like DDST, DASI, BSID. And this is something now I am really looking forward to, that is general movements, which is shown to be even better than an MRI in predicting cerebral palsy later on. And it just is so easy to do. And we are now doing a study with 2 SNCUs where we are training the nurses to teach the mothers to just take a short video and share it with us. We look at the general movements and tell them what to do next. So this is something which can be a very good one for telemedicine. Imaging may be required sometimes, but also please do not forget, we need to look at the behavior, start doing things like MChat at around 18 months of age. But more importantly, we need to do early intervention therapy right from the word go. And that's not on follow-up. It is there in the NICU, which has to be continued. So early intervention therapy should be started in the NICU. It's not for babies who have a problem. It's for babies who have a risk of a problem. And that is something that we need to do. So we have our occupational therapists visiting the NICU and continuing care on follow-up. Behavioral modification is required. We need to teach the mother. Play therapy is very important. And it's only when I sat with our play therapist, Dr. Shilpa, I realized it is so different than from what we just teach. So these are all specialities that we need to nurture for our babies. Speech therapy may be indicated, and parent training is so very important. And all these things are there in that one booklet on the District Early Intervention Center. So for me, the basis of early intervention is so fascinating. When there is a normalcy, it promotes normalcy. When there is something abnormal, we need to hinder that so that the synapses which is occurring still occur in the normal way. Take a baby who has tonal abnormalities through normal tone, normal movements. And this is the basis of our early intervention. Make the cells that are important fire together so that they wire together. These two dictums, use it or lose it. These are two principles that are the basis for early intervention. And if we remember that, we know that early intervention will work, and we have evidence for it. We have Professor Nayar's work also included, which shows that it improves cognition, it improves motor outcomes, and we have a meta-analysis also for this. Now, why have I put up the Milky Way galaxy here? And this is almost my last slide. Because the newborn baby, the number of neurons the baby has is almost the number of stars in the Milky Way galaxy. In fact, the 100 billion neurons is double what you and I have. And that is what we need to nourish and take care. There are more than 40% of the synapses you see here across time are getting pruned. So even a baby who has a problem in the NICU, like a grade 3 IVH, we, by doing early intervention and making these synapses wire together well, will make a big difference. And we do have a window. And if you see, this window shows us about the different senses, how fast they develop. And you see, particularly for vision and hearing, it's a little shorter. And that is where, though this period is around 8 years, as you see here, the focus by WHO now is on the 1,000-day concept. And that is what we need to focus on and do everything very intensively during this period. And who is going to do it? It is the mother. In fact, for such moms, I say it is worth every minute that you put in. It is worth taking leave or leaving your job, because this is a time you're not going to get back at all. And the mother and the family are the ones who are going to be doing it. And that's the principle of early childhood development. And we have this wonderful booklets from WHO. This is not only for preterms, it's for all babies. The first 2 years is so precious. And we have evidence-based recommendations that responsive caregiving, promoting early learning, integrating caregiving and nutrition interventions. Nutrition is also important, and especially breastfeeding. Finally, the mother is very important. Take care of her. Identifying mental health problems in her. Help her get that treated. Because finally, she is the main tool who is going to promote her baby's early childhood development. So thank you very much. So this shows that all our babies are born geniuses. It is up to us to ensure that they remain geniuses. Thank you very much.
Thank you, Suman. Just to remind us that it's not enough for us to just send the baby live from our course. I think it would be unimaginable if we do not have an early intervention exercise and the follow-up. It would be necessary you do it. If you can't do it yourself, I think you should partner with somebody in your neighborhood. And she also said, if you can't do it physically, there's a telemedicine mode to do that. Thank you so much. Before we go, I think there's a small announcement that Dinesh will make, and then we'll have the last winding up session for.
We have a few announcements to make. One is those who are leaving their transport desk at the reception. Will guide you for your transport. There are a few people whose awards were there and they couldn't collect the mementos. They can collect the memento from NNF stall in the exhibition area. And the awards of various competition advocacy days, which will scheduled for 19th, because many people will be leaving, they've been preponed today at the banquet at 7 p.m. And just like today's plenary, there will be another UNICEF WHO plenary tomorrow from 10 to 11:30 a.m. in the same hall. And the gold medal paper, which is scheduled at 1:35 p.m. today, because of this, they're running slightly late, so it will start it at 2 p.m. sharp. Because all the students who have come, this will be from 2 p.m. onwards. And we have an annual general body meeting scheduled at 5 p.m. today in the same hall. Thank you.
Thank you. Just a reminder that we need to continue to abide with our COVID protocols. So my request to all of you is kindly wear your mask, maintain social distancing. We've heard a great deal of what can be done, but ultimately, how do you synthesize this at the national level and how do you bring it together? To sum up all that we have heard and how to go forward, I have none other happy to invite Deepti Agarwal, who is a National Professional Officer at the WHO. Deepti.
Thank you, sir, and good afternoon. So
There is a request from organizer that the gold medal paper should start at 1:35. But Arvind Shah just asked me, because there are international speakers lined up after that. So we'll go by the schedule only, and those who can want to do lunch, they can do it afterwards. So gold medal paper will start 1:35 p.m. only, as per schedule.
Well, I'll try to keep my intervention very short. So I think much of what I'm going to say has already been said by the speakers. My role here is to basically synthesize and say what is the way, going forward in terms of strengthening facility-based care for the newborns, and especially the preterm newborns. Next one. Next one, please. So I think globally, and in India, we see that now 80% of the births are taking place in the health facility. So I think it is only intuitive that we focus on strengthening our facility-based care. But before we start to plan any services or any strengthening, we really need to see that who are these preterms who need care and what type of care do they need. So if you see in this figure, the one thing that is apparent is that, all our services in simple terms can be shown to be delivered at 3 levels of care. One is the primary level of care, which is basically for all kind of newborns and at all health facilities where the baby is born. The second one is the special newborn care unit, which is the level 2 unit. And the third one is the tertiary care level, usually at the medical colleges and maybe, corporate hospitals where we have the intensive care unit. And in India, we see that there are 26 million births annually, and about 13% of them are preterm, which means that we're talking about 3.5 million preterm births. And it is estimated that, globally around 85% are late preterms, that is between 30 to 34 weeks with better, chances of survival. And most of these, 70% of these can basically be saved if they are managed in a special care unit. It's only the 15% who are early preterms or the sick and small newborns, which basically need care in an intensive care unit. And what we need is an interconnected healthcare system, where there is a good referral between the 3 levels of care. Also, what we know is that in terms of essential care, only 1 in 10 newborns actually needs resuscitation, and of those, only 10 to 15% are going to be preterm babies. Next. So what is it that we can do in terms of strengthening our health facilities? And so here I talk mainly about the public health system, but also I think it applies to individual practices, small clinics, clinical establishments, and larger corporate hospitals. In India, we have made tremendous progress over the last 1 decade in establishing a huge network of newborn care facilities. And it has been, and India is quite a front runner in terms and the low middle income countries in terms of provision for newborn care. So I think what we really need to do with the existing health facilities is to address the quality gaps. I think Dr. Mehta mentioned in his presentation that, you know, the problem today is more newborns dying because of poor quality of care than in terms of utilization or access to care. So we really need to assess the service readiness of our health facilities in terms of preterm care. Are they equipped to provide the minimum essential care package at each level? And do they meet the quality standards that are required? The second thing that you heard from Dr. Chilani was about the mother-infant care units. So this concept has come very late to India, maybe only the last 5 years that we're talking of family-centered care and zero separation. But I think this concept has already been there in the US and the Europe between as far back as 1980s and 1990s. So I think the way forward for us is now to re-envisage our units as a mother-infant care units where we mother and baby couplet or the diet together. Also, what we find is that we have a huge network of level 2 care facilities. What we need to do is to map and mobilize all the public and private sector beds. And what we also heard from Dr. Suman was about having integrated units where we not only manage, have beds in the special newborn care or newborn care, but we also have follow-up units like the district early intervention centers, the comprehensive lactation management units, the KMC unit. So they must all come together and be integrated into a single unit moving forward. Also, I think where we are lacking is in the level 3 care. We do not have as many level 3 care facilities as we may need, although it's only 30% of newborns who actually will need this intensive care. But going forward, we need regionalized access to neonatal intensive care, which means that we map out a number of level 2 facilities and see that they are linked to a level 3 facility through a good referral transport and communication. Another important aspect is how do we provide financial protection to families who have sick and small newborns. You know, sometimes these newborns may stay in NICUs and special care units for weeks, So it is really important that, in terms of health insurance, we have some provisions so that long-term care is available without, being catastrophic for the families. And the government of India under the Ayushman Bharat has provided 9 packages for newborn care. So all those who are eligible can get free of cost care in the private health facilities. And as it is a very important piece of information, I think, which all the doctors should know, how to leverage that advantage, how to use those packages to be able to provide good care to these newborns at free of cost. And of course, we need to define what will be the minimum care package at each level. And I think WHO has already defined what those essential care, those care packages could be at different levels of health facilities. And if you look at this mostly aligns with what we are already doing in India. And this is how we need to organize the facilities. These are some of the very important components that we must include in any health facility assessment. And you see that as we move from essential newborn care to more complex care, there are various interventions which should necessarily be available at an appropriate level of facility. So this is what we can assess and ensure that these basic interventions are available and are delivered with good quality. And next very important area is about the human resources. I think the major problems that we face today is about the safe staffing levels, which is about the numbers. How many staff are we able to allocate to newborn care facilities? And also the competency-based learning. How much competencies do the staff have? It is easy to say that, we will initiate feeding early, provide KMC, provide, support for early intervention. But do the workers today that are deployed in our newborn care facilities have this kind of competence? So that is an important aspect. Especially also the other aspect is that do we have the specialized staff which can provide those advanced level of care in our NICUs? So some of these steps that we need to take going forward is, of course, to do assessments, undertake assessments to understand where are those provider gaps and where are the competency gaps. We have to strengthen our pre-service education and to see that those new areas of newborn care, such as infection prevention and control, developmentally supportive care, and all these aspects are integrated well into the pre-service education. We must be working towards establishing a neonatal nursing cadre because we will need specialized workforce to be deployed in our NICUs. And task shifting is another important aspect. I think most level 1 care is at this point of time given by nurses or auxiliary nurse midwives. Also, much of the care in level 2, as we said, feeding, KMC, developmentally supportive, neurodevelopmental care can be provided by nurses and their leadership. And in India, we're already working towards establishing a midwifery cadre. And we hope that in the future, the midwives and neonatal nurses will be able to provide much of the care in units like the MNCUs. And of course, there has to be a lot of changes in HR strategies related to recruitment, well-being of the staff, avoiding their burnout, their motivation and retention. One aspect which I really want to highlight and where I think our health facilities haven't, our health systems haven't done enough, both in the private and public sector, is the follow-up care for neurodevelopmental outcomes. And Dr. Suman has made a fantastic case about, why we need to have this component essentially, inbuilt into the newborn care in our health facilities. So here are some suggestions. And as she said that, a lot of newborns get lost on the way. Even before they reach 3 years of age. So we must, design and put in place electronic medical records, and we must have a system where we are able to track every single, sick and small newborn that passes out of a newborn care unit. And we must keep them under long-term follow-up. And she's already emphasized that we need multidisciplinary teams during inpatient care and at follow-up, which we must bring into our system now for follow-up. And we should be able to track morbidity and disability outcomes. And she has shown that, there children who have mild delay, some with the severe delay. So this is really important because I think it is a reflection of the quality of care in the NICUs. And we must also be able to evaluate what kind of models, facility and community-based models will work best to ensure that we are able to follow up these newborns post-discharge. And she's already emphasized that having parents and family members engaged in the early intervention program is really critical, because studies have shown that early intervention can make a significant impact in terms of neurodevelopmental outcomes. And there the families, the parents and the multidisciplinary teams are going to be critical. Just the last part, and again, is that we will have to work more on the data for action and quality improvement. So the important message here is that we must be able to count and track every small and sick newborn. So we already, because the babies are born in the health facilities, we are already doing the birth and death registration. But I think what we are missing really are the stillbirths. So these are babies who could have made it alive, but for some reason during the intrapartum period, they have not been able to be saved. So recording of stillbirths is really important. This is one silent, epidemic where we're losing as many babies due to stillbirths as due to mortality in the early neonatal period. The other important aspect is the maternal and perinatal death surveillance and response. So newborn death audits must be conducted in all health facilities. Recently, we have worked with the Government of India to establish a MPDSR software, which is now available online. All the newborn care facilities across the country will now, and the hospitals, district hospitals will now be reporting all the deaths and their death audits into this online system. And we hope that this will give much better information for action. We must also have surveillance systems to track congenital abnormalities as they become a significant percentage of the overall neonatal mortality. And as I said that, we must be able to track child development and disability in the graduates from newborn care facilities, because it is a reflection of the quality of care. And we have to find out some mechanism for reporting from private health facilities. So right now we only have for example, 960 units from districts who are reporting, but I'm sure there is a much larger ecosystem out there of private healthcare facilities, which should also become a part of reporting the data and for action. And just the last few points, that the facility-based death audits have to be linked to the quality improvement process. Dr. Rajesh Mehta and Dr. Praveen have talked in detail about the quality improvement processes, and any findings, gaps that that emerge from the death audit are the starting point for the quality improvement. And of course, we must start measuring our performance based on quality of care. So we have done enough of counting how many units are functional, how many people are there, how many beds are there, but we really need to see, how many newborns are going out with retinopathy or prematurity, how many babies end up in neurodevelopmental, delays. So that is the measure of quality, or the antibiotic use, judicious use of antibiotics. So those are some kind of measurements that we must now increasingly look at in terms of the quality of care. And of course, we all must move towards accreditation of newborn care facilities. So when it comes to the public health facilities, the Ministry of Health has already taken a big step in terms of launching the Muskan initiative, where they're going to accredit all the newborn and pediatric care units, but a similar initiative must also come into the private care facilities, so that we can ensure that all facilities provide care as per the quality standards. So that is all from my side. Thank you.
Thank you, Deepti, for summing up all that has been said. As I close, I only wish that all of us here, when we leave, make this promise to ourselves that we will look at one or more of these issues that we have highlighted on quality, not only in our own facilities, but also in other facilities where we will get an opportunity to interact in a variety of capacities. Thank you so much for being with us. Sorry for the delay. Hand it back to the chair.
Thank you so much, sir. Madam Deepti, can you please come on stage?
Dr. Deepti Agrawal, the health specialist from WHO. I have to say something. She has been responsible for this plenary. And, in the last few days, she has contacted all the panelists and she has had a dry run. That is the amount of preparation she has done. We have two predominant supporters, the NNF, that is WHO and UNICEF. And it is our token of gratitude and appreciation. Dr. Deepti, please come forward.
It was hard, it was happening, but it was not happening now, so we're still not sure. Holly. Yes, ma'am, yes, ma'am.
Okay, so our next program is evaluation of the gold medal award papers. We received a total of 19 papers in the office, and they were sent for evaluation to the judges. And out of that, 5 best papers are there. And out of these 5, the top 3 will be selected now. Now to judge these papers, may I request Dr. Mahavir Prasad Jain to please come on the stage. Yes. So Dr. Mahavir, there is small talk of 5 minutes. After that we'll do, because 5 minutes are left. Then we'll call you on the stage. Please play the.
Right now there's a GST sponsor talk on 3 C's of hexavalent vaccination by Dr. Sumita Nayak. Sumita Nayak is a consultant pediatrician at Children's Clinic, Bangalore. Currently the CIAP EB member of Indian Academy of Pediatrics 2021, Secretary of IAP, Bangalore branch 2019 and 2021. We welcome you, ma'am.
Good afternoon. After that intense plenary session, let's take a few minutes off to look at what best we can do to prevent infections in our children. And I will be presenting to you a case in the next few minutes to see why we need to select the best available hexavalent vaccine out of all that is available in the market today. So we do understand that we select hexavalent vaccines for the fact that it is very convenient to use. And we give a 6-in-1 protection. Now, why are we looking at 6-in-1 protection? Because we have to understand that diphtheria there has been a re-emergence of diphtheria. We need to ensure that IPV is definitely administered because that's the only way we can ensure total protection from polio. And of course, we need to keep all the other diseases under control. So when we are looking to select a vaccine, what exactly comes to mind? Of course, top of the mind, the vaccine characteristics in terms of the safety of the vaccine, the effectiveness of the vaccine, of course, what data we have over the years, the experience with it, and the convenience. So these are the points which have come out from surveys done across not only healthcare workers, but also patients. So let's look at why we are looking at hexavalent vaccines vis-a-vis pentavalent. We do understand that the most important addition here is the IPV, and we all know that IPV has been recommended to be given in 4 to 5 doses by the ACVIP. So by reducing the number of pricks and making it convenient, we are doing everything with just 1 shot of the hexavalent. So much more comfortable. Now, what are the vaccines that we have in India? We have a variety of hexavalent vaccines available, acellular as well as wholesale vaccines. We look at the data that we have from studies done in India, and especially we look at what we have got with the 3-component acellular pertussis vaccine. So if we look at what we have in terms of protection against polio, we look at titers of 1 in 8. That's the cutoff which needs to be looked at. And as we can see here, we get almost 100% seroconversion with this 3-component acellular vaccine. So it is, as I said, very, very important. We do understand that when India was declared polio-free in 2014, we had to ensure that the push was maintained and we switched over to the totally injectable polio vaccines. Now, once this happened globally, there was a shortage of IPVs. We do know that we went in for the fractionated intradermal IPVs, but this was only a risk mitigation strategy. Because as you can see here, with the data from India, with 2 doses of fractionated, we hardly got about 90% protection against type 1, 70 with type 2, and type 3 only 97%. So we didn't get 100% coverage. So we still had a small lacuna there. And then once the IPV was available, with 2 doses, the data that has come out is not really very encouraging. So that's what pushed the ACVIP of Indian Academy of Pediatrics to ensure that, to give the statement that we need to have at least 4 to 5 doses of IPV to be given. And no child should go with only a pentavalent and oral polio. So you have to give the IPV, and what better way than to use a vaccine which covers all the antigens together. So as you can see here, with 3 doses of with the Infantrix Hexa open label trials have been done across India, 6, 10, 14 weeks, excellent results in terms of protection against polio. We also look at the protection that we get against pertussis, because we are worried there has been resurgence of pertussis across different parts of India. So we need to ensure there's protection, and we do have the wholesale pertussis giving very, very variable protections. Different studies from different parts of the world have shown varying results. But if you look at the acellular pertussis, protection against the pertussis protection has been very, very consistently high across all studies done globally. So you have here a vaccine which gives data from India in terms of efficacy protection. So once the acellular vaccine was introduced in 1995, definitely uptake was much better, the coverage was much better, and disease definitely came down. So if we look at protection against pertussis, it's a 3-component. We have protection against all the 3 antigens, that's the pertussis toxin, the filamentous hemagglutinin, as well as pertactin. Excellent results have been shown with this 3-component acellular vaccine. Vis-a-vis the whole cell, which does not give protection against the other 2 components. So by WHO case definition, the 3-component acellular vaccine gives almost a 90% protection, hence very, very high efficacy. And so we move on. Once we have understood why we need to give this, we also need to look at the preterm. A lot has been talked this morning about preterms, caring for the preterms as well as follow-up. A very important part is the vaccination. We have to emphasize that we have data with this 3-component acellular vaccine in terms of trials done on preterms. So we do understand that we have to salvage preterms, we have to ensure the best protection. And there are certain myths in terms of immunization. You need to delay. No, please do not delay. They also need protection early because they are liable to more infections. And hence you can give the multi-component, that's the combination vaccine, to these preterms as well. And its immunogenicity is very, very good, as well as it's very well tolerated in preterms as well, has been extensively studied, almost 10 trials. So please recommend, this is the only vaccine which has been tried and tested for protection in preterms. So what's the global experience? I'm finishing up, Dr. Arvind. I'm just wrapping up. Just talk about the global experience here. The vaccine has been there. We have had almost 20 years of usage of this acellular vaccine, over 100 clinical trials, over 94 countries have used this vaccine with over 4 crore kids being vaccinated. So very well proven track record of this 3-component acellular vaccine, which definitely gives us the courage and the conviction that this vaccine has all that we need to take care of our infants. So to sum it all up, this particular 3-component vaccine, Infanrix Hexa, is meeting all the expectations, not only of the parents, but also of the healthcare providers in terms of protection against pertussis. Long-term protection data is available, protection against polio, and of course, very, very importantly, protection of the preterms. Thank you so much. It has been safely used, and this is all the safety data that we have. Thank you so much.
Thank you, madam, for finishing well in time. Now we'll start with the evaluation for our gold medal award papers. May I request Dr. Mahavir Prasad Jain to please come on the stage for judging these awards. Dr. Ajay Arora, sir, please come on the stage. We have total of 5 gold medal papers which is studied out of 19 in the preliminary round. We have, out of these 5, 2 will be presented physically and the rest 3 will be presenting virtually. First speaker will be Dr. Sankalp Dureja, second Dr. Jaspreet Singh Raina, third Dr. Apur, fourth Dr. Sautrik Seth, and fifth will be Dr. Amandeep Kaur. Each presenter has to make sure that they don't exceed the 8-minute time for their presentation and 2 minutes maximum for question answer. A total of 8 plus 2 minutes will be given. So I hand over the mic to our judges.
Thank you, Dinesh. And this is really a very prestigious medal. And out of almost 50 papers, 5 have been chosen for the presentation. And I hope all 5 are of similar quality. But I will request all the participants and the presenters just to keep in time, because time is also important. If they will exceed that time, probably they will have less marks. And first of all, we will be inviting Dr. Sankalp Dureja.
There's some change. I think first the physical. So please stick to the time and 8 minutes for the paper and 2 minutes for question answer. So please stick to the time.
At the end of the presentation, even somebody from the audience can also ask some question. But please be brief if you are asking any question. That is our humble request. Thank you.
Sir, shall I start? Am I audible?
Dr. Sankal, you are audible. Can you just shift your slide to see if it's moving? Can you change your slides? Yes. Go back to the first slide. Dr. Sankal, your time starts now.
Good afternoon, everyone. Thank you, judges, respected teachers, friends. My topic for this presentation is early hydrocortisone versus placebo in neonatal shock, a double-blind randomized controlled trial. Shock is a very dreaded complication in the NICU, and it has a very high mortality rate. The mortality rate in developing countries is much higher as compared to developed countries. Now, in any stressful condition like shock, there is activation of hypothalamic pituitary axis, which leads to release of cortisol. This cortisol is a very important hormone for general adaptation to illness, and it leads to stabilization of blood pressure by various mechanisms. Inadequate cortisol response is responsible for increased chances of physiological instability, multi-organ dysfunction, and death. Various studies have shown that sick neonates are often not able to mount an appropriate cortisol response, and adrenal insufficiency is common in sick neonates. A few studies have shown that adrenal insufficiency and low cortisol levels are present even at the onset of shock. Therefore, a few researchers have tried using hydrocortisone early in the manifestation of shock. In a study by Hochwald et al., which was done in babies who were less than 30 weeks, there was a trend towards decreased deaths and increased survival without BPD in babies who were given hydrocortisone early at the time of onset of shock. In a study by Kovacs et al., which was done in babies who were more than 36 weeks, who had birth asphyxia and were undergoing therapeutic hypothermia, there was a trend towards increased mean arterial pressure and reduced need for inotropes in babies who were given hydrocortisone along with first-line vasoactive agents. So based on this preliminary data, we planned our study with the research question that among neonates with fluid refractory shock, whether early hydrocortisone started with vasoactive drugs compared to placebo will lead to an absolute reduction in mortality by 30% within 14 days of onset of shock. This study was a double-blind, placebo-controlled randomized trial. It was done in level 3 NICU between 2016 and 2018 after taking approval from Institute Ethics Committee. The trial was also registered in Clinical Trial Registry of India. Our inclusion criteria was all neonates who had fluid refractory shock at the time of initiation of first-line inotropes. We excluded neonates who had moderate to severe HIE, suspected or proven congenital heart disease, definite or advanced necrotizing enterocolitis, ongoing GI hemorrhage, suspected congenital adrenal hyperplasia, and those who received steroid in the last 7 days. Our baseline assessment was to note all the clinical details. In baseline echocardiography, we checked left ventricular systolic and diastolic functions. We assessed baseline cortisol levels and other microbiological and lab investigations which were relevant. The enrolled neonates were randomized through a computer-generated random number table. The allocation concealment was ensured by opaque sealed envelopes. All the interventions, all the assessors were blinded to the study except the bedside nurse. And the randomization was done in a stratified manner for babies less than 30 and more than 30 weeks. At the time of randomization, the babies were either enrolled to early hydrocortisone or placebo group. The early hydrocortisone group received hydrocortisone at 1 mg per kg 6 hourly for 48 hours and 1 mg per kg 12 hourly for 3 days, along with first-line vasoactive agents. The placebo group received normal saline at the same dose and at the same schedule. If during the study course, any neonate developed catecholamine resistant shock, he was given open label hydrocortisone and the study drug was stopped. Our primary outcome was all-cause mortality in the next 14 days after onset of shock. The secondary outcomes were catecholamine, incidence of catecholamine-resistant shock, duration of vasoactive drugs and vasoactive inotropic scores, left ventricular systolic and diastolic functions, adverse effects of steroids, and other medium-term outcomes. We estimated sample size based on the study by Ori Hochwald et al. And so keeping in mind baseline mortality rate of neonatal shock by 70% and absolute reduction of mortality by 30%, our sample size was approximately 84. We also did an interim analysis by an independent data safety and monitoring board, which performed a blinded analysis after 2/3 of primary outcome was achieved. The level of significance was ascertained by O'Brien-Fleming approach, and the DSMB board did not find any significant difference in outcome in the two groups. So our results, so around 142 neonates were fully eligible for the study who developed shock during the study period. 58 were excluded because of various reasons, and 84 were finally randomized, of which 43 were allotted to the early hydrocortisone group and 41 got allotted to the placebo group. The demographic details in the two groups were similar. The mean gestational age was approximately 30 weeks in both the groups, and birth weight was 1 to 1.1 kg in both the groups. The two groups were similar in their perinatal characteristics, in the clinical and lab characteristics, and in the echocardiographic parameters and serum cortisol levels. Now coming to the study outcomes. Our primary outcome was mortality. So the placebo group had a mortality of 83%, while early hydrocortisone group had a mortality of 72%. The relative risk was 0.7 with 95% confidence interval of 0.37 to 1.33, and the p-value was not significant. The secondary outcomes, in terms of duration of inotropes, the inotropic scores in the two groups, there was no significant difference. The incidence of catecholamine shock and need for open label hydrocortisone of adverse effects steroids and other media did that there was no significant difference in mortality and other outcomes between early hydrocortisone and placebo group. And therefore, hydrocortisone should be reserved for conventional indication, that is, those subset of neonates who have developed catecholamine resistant shock should be given hydrocortisone. The limitations of study was the study cannot be generalized to other forms of shock and to high-income countries. And our anticipated effect size, the sample size would increase. Research implications: the serum cortisol is low in many neonates with shock, and therefore further studies are needed to find out the appropriate timing and dose of hydrocortisone in neonatal shock. Thank you.
Dr. Sankalp, what do you think that what your study is going to add in our existing knowledge, and as far as the uses of hydrocortisone is concerned in the neonatal shock?
Thank you, sir. So, sir, conventionally, hydrocortisone is given only in that particular subset of neonates who develop catecholamine resistant shock that give hydrocortisone at the onset of hydrocortisone does improve outcome, and therefore we did this randomized controlled trial. However, with appropriate sample size and robust study design, we proved that early administration of hydrocortisone does not help in improving mortality or any other outcomes in neonatal shock, and therefore it should be reserved only for those subset of neonates who require high dose of inotropes and who have catecholamine resistant shock.
Sankalp, what is the long-term follow-up of these babies who receive steroid? Any change in neurodevelopmental outcome on long-term basis?
Yes.
And repeating. Any effect of on long-term basis, you follow up of long-term basis, those who receive steroid on neurodevelopmental
Sir,
outcome.
yes, sir. Sir, am I audible? Thank you, sir. Sir, we, as a part of the study, we did not assess the long-term outcome of the patients. And we know from previous data from other studies with the use of hydrocortisone, like the Premilog study in BPD, that hydrocortisone does not affect long-term outcome in a very significant way. But unlike other steroids like dexamethasone, but as a part of this study, we did not assess the long-term outcomes.
Anybody else from the audience want to ask any question? Thank you, Sankalp. You have done a good job, and definitely it was a well designed and well conducted study. Thank you. Thank you very much.
Thank you, sir. Thank you, all.
Now I invite Dr. Jasprit Singh Rana for the second paper, that is resuscitation with intact versus clamped cord in late preterm and term neonate randomized controlled trial. Dr. Jasprit Singh Rana. You can start, your time starts. Now you can start.
Welcome everyone, respected judges, teachers, and my senior colleagues, and also a very warm welcome to all. I'm very thankful for this opportunity to present the research that is resuscitation with intact versus clamp cord in late preterm and term neonates, randomized controlled trial. So coming to the little bit of background. So till now, delayed cord clamping is not done in neonates requiring resuscitation at birth because we have to prioritize start of post-operative ventilation. However, recent animal studies have shown that initiation of ventilation before cord clamping results in a smoother cardiopulmonary transition. And also human studies have shown feasibility as well as safety of such approach. However, large studies are lacking. So our research question was whether in late preterm and term neonates needing resuscitation at birth, does intact cord resuscitation as compared to clamp cord resuscitation results in a better postnatal physiological transition as measured by expected cord score at 5 minutes of age. Our primary objective was to compare expected cord score at 5 minutes of age, and under secondary objective, we evaluated various resuscitation events, neonatal morbidities, as well as maternal safety outcomes. Now coming to material methods. So this was a single center, open label, parallel group, randomized controlled superiority trial done in Tertiary Care Hospital of North India over a period of 16 months and was registered prospectively under CTRI. Study subjects, that is our newborns born at more than 34 weeks of gestation and those requiring resuscitation beyond initial steps. We did a two-step enrollment. In the first step, we identified the women who were admitted in the labor room because of with period of gestation more than 34 weeks and having risk factors for resuscitation. The following risk factors for resuscitation as given in NRP update 2015 were included. Whether having congenital malformation in the fetus or these complications which can interfere with their own well-being or with conduction of BCG were excluded. These eligible women were then approached for consent and then the randomization was done. For randomization, random number sequence was generated using blocks of variable size and was stratified for mode of delivery and was enveloped. We used severely opaque envelopes for application concealment and which were opened just before the time of delivery. Study subject. Our study subject include newborns born at more than equal to 34 weeks of gestation and requiring resuscitation beyond initial step. So these were included in, these were the final step that was done at the time of birth. We identified these women, these babies who ultimately required post-operative ventilation. For randomization, after randomization, there were two groups, there are two intervention groups, one is intact cord resuscitation group, another one is clamp cord resuscitation group. In the intact cord resuscitation group, we use a special design trolley called the ICR trolley, which was equipped with a overhead radiant warmer, a T-piece resuscitator, a pulse oximeter, and an inbuilt suction machine. The figure on the right shows the position of the neonatologist and the obstetrician during the vaginal as well as during the cesarean delivery. So in the ICR group, if the baby is breathing at birth, after initial steps, a DCC for 180 seconds was done. However, if the baby was not breathing after initial steps, positive pressure ventilation was started with intact cord. And this resuscitation was continued for at least 180 seconds or till the onset of spontaneous breathing with a maximum time limit of 5 minutes. While in the ICR group, if the baby was breathing at birth, he or she received DCC for 180 seconds as standard care. While if the baby failed to start respiration, we clamp the cord and cut it, and then we started with initial steps as well as the positive pressure ventilation. Our primary outcome, that is expanded CAR score at 5 minutes of age. Little bit about it. So normal conventional CAR score consists of these well-known 5 components, so that a normal baby get a maximum score of 10. However, the CAR score doesn't take into account the intervention baby is receiving at the time of scoring. So in expanded CAR score, we add a score of 1 for each of these interventions if the baby doesn't receive this intervention. So a normal baby can have a maximum score of 17. We use expanded CAR score because it gives idea about both baby condition as well as the intervention required. Secondary outcomes were admission temperature, bilirubin as well as hematocrit at 24 hours, need of an ICU admission, incidence of HI, seizure, need of hypothermia, and maternal safety outcomes. Sample size, it was calibrated to detect improvement of at least 1 in expanded CAR score with a standard deviation of 2, power of 80%, and a two-sided alpha error of 0.5. A total of 63 units need to be enrolled in each group. Statistical analysis was done using standard methods, and intention to treat principle was followed. Now presenting the results. So during the study period, a total of 1181 mothers with risk factor for resuscitation were delivered. Of these, roughly half were excluded because of either pre-exclusion criteria or refusal of consent, or because of operational reasons, including the COVID deliveries. So finally, 496 women were randomized, 247 in the ICR group and 249 in the CCR group. In the ICR group, around 71 babies required positive pressure ventilation and were included for the final analysis, while in the CCR group, 91 required positive pressure ventilation and were analyzed for the primary analysis, primary outcome. We can see in the ICR group, out of the 71, cord clamping was done within 30 seconds only in 1 unit, while in 16 unit, it was done between 60 to 180 seconds. Coming to the baseline characteristics, baseline maternal characteristics like pregnancy as well as intrapartum characteristics were similar between the two groups. We can see the baby requiring positive pressure ventilation have higher incidence of abnormal fetal heart racing and the need of cesarean section. Baseline neutral characteristics like gestational age, birth weight, being SGA or male were similar between the two groups. Our primary outcome, that is the median of CAR score at 5 minutes, was significantly higher in the ICR group compared to the CCR group with a mean difference of 1. Conventional CAR score was similar at 1 minute between the two groups. However, it was significantly better or higher in the ICR group at both 5 and 10 minutes. Similarly, heart rate at 1 minute was similar between the two groups. However, at 5 and 10 minutes, it was significantly lower, that is with a more stable and a normal pattern, as indicated by smaller standard deviation at both 5 and 10 minutes in the ICR group. Oxygen saturation was higher in all timelines, 1, 5, and 10 minutes. Need of positive pressure ventilation. 28.7% of babies in the ICR group required positive pressure ventilation compared to 36.5% in the CCR group. And we can see the relative risk upper bound just crosses the 1, showing a trend towards lesser need of positive pressure ventilation among the babies resuscitated with intact cord. So this is the Kaplan-Meier survival curve showing the proportion of the babies requiring positive pressure ventilation at any time point. And it was found that it was significantly lesser among the babies resuscitated with intact cord. Secondary outcomes include admission temperature was similar between the two groups. Heart rate at 12 hours as well as oxygen saturation at 12 hours was significantly better in the ICR group as compared to the CCR group. As expected, bilirubin as well as hematocrit both were higher in the ICR group than the CCR group, indicating the successful placental transfusion. While incidence of HI, seizures, and therapeutic hypothermia was similar between the two groups. Less babies in the ICR group required an ICU admission. A large sample size, both mode of deliveries were included, and high rate of adherence to ICR protocol. Limitations were large post-admission exclusion as well as unblinded nature, both of which were unavoidable because of the study design. And we were also not powered to see impact on important outcomes like HI, mortality, and neurodevelopmental outcomes. To conclude, intact cord resuscitation results in a better postnatal physiological transition in the form of higher CAR score, stable heart rate, higher oxygen saturation, lesser need of resuscitation, and lesser need of intensive care. Implication for practice, that for resuscitation can be practiced, but adequate human resources and appropriate equipment are required. And for research, large multicenter trials are required to see the efficacy of this approach on important outcomes like HI, mortality, and neurological outcomes. Thanks.
Thank you, Dr. Jaspreet. Very well conducted study. How you will apply this study, especially in the public? Do you think in the near future there will be any application of the study in the public, especially hospitals and smaller centers, where most of the births are taken?
Thank you, sir. Sir, although our study was done in a tertiary care hospital, but there is a recent trial by the name NAPPOD 3 trial, which was done in a setup where deliveries were carried out by midwives. It was done in Nepal. They also show a significant improvement in APGAR score, heart rate, and SpO2 in these babies. So, but we need to train these healthcare workers before applying this. And we also need special trolleys. Although in NAPPOD trial, they didn't use any special trolley, but their failure rate was very high. Their protocol violation was very high. Roughly around more than 50% of babies were having failure rate in that study. So for district hospitals, special trolleys provision or adequate training has to be must before applying this.
What is the rationale for using this intact cord resuscitation in severe bursts?
Sir, in birth aphasia, two main components are hypoxia and poor perfusion. While by continuing the placental transfusion, we can allow the mitigation of the hypoxia because placenta can serve as a point of gas exchange till we establish a spontaneous efforts or spontaneous good ventilation in the baby. Secondly, a larger volume will be transferred to the pulmonary blood flow, resulting in pulmonary vasodilation and good oxygenation. And also, it has been seen that blood pressure as well as cerebral blood flow, they are more stable in these babies who receive intact cord resuscitation. So even severe birth aphasia babies can also benefit from this. Also, recent studies have shown that babies who receive delayed cord clamping at DCC, they have increased myelin content. So these stem cells, which baby gets during this placental transfusion, can help them during the later time to have that neuroplasticity, which the sir was talking about a little bit earlier. So that can help in various ways.
Any long-term follow-up of your studies for HI?
Sir, yes, we plan. We plan for, although we have planned for a short-term follow-up only at 3 months, we were planning to go for a Heinz score in these babies, and we will publish that also.
Do you see any in future whether this kind of practices will be taught or will be included in NRP also?
So it is a baby step. Still we get more evidence, then I think there might be a change in the NRP also. It's like exit process done in congenital diaphragmatic hernia patients. So I think this will be a good thing.
Thank you. Thank you very much. Anybody else want to ask any question? Thank you, Dr. Jaspreet. Thank you. Nice presentation.
Now I invite Dr. Apurva for next paper, that is quality improvement initiatives on sustaining KMC practice during COVID pandemic. Dr. Apurva.
Yes, sir.
Dr. Apurva, you can start sharing your screen with us.
Ma'am, just 1 second, ma'am.
I think Dr. Apurva is not able to join.
I'm so sorry, sir. Are my slides visible, sir?
You have to start sharing.
If she is not able to connect, can we take the next one? We have one, Dr. Amandeep Kaur is here. So I invite Dr. Amandeep Kaur to speak about his paper on ultrasound guided umbilical venous catheter insertion to reduce rate of catheter tip malposition in neonates, a randomized control trial. Dr. Amandeep Kaur.
A very good afternoon to all. 1 minute. The time starts now. So I did this study on ultrasound guided umbilical venous catheter insertion to reduce rate of catheter tip malposition in neonates. Umbilical venous catheters are commonly used for intravenous therapy in premature and critical infants. X-ray is the standard investigation to confirm UVC tip position. UVC tip malposition is the most common complication of UVC, and rates can vary from 20 to 50% to even 70% in some studies. Thus, preventing malposition will avoid manipulations and also additional radiation exposure. Malposition catheters can also further lead to various complications. Point-of-care ultrasound is increasingly being considered for locating UVC tip position, as it has a good sensitivity and specificity in accurately locating the catheter tip, no radiation exposure, real-time assessment, and immediate manipulation if catheter tip is misplaced. So we went ahead with this study to answer the question, does ultrasound-guided umbilical venous catheter insertion in neonates, in comparison with standard insertion, reduce the rate of catheter tip malposition? The outcome of my study was the rate of catheter tip malposition in ultrasound-guided group versus that in standard insertion group. And it was based on the first X-ray after UVC insertion. The secondary outcomes were the number of patients requiring additional X-rays, the time taken for catheter insertion, and successful placement of UVC using the technique described by Kishigami. It was an open-label randomized controlled trial done in a level 3B NICU from March to August 2021. Institutional Ethics Committee approval was obtained and CTRI registration was done. All neonates less than 1 week of age requiring UVC insertion were eligible. Informed written consent was also obtained. Infants with major congenital anomalies of thorax and abdomen were excluded. We did a block randomization with variable block size of 2 to 4 using computer-generated random number sequence. Blinding was not possible due to the nature of intervention. Allocation concealment was done using serially numbered opaque seal envelopes. So depending upon a survey done in our unit in the 3 months preceding the study, we found that the UVC malposition rate was found to be 78%. So to achieve a relative reduction of 50% and a two-sided alpha error of 0.05 and a power of 80%, the sample size was estimated to be 26 neonates in each group. The standard placement group, the catheter insertion length was calculated using the formula by Shukla et al. And routine insertion was done. Well, in the ultrasound guided group, we did during the UVC insertion, the ultrasound was done by the sonocyte edge by a single investigator with a sector probe, which was placed longitudinally in subcostal region, while the insertion of the catheter was done by a trained neonatal fellow. UVC catheter sizes were according to the weight, and we had a portable in-house digital X-ray machine for checking the tip position of the catheters. So while the UVC was inserted, it was visualized at the IVC RA junction by ultrasound, and sterility of the probe was maintained by disinfection followed by covering the probe with a sterile finger glove. If the catheter goes towards the portal vein, like it sometimes does, Kishigami technique was applied. So this technique involves a gentle pressure with the ultrasound probe over the liver to align the umbilical vein to the ductus venosus, thus directing the catheter tip to reach the right position. Tip position on X-ray determined the final outcome. The first X-ray taken after insertion was sent to the consultant who was blinded to the group allocation from primary outcome assessment. Malposition was defined if the tip position was either coiled or curved, that was inside the liver, or either it was too high, that is above vertebra T8, or it was too low, that is below T10. If it was high or low, necessary repositioning was done and confirmed with a repeat X-ray. If the position was still lower after the manipulation, then catheter was used for administering IV fluids only and removed within 1 week. If it remained in liver or splenic vein despite manipulation, UVC was removed and a PICC was inserted. So this is my study flow chart. We assessed 68 neonates for eligibility and randomized 53, 26 into the intervention arm and 27 into the control arm. Appropriate statistical analysis was applied. Relative risk and 95% confidence interval were calculated, and we analyzed using the STATA version 12. Coming to the baseline characteristics of the study groups, it was comparable in both the groups. While in the primary outcome, the rate of catheter tip malposition, as we can see, was 42.3% in the ultrasound guided group, while it was 74% in the standard insertion group, which led to a reduction in the malposition rate around 43%, and it was statistically significant. Also, among the secondary outcomes, the need for additional X-rays was reduced by half in the ultrasound group. And also the time for insertion of the catheter was also reduced, significantly reduced in the ultrasound group. We did not note any major immediate catheter-related complications in both the groups. So in a study, there was 43% reduction in the rate of catheter tip malposition with ultrasound-guided UVC insertion. To our knowledge, no RCT comparing ultrasound-guided insertion with standard insertion with malposition of the catheter tip as an outcome is published. In the study by Fleming et al., there was 46% reduction in the time taken for the procedure, while in our study, it was reduced by 20%. The number of X-rays also were reduced by half in the ultrasound group, which is comparable to their outcome, in which X-rays were reduced from 4.1 to 2.3 X-ray per patient. Ishigami et al. Placed the UVC correctly using their method in 93% neonates, while it was successful in only 53% neonates in our group. The strength of my study is applicability in a busy NICU. Neonatologists can place the line and confirm the position in real time and start the IV fluids. Availability of portable in-house digital X-ray machine and console reduce the total procedural time. Use of Kishigami technique reduced rate of catheter tip malposition. There were some limitations. We did not evaluate whether the size of umbilical catheter or the day of insertion of catheter affected malposition rates. Also, we did not evaluate the long-term catheter-related complications during hospital stay. So in conclusion, the use of ultrasound in guiding UVC placement significantly reduces catheter tip malposition rates compared to standard insertion. It also reduces the time taken for insertion, number of manipulations, and radiation exposures. With adequate training, it could be incorporated in routine bedside practice during insertion for optimum placement. Thank you.
Thank you, Dr. Murali. It's all right that the only three things, the time was less, malposition rate was less, and the number of X-rays was less in your study.
Yes.
But definitely one thing which you already have mentioned in the paper, the rate of complication, especially the long-term complication, comparing these two is also important. So I think that should have also been done, especially in this kind of.
So we looked at the immediate complications like temperature instability or vital changes during the procedure or any arrhythmias. There was nothing immediately, but yes, I agree we should have looked at the other long-term complications, but because there were many confounding factors looking at them, so that's why we didn't go ahead with them.
Community setup, what is the role of this ultrasound guided versus normal? Because the availability of portable ultrasound at community level.
Yes, thank you, sir, for your question. Actually, the UVC insertion is a procedure which is done generally in sick neonates, and the care is generally taken in level 3 NICUs, and mostly nowadays we have a portable machine in that. The aim of my study was also for my unit itself, because the baseline malposition rate was pretty high. And this study helped me and my unit in reducing the malposition rates. So that goal was accomplished, and we used all the materials and so that we can carry it forward. And as in a public sector hospital, we don't need any additional funds except the machine.
This your intervention lead to decrease in the morbidity and decrease in mortality in your intervention.
Sir, actually, UVC, when it is malposition, it is a very big problem. when it goes towards the liver or if it's very high, it increases the burden on the patient also when we need to repeat the manipulations and repeat the X-rays. So definitely, if it is positioned the first time only, it will affect, it will decrease the morbidity in the patients. So that was my goal, which we achieved with this study.
Anybody from the audience want to ask any question to Dr. Mandi? Thank you, Dr. Mandi, for a very brilliant study. Thank you.
Now I invite Dr. C for the next paper, that is nasal HFOV versus nasal IPPV as a post-extubation respiratory support in preterm infant, the randomized controlled trial. Dr. C, please.
Good afternoon, everyone, and my esteemed judges. I'd like to. I'm Dr. Sophie.
Mail. Safaria.
Hello, am I audible? Are my slides visible?
Yeah, you can start.
I'm Dr. Soutrik. I'm going to present my paper on this platform virtually. And my paper is on nasal high-frequency oscillatory ventilation versus non-invasive positive pressure ventilation as a post-extubation respiratory support in preterm neonates, a randomized control trial. It is performed in IPGMR and SSKM Hospital, Kolkata, under the guidance of Dr. Bijon Saha and Dr. Suchandra Mukherjee. CTRI registration had been done, and there was no conflict of interest, and there was no funding also. Invasive mechanical ventilation is still the best modality of treatment that we can give to babies with respiratory distress, but it has got its own long-term morbidity. Extubation failure is also a significant problem in preterm neonates, and subsequently there has been a search for these different non-invasive respiratory supports, out of which the non-invasive high frequency is just another brick in the wall. The different modalities that are available includes the CPAP and its varieties, the non-invasive positive pressure ventilation and its different varieties, the nasal high frequency ventilation, and the heated humidified high flow nasal cannula, which is an inconsistent method of delivering pressure and IPS. According to the latest evidence, NIPV has been found to be more effective in decreasing the extubation failure compared to nasal CPAP. However, in that study and also in the systematic review of Cochrane, they have shown that the synchronization may provide better results, which, however, with the present array of devices of non-invasive ventilation is very difficult to achieve. And there are very few machines which are developed, which are giving this synchronized form of NIPV. So the principles from nasal high frequency is that we are getting the benefits of invasive high frequency ventilation without any need for synchronization and efficient carbon dioxide removal because of active expiration. There will be less volutrauma, barotrauma because of lesser physiological tidal volume, and we can work at a higher mean airway pressure. Also, this is the advantage of non-invasive ventilation because of a non-invasive interface. So different clinical studies that have been performed till date, starting from 1998, Van der Hoeven, have all shown that this leads to less intubation, better PCO2 clearance. And accordingly, after 2019, also several studies have proved that it is feasible. Nasal high frequency leads to less apneas, less ventilation. So our study, the research question was, in preterm infants born between 26 to 37 weeks, can nasal high frequency compared to nasal IPPV prevent extubation failure better within 72 hours of extubation? The aims and objectives were primarily to compare the extubation failure during the first 72 hours post-extubation, and this was a prospective randomized controlled trial, single-centered RCT conducted at the level 3 neonatal unit between August 2019 to October 2020. The inclusion was all newborn infants born between 26 to 36 plus 6 weeks of gestation. Inborn babies up to 15 days of postnatal age was included. In required and needed invasive ventilation for at least 12 hours, and parental consent was obtained. Excluded were less than 26 weeks, more than 37 weeks period of gestation, outborn babies, major congenital anomalies, or chromosomal anomalies, upper airway anomalies, and severe congenital asphyxia. So a nasal high frequency in our case was provided with the SLE 6000 ventilator with an appropriate feature cycle interface. NIPV was provided with a Draeger Babylog 8000 plus ventilator with appropriate feature cycle nasal interface. So the cycling of prong and mask done as per unit protocol every 4 hours, and the prong and the mask size was chosen so as to have a snug fit. Oxygen saturation probe was placed on the preductal location, and orogastric tube placement and periodic gastric aspiration was done to prevent gaseous distension of the stomach. The parameters that were used initially, nasal high frequency was started at a frequency of 10 to 12 hertz with an amplitude of 25 to 35 centimeters of water, P mean of 8 to 10 centimeters of water, and FiO2 to maintain a saturation between 90 to 95%. NIVV, on the other hand, PIP of 2 centimeters above the extubation set PIP, PWP of 4 to 6, respiratory rate of 40 to 50, and FiO2 adjusted to maintain the saturation between 90 to 95%. Weaning, FiO2 was first weaned in the nasal high frequency group by 3 to 5% while maintaining the target saturation until it reached a FiO2 of 30%, and P mean then thereafter was reduced by 1 centimeter every 2 to 3 hours to 6 centimeters of water. Similarly, NIPV, the FiO2 was decreased first, followed by the PIP. Discontinued when there was minimal or no signs of respiratory distress and the FiO2 was less than 30% with a P mean of less than 6 in case of nasal high frequency, and similarly PIP of less than 13 and FiO2 less than 30% in case of NIPV. Upgradation in case of increasing respiratory requirement, P mean was increased to maximum of 12 centimeter and FiO2 maximum of 60%. On the NIPV group, PIP was increased to maximum of 25 centimeter, 25, and a PWP of 6 and FiO2 of 60%. After that, it was considered as failure. In case of failure, both the arms were intubated. Primary objectives: extubation failure within the first 72 hours after extubation, and secondary objectives have included bronchopulmonary dysplasia, mortality, composite death BPD ratio, ventilator-free days, NEC, late onset sepsis, pulmonary ALX, intraventricular hemorrhage, feed intolerance, full feed days, retinopathy of prematurity. Sample size calculation, considering a need for reintubation in studies using NIVV as a post-extubation method of 35% and our own liquid data ranging between 25 to 35%, chose to study 43 subjects in each group to have an 80% power and a significance of 0.05% to reduce the extubation failure rate from 35 to 10%. Randomization was computer generated and the total population was subjected to stratified randomization. The investigator could not be blinded due to the nature of the study. However, the assessor was blinded. The data analysis was done by Metcalfe 19.4 and Graphite Prism 7. Routine descriptive statistics were used and significance level was set at P less than 0.05 for all comparisons. So this is the console flow chart. During that period, 650 deliveries were occurred, out of which the assessed for eligible were 112 babies, excluded were 26 babies, randomized 86. Subgroup analysis, subgroup division was done. Allocated to nasal high frequency and NIPV, and there was no loss to follow. All of them were analyzed. So baseline characteristics were similar in both the groups, including the antenatal steroid coverage, the Abgo score, the birth weight, the positive pressure ventilation, intubation, RDS, including the SNAP2 scores, which determine the level of severity of the disorder. Results, the baseline parameters were comparable in both the groups, and out of the 112 babies, 86 babies had a mean gestation of 32 weeks and a birth weight of 1660 grams, and they were subjected to stratified randomization. There was no significant reduction in the reintubation rates within 72 hours post-extubation, 9.3% in the nasal high frequency group versus 11.6% in the NIPV group with a p-value of 1. Median days of assisted ventilations were 7 and 8 days respectively in the nasal high frequency and the NIPV arms, and similar median days on oxygen were 8 and 9 days respectively. There was no difference in the BPD, IVH, ROP, composite death BPD, etc. Among the other secondary outcomes, however, nasal high frequency showed a lesser trend towards the NEC, 4.3% versus 11.6%, however, not statistically significant. Similar for feed intolerance, 37.2% versus 58.13%. PCO2 post-intervention was similarly less in the nasal high frequency group. Full enteral feeds were reduced by 1.5 days in the nasal high frequency group, and length of hospital stay was also reduced in the nasal high frequency group, but none of these were statistically significant. So this is the primary outcome as we have discussed. These are the secondary outcomes. There was not much difference. However, there was a reducing trend in the nasal high frequency group. Again, coming for the subgroup analysis also for 26 to 32 weeks and 32 to 37 weeks, there was not much of difference. However, there was a decreasing trend in the nasal high frequency group.
Dr. Seth, your 8 minutes are up.
Please wind up in 30 seconds.
Okay. Limitations, there is a small sample size to derive any statistical significance. The comfort level of the babies were not quantified objectively, whether intermittent use of mask led to lesser efficacy needs to be investigated further. Similar mean airway pressures in both arms made the comparison more realistic, but again, low mean airway pressure in the nasal high frequency group of 8 to 10 centimeters of water probably led to less recruitment, less efficacy. Long-term side effects and neurodevelopmental outcome needs to be assessed, and this has been a single center study. So there was no superior age of nasal high frequency over NIPV in the reintubation rates or any other secondary outcomes. However, nasal high frequency appears promising in reducing the feed intolerance rate and the hospital stay. And this has been the first randomized control trial comparing nasal high frequency versus the NIPV as a post-extubation modality in preterm infants worldwide. So I'd like to thank you all and thank particularly the guardians of the babies, my parents, my wife, without whom this study would not be possible. Thank you for your patient hearing, and I may take some.
Thank you, Dr. Seth. So in your study, the results are almost comparable. So on the basis of only secondary outcome, what is your recommendation? What you want to see that only the milk intolerance and the MEC are the sufficient criteria to promote HFOC or other things?
So first of all, I would like to say that our study was based, the sample size was calculated based on Western data. And our actual NIPV failure rate is lower than that. So probably if we had considered our own NIPV failure rate, our sample size would have been large to derive any statistical significance. Again, from a respiratory point of view, giving respiratory support and thinking about lowering the number of ventilation days and number of feed intolerance, I think this is not feasible at this moment. It will require more studies, more multicentric studies to come to a conclusion.
Compare the cost-benefit analysis of these two different modalities.
The cost-benefit analysis at present in India and also outside, the non-invasive positive pressure ventilation machines that are available are derived from the ventilator. So around 18 to 20 lakhs is the cost. Nasal high frequency also similar cost, but the availability of nasal high frequency at present in India as well as outside is less, much similar to the synchronized form of NIPV. So this we are more comfortable probably with a non-synchronized NIPV at present compared to a nasal high frequency. But nasal high frequency from our experience is easier to handle, and we also could not consider the comfort level of the babies. Probably if we had considered, we have found that the babies were more comfortable with the nasal high frequency.
Thank you.
Thank you, Dr. Soprik. Thank you very much for studying your hard work. Thank you.
Thank you.
Now, Dr. Apurva, are you ready? We can start your presentation as quality improvement, initiating on sustaining KMC practice during COVID pandemic. Dr.
Yes.
Apurva.
Yes, sir. So good afternoon, respected judges and delegates. I apologize for my technical glitch earlier. And I'm Dr. Apurva. I'm going to present my paper on quality improvement initiative on sustaining kangaroo mother care practices during COVID pandemic. Coming to introduction, we all know that kangaroo mother care is an evidence-based standard of care for preterm neonates. And even the latest Cochrane review 2016 reported that neonates who received KMC had a 40% reduction in mortality, 72% reduction in hypothermia, and 65% reduction in severe infections compared to standard of care. Coming to the need for the study, COVID-19 pandemic has disrupted healthcare systems worldwide, and especially the restrictions imposed during COVID pandemic have affected the provision of quality of care. Roberton et al. In 2021 reported a 52% reduction in institutional births, 20% increase in preterm birth rates, and threefold increase in facility neonatal mortality rate. And our Indian study, Sumanro et al. Has showed that kangaroo mother care services was disrupted for COVID positive mothers as well as for the COVID negative mother baby dyads. And their study found that KMC coverage was generally low during the COVID pandemic. Our unit is a tertiary care hospital. We already had a quality improvement project on kangaroo mother care practices in place from January 2009, with the rate of initiation of the KMC before COVID pandemic well sustained at 86%, and mean duration of KMC was sustained at 8.5 hours. But during COVID pandemic and lockdown, the rate of initiation of KMC has reduced to 43.4% and mean duration to 1.5 hours, hence the need for the study. Coming to the aim statement,
We have formulated an aim statement to increase the rate of initiation of KMC in a stable, that is, who are not on any cardiorespiratory support, low birth weight babies less than 2,000 grams, admitted to our special newborn care unit from existing 43.4% to 80% over a period of 8 weeks from the month of August to September 2020. The main outcome indicator being number of eligible infants initiated on KMC by total number of infants eligible for KMC. And then we have formed a QI team, including the team leader, who is the in-charge sister in our SNCO, a DM resident, and including the team members like staff nurses, resident doctors, supporting staff, parents, lactation counselors, and SNCO medical officer. Team also included administrators, data recorder, and a data analyzer. And we have found the bottleneck in implementing the KMC practices by forming a fishbone analysis. And we're coming to policies. We already had an existing policy for kangaroo mother care in place, but we were not following the policy during COVID pandemic. And we had a separate KMC room, but it was very congested because of increase in number of admissions. Coming to the persons, there was inadequate staff at any point of time because of COVID quarantine leaves for 50% of the staff. And there was lack of awareness and guidance for KMC practices among the mothers. And there was a fear among healthcare staff of contracting COVID. Coming to materials, we initially did not have a regular supply of PPE kits and N95 masks. And we have, by Pareto principle, we found that 80% of lack of initiation of the KMC was because of fear among the healthcare staff of contracting COVID, healthcare staff working with half of the capacity at any point of time, and lack of guidance and assistance to the mother for KMC practices. Here, as we can see, this is the Pareto chart, and we can see that 80% of the causes for lack of initiation of KMC were because of the first 4 causes: lack of guidance, inadequate staff, increased workload, and fear of contracting COVID. And then as a team, we have proposed few change ideas to implement during the intervention phase, like emphasizing on the benefits of KMC to all the QA members, decongesting the KMC room, ensuring regular supply of PPE kits to healthcare staff, identifying a KMC leader among the mother, and display of IEC material, and then group counseling of mothers by doctors every day. Come to methodology. The data source staff nurse documented the number of infants initiated on KMC in a register every day, and the data was collected every day and reviewed every week during meeting of team members, and further plan of action was formulated during the intervention phase. As you can see, this is our register recording the baby birth weight and also the duration of the KMC duly signed by a medical officer. And then coming to the interventions. Our first intervention was sensitizing our staff and also group counseling of mothers on KMC every day. And we have done the first intervention in 4 PDSS cycles, plan, do, study, act cycles. Coming to cycle 1, we have sensitized the doctors through WhatsApp group, and then cycle 2, sensitize the nursing staff in each shift by doctors on KMC by IEC material. And cycle 3, sensitizing the supporting staff on KMC with the help of IEC material. Cycle 4, sensitizing the mothers by group counseling of the everyday. The process indicators, including is the number of doctors, nurses, supporting staff, mothers who are aware of KMC practices by number of them who are counseled. Coming to the intervention 2, which was decongesting the KMC, which was done in 4 PDSS cycle was extra chairs and tables for doctors were removed. Second cycle, the stable term infant babies requiring only phototherapy was shifted to another new room. Cycle 3, the spacing of beds and chairs as per social distancing norms by supporting staff in each shift was maintained. Cycle 4, security personnel did rounds in each shift to reduce the number of attendants in the KMC room. The process indicator being number of times the security personnel were doing rounds in KMC room every day, number of days in a week where the KMC room was maintained as per the social distancing norms. This is our unit with the this is our KMC room with the KMC chairs, and then this is a resident doctor counseling the mothers. Coming to intervention 3, which was providing PP kits and N95 masks to all the healthcare staff. This also was done in 3 PDSS cycles. In cycle 1, we have spread awareness to healthcare staff in each shift on use of N95 masks. On cycle 2, we have ensured availability of N95 masks, gloves, and face shields to all cadres of healthcare staff. And then cycle 3, we have supervised the compliance. And this is one of the healthcare staff donning the PPE kit and then counseling the mothers on KMC. Intervention 4 was a KMC leader. We have identified a KMC leader among the mothers by doctor and we have rotated it every week. And then in cycle 2, we have appreciated the KMC leader in the presence of all mothers by doctors every week. And cycle 3, we ensured that KMC leader helped her peers in providing KMC to their infants. And the process indicator is the number of times a KMC leader is identified in a month, number of days in a week where a KMC leader helped other mothers in providing KMC. This is one of the mother helping the other mother in providing KMC. Intervention 5 was involving the lactation counselors. We have consulted lactation counselors on importance of KMC during COVID pandemic. We have provided masks and face shields to them. And then we have ensured the presence of lactation counselor by daily documenting their attendance. These are our lactation counselor helping the mothers on KMC. And then we have documented the counseling by the lactation counselors in a register. And then finally, intervention 6 was virtual meetings. We held the audits by virtual meeting of all the team members every month, and then we have documented the attendance of all the team members during the virtual meetings. The statistics, as we can see from 2019 to 2021, the admissions in SNCU has increased. Even the weight-wise admissions, more among the 1,000 to 1,500 grams weight of preterm babies, admissions have increased. And then the baseline characteristics of birth weight and gestational age were compatible between the baseline and intervention phase. The process indicators which you have monitored were the knowledge, attitude, practices of the healthcare staff, number of days where the KMC room was arranged as per social distancing norms, and the number of days with adequate supply of N95 mask, and the compliance of healthcare staff to N95 mask, identification of KMC reader, and compliance of the lactation counselor. Outcome indicators were the percentage of initiation of KMC among eligible infants and also the mean duration of the KMC. And these are the 6 interventions where the percentage of initiation of the KMC has increased from a baseline of 43.4% to 88%, and mean duration had increased from 1.5 hours to 4 hours at the end of the intervention phase. And we have also monitored the compliance to the process indicators, where, as we can see, in the sustenance phase, we had 100% compliance to the supply of the PPE kits.
Dr. Apurva, time is up.
Oh, sorry. And I would like to conclude. And the challenges we have faced were regulating the number of attendants visiting the KMC room, overburdened healthcare staff during COVID pandemic, maintenance of KMC hours during evening and night hours, ensuring attendance of all the team members during virtual meetings, and increase the duration of the KMC was a challenge for us. To conclude, restoring the KMC practices for preterm infants during COVID pandemic was of paramount importance, and quality improvement initiative is a simple and cost-effective method which has improved KMC practices in our unit without any addition of the extra manpower. Thank you.
Thank you, Dr. Purva. Thank you. You did a very good job in the COVID time. Of course, every aspect of the health system affected, and more so our neonatal services, and keeping all the corona or COVID appropriate behavior, and thus providing the KMC and other services with your few innovation and the good ideas, and apart from the facing all the challenges was good. And that's why you were able to do better as far as number of KMC care is concerned.
Yes.
So that was very good. And definitely it shows whenever there are difficult times, we have to change our strategy according to the challenges, and we have to do something innovative also.
Yes.
Thank you, Dr. Purva.
Dr. Apurva, can you tell me the difference between the early KMC outcome and the late KMC? Most of the time KMC started on 3rd day, 4th day. So any benefit of early KMC? Have you studied this in your study?
Sir, actually in our study, we have not measured the KMC outcomes. Earlier, in the first QI phase, we had measured the other secondary outcomes. But in this study, during the COVID pandemic, actually, we as such did not see other secondary outcomes.
And what is the most challenging? Cycle 1, 2, cycle 3, and cycle 4. What do you feel the most challenging out of all 4 cycles?
Most challenging
is to convince the SNU staff, to convince mother. Out of 4 cycles, which is the most challenging?
The most challenging was to convince the staff, sir, healthcare staff, because there was a lot of fear among the healthcare staff of contracting COVID, because the COVID status of the attenders, they were not, it's not known to us at that point of time. So mostly convincing the healthcare staff and involving them in helping the mothers in providing the KMC was very difficult for us. So.
Thank you, Dr. Purva, and thank you, organizers. And definitely all the 5 participants, their papers were very good, their presentation was very good, and their content was very good. So I congratulate all of them for their hard work and for their dedication and their commitment shown towards the neonatal care.
Thank you, Dr. Mavi, Dr. Ajay. I will take just 1 minute to total and collate the results. Please wait for a few seconds, and then we'll announce the results.
So the important things left will be the general body meeting in the evening, same venue, social neonatology paper tomorrow, and UNICEF WHO plenary number 2. You saw it was a fantastic plenary today, the plenary 1. Tomorrow will be the plenary 2, same place at 10:10. Tomorrow will be the second plenary and social neonatology paper. Today we are going to the poster area. Please take time and please do come and attend because there are 2 sections in the poster area, general poster and innovative posters. From here we are moving there.
Thank you. Of course, all.
Result is ready. Dr. Mahavir will now declare the result.
Of course, all have done very well for the sake of the competition. Dr. Amandeep Kaur is the second runner-up. Dr. Jaspreet Singh Raina is the first runner-up. And Dr. Sankalp Judeja is the first one. So gold medal belongs to Dr. Sankalp Judeja. Yeah, Dr. Jaspreet Singh Raina is here and Dr. Amandeep Kaur is here. I invite.
Please come on the stage.
Yeah. Yes, Amandeep Kaur is second runner and Dr. Jaspreet Singh Raina is first runner.
Pointer work ಆಗಲಿಲ್ಲ ಸರ್ ಯಾವುದೇ ಪಾಯಿಂಟರ್ ವರ್ಕ್ ಆಗಲಿಲ್ಲ
लिंक भेजना है हमको
Both the judges
just scroll that slides.
both of them for
slides
their valuable time and judging this very prestigious award of winner. So I'd like Dr. Ranjan to felicitate our judges.
Slide video ಇದೆ ಅಂತ play ಆಗಬೇಕು.
ಇಲ್ಲೇ ಚೆಕ್ ಮಾಡಿ ಇಲ್ಲಿ ಇಲ್ದ್ರೆ ಇದೆಯಾ ಈ ಸ್ಲೈಡ್ ಅಲ್ಲಿ ಆ ಸ್ಲೈಡ್ ಅಲ್ಲಿ ಸರ್
Which slides? No? Go down. Go down.
Just go down.
Back. Yeah.
This one is?
Yeah.
This one is not video.
This video. Limits video very important. Slide number 24. Slide show.
Dr.
Sankalp, can you hear us? Hello? Is Sankalp there?
Dr. Sankalp
Yeah,
is
virtually he must be there on join. Hello? So he's not there. So we'll send his certificate and medal. We can collect from the office later on. Yeah. Right. Thank you, Dr. Mahavir.
Congratulations to the team.
कितने भेजी थी कुछ खाना खाना ने साइड से रखी भेजी मत रखी
Starting our next panel
हेलो
discussion.
हेलो
Kindly be seated. Thank you.
Membership, you want to give that?
हेलो हेलो सर हेलो 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 डॉक्टर रमेश हेलो हेलो डॉक्टर रमेश हेलो हेलो गुड आफ्टरनून सर हेलो
Just put this one here. And then you have my mouse? You have a mouse? Mouse, no. There, this one.
हेलो हॉल है एडमिन हेलो
Make an.
हेलो
Just have problem with this video.
हेलो हॉल है एडमिन हेलो
This one video, sir.
हेलो
This video.
हेलो हॉल है एडमिन हेलो हेलो सर हेलो हेलो
What name, sir?
हेलो
PV.
हेलो
Switch presentation.
This is
हेलो हॉल है एडमिन हेलो
No air conditioning. Can just tell the organizers. Waiting on the snail. Snail. Waiting on the waiting a lady. Air conditioning. Are too hot, sir. Air conditioning. Probably they might stop now.
Behekar, right?
Yes, sir.
Dr. Satish.
Oh, hello, sir.
It's in your email as well.
Oh, yes,
हेलो
it's in
हॉल
the-
एडमिन हेलो
Easy to just copy paste. Satish says debate.
Okay, నా అదే ఇంకా చూడలేదు.
ఏంటి వీడియోస్ ఇందులో ప్లే అవ్వాలండి
అదే అప్పట్లా
ఇక్కడ ఈ ప్లేయర్ ఉంది చూడండి ఇది విమియోనా ఇంకొకటి చూసుకుంటున్నా అది
Can you
That is nice.
because this is player center. You please start your video and
ప్లీజ్
audio.
ఏమనండి అది వచ్చి ఇలా అక్కడ వస్తుంది కానీ అక్కడ రాదు
ఇక్కడ వస్తుందంటే అక్కడ వస్తుంది మరి ఇక్కడ దానిలో ప్రెజెంటేషన్ లో పెట్టాలి కంటిన్యూషన్
You please switch on your
లేకపోతే you have to stop the presentation and ask him to play the video.
చూడండి సార్ వస్తుంది ఓ సూపర్ సూపర్ మరి ప్రెజెంటేషన్ కంటిన్యూషన్ ఇప్పుడు ఇది అటు పెట్టావా ప్రెజెంటేషన్ ఉంది కదా పైన ప్రెజెంటేషన్ ఉంది చూడు
hello.
Dr.
Dr. Ashish sir. Hello, good afternoon, Dr. Ashish sir.
Early morning.
ఇది తీసేసి అది పెట్టాలా
You can hear me?
మూమెంట్ వచ్చింది కదా అప్పుడు ఇది దీనిలో రావట్లేదు కదా. This is not coming, no. So you need to keep into this.
Okay, already it's done, sir. Presentation is ready, sir.
Yeah, but దీనిలో రావట్లేదు కదా. ఇది
Subodh, I can see you. Can you see me?
వస్తుంది. దీనిలోనే వచ్చేస్తుంది కంటిన్యూషన్. అక్కడ పెట్టు.
Subodh, can you kindly?
So it is in the same presentation.
Yes.
Perfect.
Subodh, can you hear us?
This అవసరం లేదుగా.
వస్తుందా వీడియో?
ఇది పెట్టావా ఇది పెట్టు.
Yes. Yes, sir. I can hear you.
Yeah.
Can you hear?
It is LED, sir.
And I can see the video also.
LED స్క్రీన్ మీద రాదండి, వేస్ట్. LED మీద రాదు. రాదు, ఇన్ని మీద వస్తుంది. దాని మీద వస్తుంది. అక్కడ ఉంది సార్, మన స్లైడ్ చేంజ్ అక్కడ ఉంది.
అక్కడ వస్తుందా?
అక్కడ వస్తుంది, వచ్చలేదు. మన స్లైడ్ చేంజర్ అక్కడ ఉంది. You can use it.
కానీ
You have a slide.
నాది ఇచ్చేసేయండి.
Get the back.
We'll be seated there, sir.
Okay.
Am I audible, sir?
Yes.
Am I audible?
Yes, sir. Yes, yes.
Sir, am I audible?
Yes.
Okay,
Yes.
sir. Okay. Thank you. Thank you. I am audible?
Yes, yes.
Okay.
Yes, yes, sir. ఇదమ్మా.
This is
సతీష్ సేమ్ లైక్ ది అదర్ సతీష్ GHANT.
Hello. हाँ जी, जी सर.
Can you use this laptop? We can start. Our project ಮಾಡ್ತಾರೆ.
Our project.
So okay, no?
Just keep them to remove restricted parts. Restrict part use ಮಾಡಿದ್ದಾರೆ.
Good afternoon. Welcome on to the panel discussion on growth monitoring in NICU and follow-up. 2010, India had recorded neonatal mortality of 45.1 per thousand live births. Whereas now, in 2021, we are at 29 per thousand live births. This decline in neonatal mortality shows development of neonatal care in our country, and one of the major factors which has helped us save so many babies
If you can have a
is growth
laptop here,
monitoring in NICU and follow-up.
so I can play my own
So please welcome Dr. Ashish Mehta to share his precious knowledge.
Hello. Hello.
He is director in NICU Sterling Hospital.
Hello. Hello.
Sir, you're audible.
Am I audible? But then, can I request admin to unmute all the delegates except the panelists?
Please welcome our panelists, Dr. Shilpa, Dr. Sanjay, Dr. Daljit, and Dr. Sai Sunil Kishore.
लगा दे दोबारा फटाफट कर ले
Ashish sir, can you hear us?
शुरू हो गया कोई लगा
Yes, sir, we can see you.
Is it visible now? My screen?
Yes, sir. Your screen is.
Good afternoon, everyone. At the onset, I'd like to thank organizer for this opportunity. Unfortunately, because of unavoidable circumstances, I'm not there physically. And that's the reason to do this panel virtually. Would love to be with my team there, but unfortunately, I'm doing it virtually. Now, why do we need to monitor the growth? Because it is very important to diagnose growth failure. If baby is growing all right, in the NICU you are happy, everyone is happy. The concerned physician, the doctors, the staff, and the parents, everyone will be happy if the baby is growing well in all parameters, not only the weight, height, length, and the head. Baby is developing in front of you. And that's a great satisfaction. But there are instances where the baby is not growing because of one or other reason. And really it is important. Why? Because that growth failure in early postnatal life is risk factor for, is independent risk factor for poor neurodevelopment outcome, poor cognitive outcome, and poor scholastic performances. And to discuss this, I have got elite panel here. I'm happy to thank organizer to have this panelist for me. To lead the whole panel, we have Lieutenant General Dr. Daljit Singh. He's been awarded Vishisht Seva Medal. He is MBBS and MD from AFMC Pune. He had his DNB in Pediatrics, followed by DM in Neonatology from Chandigarh PGI. This is his basic qualification. Apart from that, if you can see, he has been serving this nation, and we must salute him for this particular services that's been offered, not only to us, to the whole country. Welcome, sir. I'm happy to say that you are the one who are guarding us all over the country. Apart from your excellent knowledge in this field, I'm thrilled to have you in this panel.
Thank you so much, sir. Thank you.
Next panelist is my dear friend, Science Panel Kishore. He is DM from PGI Chandigarh. He is a consultant neurologist at Vizag and also associate professor at one of the medical colleges. To his name, he has got 35 publications, and he's been interested in all sorts of neonatal management, ventilation, nutrition, sepsis, and all that. My colleague, Dr. Shilpa, she is a consultant neurologist from Dheeran Mangeshkar Hospital. She has done DNB pediatrics and DNB neonatology. Very young, budding neonatology. He's been faculty for most of the conferences and workshops, particularly interested in perinatal medicine and ventilation. Welcome, Dr. Shilpa. And another young budding neonatologist, Dr. Sang Mitra. She had IAP fellowship in neonatology followed by DM in neonatology. This is a consultant neonatologist at Vijayawada. And also she has been active in research and publications. She has got 8 publications to her name by this time, already 1 research paper and 7 case report. I'm so happy to have you all over here. Welcome. So let's start with case number 1. I'm going to put 2 scenarios. And these are the scenarios which are really relevant to our day-to-day practice. Talking about first case, this is about a 26-year-old primary gravida. She had severe PIH. She had gestational diabetes. Everything was going smoothly, and at 29 weeks, suddenly the obstetrician found that there are abnormal flows in the umbilical vessels. Unfortunately, baby had poor liquor, severe hydrogenous, baby had brain sparing effect, fetus had, and the report said that there is FGR, meaning fetal growth restriction, stage 2. And birth weight was 600, and it's not birth weight. This baby had the weight at this time of the scan was 618 grams. So looking at all this thing, everyone is afraid. Obstetrician, the parents were sent to me for antenatal consultation. And they are wondering with this unique word, FGR. So can you tell me, Dr. Shilpa, what does this mean? Because we are aware of SFD, we are aware of IUGR. What is this FGR meaning?
Yeah, so good afternoon, everyone. The term FGR, that is fetal growth restriction, IUGR, intrauterine growth restriction, and SGA, that is small for gestation age. These terms are commonly used and they are interchangeably used. However, these terms are not synonymous. FGR, that is fetal growth restriction, and intrauterine growth restriction are synonymous as they refer to the pathologies before delivery leading to the fetal growth restriction. And nowadays the term IUGR has been replaced by fetal growth restriction, and it has been commonly used, not the intrauterine growth restriction. So fetal growth restriction is defined as a rate of fetal growth that is less than normal for the expected growth potential for a specific infant based on the race and gender of the fetus. So to simplify this, fetal growth restriction or the IUGR, this diagnosis is made by the obstetrician based on the prenatal scans. Small for gestation is a physical diagnosis. This is generally would be defined as a baby who is born less than 10th percentile for the gestation age as well as the gender, and the birth weight below 10th percentile. So that will be small for gestation age. So in short, a baby who is small for gestation age may or may not be growth restricted. However, a baby who is growth restricted may or may not be small for gestation age. So I want to show the diagram. The previous slide, sir. Yeah. So just to simplify here, you can see the growth chart of the red growth chart and the growth curve and the green growth curve. So the red growth curve tells you that the baby is growing appropriately. However, the baby's weight is less than 10 centile at birth. So this is, the baby has achieved its growth potential, but at birth the baby's weight is less than 10 centile. So this is not growth restricted baby. However, it would be defined as small for gestation age. However, the other baby who had the weight at 26 weeks equal to the baby with the previous baby. However, at birth you can see that the growth has faltered. So this would typically be defined as fetal growth restricted baby.
So do you think that there is some considering overlapping of these two terms?
IUGR and FGR?
Yep.
There is overlap. However, when we use the term fetal growth restriction, I think we take into consideration the pathologies which happen prenatally leading to the growth restriction, as well as it talks more about the future impact, the neurodevelopmental impact. Hence, even it has been recommended the FGR term should be used than the IUGR.
So are you worried if I give the choice that let's take one out of this SG and IUGR, which will you pick?
Okay, among SG and IUGR, I would pick difficult. I don't want both. I don't want both, but yeah, means yeah, it depends upon the cause. So
Yeah, but
I don't know.
Yeah, Dr. Daljit, can you put some input here?
Yeah, I was just want to tell, when we say SGA, we could be also looking at normal babies.
Yes.
Yeah, absolutely. Yes.
Well, FGR, the moment you said FGR, there is growth restriction. So that's where you have to, that's the difference.
Yeah, but yeah, in terms of clinical achieving the clinically, basically neurologically intact survival, I think both have equal potential. However, the FGR babies are likely to have complications in an ICU. So given the choices, I would like to have SGA, not the
Yes,
FGR
that's
baby.
perfect answer. That the preference would be, of course, no one would like to neglect any baby. If it is IUGR, we try to see the panel discussion what we are going to do with the IUGR babies or FGR babies. But if I given the choice, then SJ is the better than the IUGR, simply because that baby has grown to their potential. You know, the SJ has grown to their potential. Potential was low. Maybe some small stature patient community, Japanese, Sri Lankans, they are small, and that's why they grow on the lower part of the chart. And this chart are not meaning for that community also, the where they are plotted. So if you project this baby on those charts, their community chart, excuse me, organizer, please unmute others. Hello. Hello. Requesting admin to unmute the others other than panelists. So the SJ babies are the one who are not grown to their potentials. That is there. They have gone to their potential was on the lower side. While the FGR, the one, they have not grown to their original potential. And that's why the preference would be SGA, and IUGR also can because of so many other reasons, isn't it?
Right.
So what's the problem with this particular FGR or the IUGR terminology?
Means the postnatal problems?
Yes, not basically the imbalance.
No, both of them, they show us that the baby, there is some placental issue or the baby side issue or the maternal issue, maternal medical condition that have affected the fetal growth. Both of them they refer to, and that has caused the growth restriction. However,
so basically this mismatch between the metabolic demand and the calories intake, and that's the reason there is a growth is affected, isn't it?
Yeah. Yeah.
So what would your plan? I mean, this baby is not delivered yet. Okay. If this baby come to the NICU, before that, will you like to recommend something to in your experience, what the obstetrician would advise when they see FGR?
Yeah, so in our center, yeah, so whenever such delivery is anticipated, the obstetrician do call us. They tell us what they have counseled the relatives, and they need antenatal counseling. I think it's an important thing because here the parents need to know what the baby is going to go through. Also, they need to know what are the likely NICU problems they are going to face, as well as the stay duration of, as well as the cost and the future outcome also. So we typically talk about all these factors to the parents, including mother, as well as all the grandparents and etc., because everyone needs to be on the same page, and it shouldn't be a surprise to them. We definitely, when we counsel, we talk to them about our NICU data about the outcome so that they are confident. If required, we show them the delivery room as well as the NICU, also the setup what we have.
Yeah, but I'm talking about antenatal management, and for that matter, they give low dose aspirin and proteins, amino. And there is a fetal management of growth retardation. Am I right?
Right, sir. So apart from what you mentioned, I think for the good outcome, we would recommend antenatal steroids and antenatal magnesium sulfate also in this case. And yeah, and in delivery room, the typical delivery room management of having a resuscitation team, delayed cord clamping if it is possible, and delivery room CPAP and use of blender. So yeah, these babies need to be aggressively managed. It is a multidisciplinary management, including delivery room and immediate NICU stabilization. Now here, these babies are going to have increasing caloric requirement, as well as they need to be maintained certain kind of nutrition. If it is not provided, they are at risk of extrauterine growth restriction. And here we have to balance both this, and and to balance this, we have to monitor growth regularly in NICU.
Yeah, so ultimately it comes to the monitoring growth of this particular lot. A full-term baby with PPHN or meconium, yes, growth will not generally be a problem. Otherwise, a preterm baby, 28-30 weeker, if you manage well, doesn't add anything extra to the baby in form of sepsis, they also grow well. But these are of course, their growth monitoring is equally important. But these are the one, particularly the growth retarded babies or compromised baby or something with the congenital malformation or syndromic babies. There, the growth is always a problem. So, Dr. Sunil, first of all, how to monitor the growth? How do you do that in your day-to-day practice? Hello?
Am I audible?
Yes.
Very good afternoon, and thank you very much for making me part of this conference. So growth charts are an integral part of growth monitoring. So without growth charts, you can't have an objective assessment of what is happening to the baby. So when it comes to the topic of growth charts, we have actually three different categories of growth charts. So one of them is called intrauterine, and second one is postnatal, and third one is combined. So what we call it is fetal and infant growth charts. So next. So
which growth chart do you use?
Yeah, when it comes to growth charts, actually like in growth charts, we have different categories like Babson and Brenda as well as